So I've informed him that you will be presenting today. So let's see if he comes.
Very nice. Yes, say hello to Davis for me.
Yes.
So is my voice loud enough?
Yeah, you can be a little more louder if it is possible.
I will try.
Yeah.
How's that?
Dr. Nural, we are good to go.
Yes, Dr. Sunal, we are live on website as well as ipdcon.com, so you
Oh,
can continue.
thank you so much. Thank you, Dr. Nural. Welcome to the International Pink Dental Congress 2025, a celebration of women's excellence in dentistry. Today, we honor the resilience, leadership, and achievement of women shaping the future of oral healthcare. Excellence knows no gender. True progress comes from mutual respect, shared responsibility, and equal opportunities. Women are not just supporters, they are leaders, innovators, and change makers. We must continue fostering an environment that nurtures talent and challenges unbiasedly. We here at International Pink Dental Congress have a sole motto in our heart to give opportunity to each and every woman dentist and celebrate each and every woman dentist who have not only created a niche for themselves but also are inspiring others around them. Let us break a community wherein we, regardless of any gender, we are valued, respected, and we honor each other. Yesterday was our inaugural ceremony, wherein we had three beautiful speakers who enlightened us on various aspects of dentistry. And we had paper presentations from our participants who were kind enough to wait and share their knowledge with us. We had our patron, Dr. Shail Jacki, ma'am, inaugurating the function, and we had many guest speakers who were participant to this inaugural ceremony. Today we have a beautiful lineup of around 17 awesome dental divas who are going to be enlightening you. Our day today is going to be a very hectic and a long day, and I urge you all to be with us and support all our speakers. On that note, I would like to welcome you all to International Pink Dental Congress Season 3 2025 in association with MedSkills and National Health Academy. With that, I would like to welcome our first speaker for the day, Dr. Elizabeth Roberts. Dr. Roberts, can you just come on the screen? Yeah.
Yes.
Yeah, Dr. Roberts, as we all know, she is when I saw her profile, in fact, if to sum up her profile in 100 words is a task. She is DDS, MDS. She has completed FACD, an associate professor of diagnostic sciences at Rutgers School of Dental Medicines. Ma'am, I know this is a very short and brief introduction of you. You as a human are much, much more than this. And I would urge you to start your presentation. But before that, I would like to know a little bit about you. And if you can just enlighten us, what would be that thing that you would like to tell your younger self? Like, when you were 20 years old or 30 years old, what is that one thing you would like to tell her when you're standing at this phase?
That's a very good question. Thank you so much, Sanal, for that lovely introduction. And now for the stumping question. Um, I think I would tell myself that that there really is, there are a lot of opportunities that you can't even imagine yet. And so don't limit yourself to today's thinking. There's so much more in your future, and it's going to be very difficult for you to even dream of it today.
Lovely, ma'am. Lovely. With that, can you just start sharing your screen, ma'am? Welcome to International Pink Dental Congress.
Sure. Thank you very much. How's this? Can everyone see?
No, ma'am. Still not yet. Just share the
Oh,
screen and then
let me go back. And that
Dr.
was an effort.
Nurul, is she the co-host? Dr. Nurul, have we made her the co-host? Yes, your screen is,
Screen
you started
sharing.
sharing. Yeah, just 2 seconds. Yes, ma'am. Can you go on the presenters mode? Yes, slideshow mode.
There we are.
Yes, please continue,
How's
ma'am.
that? Thank you very much. And thank you for that kind introduction and for the chance to join you on International Women's Day. This year's theme could not be more important. Let's accelerate action for women's equality, for gender equality. It's not easy to accelerate action for the world, but we can certainly accelerate action for ourselves by developing our full potential. And let's let the world see women in all the different roles we want to play in our own lives and for the world. And maybe one by one, we can create that tipping point where gender equality becomes a reality. What I'd like you to do is to think about where your potential could take you and always feel comfortable to ask yourself, why not a woman? Why not me? What I'd like to share with you today is my own non-traditional career path. I've taken dentistry down a very different journey, one that I had never anticipated when I was still in dental school. And I've developed some foundational capabilities that I want to share with you because I think they were important to going forward. I'd also like to talk with you a bit about how important it is to really know who you are. Take the time for some introspection, be able to project yourself to others through the stories of your experiences as well as the stories that you've learned from others. I'd like to share with you how I use these concepts with my students and how you can use them too. So let me start. I'm from Wisconsin, Milwaukee, Wisconsin, and I just gave you a map of the US so you could see where I am originally from. I graduated from Marquette Dental School in 1981, and my first position out of dental school was as a clinician in private practice. And then I got married the October after my graduation, and my husband was an officer in the Navy. And so after our wedding, the Navy moved us to his next station, which was in Virginia. Now, once I was in Virginia, I was still a clinician, but this time I was in public health. And at first, I was a clinician in a public health clinic 3 days a week. And then a couple of years later, a neighboring town asked me for my other 2 days to treat patients in their clinic and to be their clinic manager. Because their full-time dentist had been on extended sick leave, they didn't know when or even if he was going to come back. But I got a taste of being a clinic manager and I absolutely loved it. I didn't realize I had a business aptitude, but I discovered it with that position. At the same time, my husband was finishing his tour in the Navy and he was looking for a civilian position and he planned to get an MBA. And I thought, me too. I want to be a manager and I'm going to get an MBA too. And so my husband got a position in New Jersey and we moved to the New York, New Jersey area. And we both got accepted into Rutgers MBA program and we went to night school while also holding down full-time jobs. At the time, my very first break was with an insurance company reviewing dental claims. And I got that position because when I was back in Virginia and decided I wanted to be in business, I started writing letters to companies that do business with dentists. And I thought that would be a good opportunity to see if maybe there's a way of breaking my way into the business world. So I got hired by this insurance company. After reviewing claims for a while, I rose to an executive position. I was first in dental relations, and then I became director of their dental health maintenance organization for the Northeast region of the United States. And then later, I got a position, an executive position with a competing insurance company. By this time, both my husband and I had our MBAs, and we each got hired by a major consulting firm. My husband got hired by Price Waterhouse in New York, and I got hired by Deloitte Consulting. And I got hired to work in their healthcare and financial services practices because I was knowledgeable in healthcare economics, having been in insurance, of course. And while I was in Deloitte, I was on teams where we helped large organizations solve their real thorny, complex business problems. And I really got to use and build my MBA muscle in that position. A few years later, I got a call from an executive recruiter who told me about a team that Pfizer was building. They were looking for strong business managers who understood healthcare to manage their clinical operations for their clinical studies for their major blockbuster drugs like Zithromax, Lipitor, Aricept, Viagra. And I took that position. It was a very exciting time. I really loved it. Short time later, I transferred to Pfizer Consumer Healthcare. That division had Listerine as one of their major products. And seemed like a terrific match for me for a dentist who already knew Pfizer and had this business background. I got the job. I was now in business development at Pfizer Consumer Healthcare, and I was looking for licensing and acquisition opportunities with inventors of new oral care technologies for the Pfizer oral care business. And then just about 2 years into that, Mother Pfizer, the Pfizer pharmaceutical, decided they wanted to get out of the consumer business, and they sold Pfizer Consumer Healthcare to Johnson and Johnson. And at Johnson and Johnson, I had a new job. I was now in research and development, and I was director of scientific and professional affairs for North America for the oral care products. And in this job, I was building relationships with major dental associations like the American Dental Association, the American Academy of Perio, the Canadian Dental Association. And I was working with advisory boards, scientific advisory boards who are made up of major scientists from different dental schools and universities. And then I retired, but not really. My husband also retired from his consulting positions, and we decided to establish our own firm. What a name, Roberts and Roberts Consulting. And a short time after that, I heard about another opportunity, and this one was at Rutgers School of Dental Medicine. They had a program where they were trying to see how they could teach dentists to become teachers. And I was one of 10 dentists who got accepted to that program that year. And that brought me to the opportunity that I now have at the dental school where I'm assistant professor of diagnostic sciences. And I'm still doing consulting at Roberts and Roberts. Now, there have been many things that I've done along the way. Let's see, I think I may have skipped a slide. Yes, there are many things I've done along the way because one of them was that I never stopped learning. I continued to build my credentials. I already told you about my MBA at Rutgers. I also got a pharmaceutical management certificate after taking courses there. At the University of Chicago, I got a strategic marketing management certificate. I told you about the faculty development certificate at the dental school. And when I was still in insurance, I took courses and sat for exams to earn my insurance business certificate. So I really never stopped learning. I continued to stay in school and build my skills and build my credentials. And I've got to tell you, I'm just going to take a stop now to say I didn't get all the jobs, all the money, or all the titles that I wanted. None of us do. And I didn't even like all the jobs or all the people once I got there. But I still had to fight being a woman and not being an industry specialist to win the new position and succeed. I always used my dental degree, sometimes explicitly and sometimes peripherally. But having that dental degree was always important to my employers. And in fact, except for when I was actually a practicing clinical dentist, I never really knew exactly how to do the next job I'd had before I took it. Now, location definitely made a difference. I know you can say, well, you're in New York, New Jersey. Of course, there's lots of opportunities there. And you're right. A lot of things here. But as I look back, if I had never left Wisconsin, my career would have been very different. There's no question. So my ability and interest in moving for an opportunity also played a role. And New York and New Jersey certainly offered opportunities. But with the skills I developed along the way, I was always better equipped to succeed and advance in a lot of different and interesting positions, and I enjoyed all of them. Um, but I'm convinced that why I was selected was about way more than my resume, because all of us are way more than all the different bullets on our resumes of saying where we've been, what we've done, what degrees we have. I believe I was getting selected because of how I came across in interviews. I was authentic. I really understood myself, and I still do. I do that all the time, and I've been doing that from young on. I could draw from my various experiences in education. I could work well as a leader and a team leader, and I could express those qualities and tell the stories of my experiences in very simple, succinct messages. And I could tell stories about other things that I knew about that were relevant to the conversation I was having with those I was being interviewed by. So, what I'm about to tell you now is not something that I created. It's not in any one book. It's kind of a meld of all kinds of experiences and of a lot of things I've read. But it's something that works for me, and I've shared it with my students, and today I'd like to share it with you. As a teacher, I get asked, oh, by maybe 2, 3, 4 students a year to ask to write a letter of reference for them. And they always come to see me armed with their resumes, their transcripts sometimes, their essay on their personal statement of why they chose to become a dentist and what their life is about. And I read that and I think, you know what? They are more than these papers. And I know I have experiences of them in clinic and in school. But I always ask to have a conversation with them, and I sit with them for about an hour, and I ask them all of these questions to try to understand what makes them tick. I ask them, what do they really love? Where have they had to really struggle and succeed? Tell me about, your best moment, your proudest moments. Tell me about experiences you've had with your patients who may have surprised you or where you may have turned things around for them. Tell me about more than what's on your resume. And then I take all that information and I sit down with it in my computer and I start writing my letter. And I write many, many drafts because I'm trying to get into why would this individual be such a strong contributor at the residency, for example, that they are aiming to get for themselves. And what I found is that, and then I always give them their letter. I always do. They always read their letter before I send it out because I want to make sure I've got it right. Um, I also want to tell you that the stories that I tell in my letter to support the positions I feel are, their strengths, they are not embellished stories. They are the facts. They really happen. And so once they read their letters and they read their stories and they recognize themselves, what I've learned is that their letter really helps them see what they are truly about. what I've been doing all along, which is always this introspection and self-examination and trying to figure out what I can do better and where I want to go, that's not always coming through in when they're thinking about themselves and trying to project themselves for an interview. So it really does become a wow moment for so many of them. And they see themselves in a new way through my eyes. And now they are empowered to project themselves for the strengths they demonstrate and in the actions they consistently take. So now I want to get back to those foundational capabilities that I think are so important. Um, Mastering your foundational expertise. It's important to never let that go. And for me, my foundational expertise, it started with dentistry and went on to be business, consulting, and now teaching. But I continue to work towards mastery of those areas. For all of us, it's important to build our communication skills, how to be conversational, to write, to give a presentation, build your listening skills, ask good questions. We do that all the time with our patients, right? And then build networking skills. You need to not only be able to share with other people where you want to go and what they're wanting to do, but also they can be your eyes and ears when they are aware of an opportunity that could fit you. And then there's building your credentials, a commitment to lifelong learning. And it's not just collecting the degrees. It's important to be able to integrate your new knowledge with the knowledge and experiences you've gained over time. And then gain new knowledge about opportunities that draw you. If there's something interesting, study it, learn about it. You might find out, let's say if there's a project that's going to be taking off, you may find that as you learn more and more about it, that you'd like to be a part of it and gain new knowledge in all areas, areas that interest you, your hobbies. Be a Renaissance woman. Really embrace your curiosity and learn more. Absolutely never, ever stop reading. I can't say that strongly enough. And again, know yourself really well. It is so critical to really take a time out and understand what drives you. Where do you succeed? What have you been successful in? And it's especially important to do that for every once in a while, you'll get a dark moment where something didn't work and you doubt yourself. Go back to say, well, wait, maybe not now. And maybe not with this occasion. It may not have been my best day, but I know I have it in me to succeed going forward. And you can draw from that strength. And storytelling is an excellent skill to develop because you can use your stories to describe your qualities or whatever point you want to make. I can tell you that I used storytelling with that very first opportunity with the insurance company. That was really a networking opportunity I had. Were not about to offer me a job. There was no job on the table, but I was talking to them about, where would you see someone like me with my skills in business? Can you give me some ideas? And the vice president I was talking to said, well, actually, we're thinking about establishing a pilot. We think that we can review dental claims better ourselves than outsourcing it to an outside firm. And so we're going to be hiring some people for this pilot, but we're really looking for people with experience. And I said, oh, that's really interesting. I wonder if you would give any thought to looking at it this way. You want it to be a pilot, and you're telling me that you want to see if doing it your way is better for you. And if you think your own people can do a better job than what you're getting. I said it would seem to me that what you might want to do is hire inexperienced people who only learn it your way. And I told them the story about a shipbuilding company that was looking for welders to weld this very new innovative material. And they had decided that they were not going to get experienced welders because experienced welders could stray from the protocol and make an error, and that could be devastating for the ships. So instead, the only welders they hired were brand new, inexperienced people who had never held uh, any kind of equipment to weld. And what really surprised me was a short time later, I was the first dentist that they hired for that position for their pilot. And then they hired a second dentist shortly after, and that second dentist also had no experience. So stories, know not only your stories, but be able to tell other stories that can support the points you want to make. And it's important to be able to tell 30-second versions and 2-minute versions. Think about using a model to be able to do that. And then I do a lot of thinking in real time using models. I do that as a consultant. That's where I really established that skill and I got better at it. But models will reduce a very complex concept into very simple chunks. And they can help you learn, plan, decide, forecast very quickly so that in real time, while you're talking to someone, you can start getting to the real core of what they're trying to tell you. And think about the simple models that you are already using, but now apply them in new ways. So, for example, benefits and risks. You do that now. We all do that now when we are offering treatment plan options to our patients. It's a matter of comparing, let's say, for example, the past versus today. What's different? What has changed? What can we look forward to in our future? So I hope that with these thoughts that I'm sharing with you, the foundational capabilities that have helped me, and the ability to look at yourself as someone way beyond your resume, way beyond the schools you went to and the degrees you hold, be able to tell your story in stories and to be well read so that you can pull from the stories and examples of other areas to make your points. And I hope that with that kind of support, you can look at an opportunity that interests you or catches your eye and say, why not me? And what I'd like to share with you now, and I've left this with Sonal, she can make it available to you. I have 2 pages, very simple. I wrote both of them. This is about helping you learn how to explore yourself and really get to know who you are, and then how to convey experiences and stories. And the second page for you is a summary of those foundational capabilities that helped me. So I hope that you can take at least some of these thoughts and maybe they'll be useful to you. You do have to customize it for yourself if you want to play with it. And I wish you all the very, very best as you try to fulfill your own potential and get those roles that you want to have. Thank you very much.
Thank you, ma'am. Thank you so much. That was really an inspiring story. And what you said, you need to be a storyteller because once you become a storyteller, you can bring the thoughts together. And that's what is important. Yeah, thank you so much, ma'am. And I have taken the screenshot of your slides, what you said you wanted to share it with the audience. So if possible, I'll drop it in the chat box, or if anybody wants to have them, they can connect with me. All of them have my number. So thank you, Dr. Roberts, and it was a pleasure and honor to have you on board. Thank you so much, ma'am. And I am truly inspired by your story. I'm going to read more about what you are doing, and it's an inspiration in a way that anybody can do anything at any time. I mean, age is just a number, and it's just a mindset. Thank you so much, ma'am. And it was lovely to have the start of the day in such a positive way. Thank you so much. I know I understand it's late night at your end, and thank you for accommodating us, our conference, with your time schedule. Thank you so much.
It's
Thank
my
you for being
absolute
a part of
pleasure.
our International Pain Dental Congress. Thank you,
Thank you
ma'am.
so much. My absolute pleasure.
Ma'am, smile for the camera, please. Thank you. Thank you so much, ma'am. Okay, with that, we have our next speaker, Dr. Meenu Bhasin. Are you there, Dr. Meenu? Can you switch on your camera and mic, please?
Yes, Dr. Sonu.
Yeah, hi, looking
Morning
lovely.
and happy
Yeah,
Women's
smile for the
Day.
camera before you start. Just smile for the camera. Look up. Yeah. Thank you, dear. Okay. Dr. Meenu Bhasin, she needs no introduction actually, and I'll be very concise. This is just a two, 3 liner introduction of hers, but everybody knows of you and about you. She's an MDS in periodontics, and she's completed a diploma in oral implantology. And she's also the vice president of Indian Society of Periodontology, and is a well-known implantologist and periodontist. And today we have the honor of having Dr. Meenu discussing a very important topic with us. Happy Women's Day, Dr. Meenu.
Happy Women's Day.
Yeah, your screen is visible. The stage is all set for you.
Thank you. So first of all, happy Women's Day to all everyone, and thank you, Dr. Sonal, actually for making me part of this webinar series with all these elite women. And I believe that behind every successful woman is the woman herself. Okay? So I think we should all applaud for ourselves first. So my presentation is on science-driven periodontal therapy. Okay. In women, addressing women-specific periodontal health concerns. Am I audible well? I'm going to discuss about the influence of hormones on periodontal health in women, periodontal therapy during different life stages, and preventive measures as well as maintenance. Introduction to oral health in women. As women, we all go through different hormonal fluctuations throughout our life. Okay? And these hormones affect us from puberty onwards till menopause. And they have implications not just on our overall health, but also have an implication on our periodontal health. For example, the most important hormones like estrogen and progesterone, they can cause changes, can affect the composition of subgingival bacterial plaques as well as a change in the immune response. So what they do is these hormones uh, cause a dysbiosis, an increase or decrease in these hormones can cause a dysbiosis as well as have an effect on the immune response of the gingival tissues. So do you know this that your vaginal tissues as well as the oral tissues are almost very similar and hormones do not differentiate. Why? Because both the vaginal tissues and oral tissues have receptors for estrogen hormone. Okay, so when they have a receptor for these hormones, the hormones is not going to differentiate, it's going to attach there also. And what does these hormones do? An increase in the estrogen has an impact on the gum spike because it causes first of all dysbiosis in the oral microflora. It causes increase in the production of certain cytokines. During pregnancy, high estrogen level is known to cause pregnancy gingivitis. It causes estrogen is important for bone health, okay, and also estrogen influences the salivary blood flow. So fluctuations in the estrogen can regulate, can cause sensitivity and bleeding, and also a risk for gum diseases. Coming to progesterone, progesterone also has a role. High progesterone level increases the blood flow to the gums and which can cause gingival swelling and bleeding. Also, progesterone levels rise during pregnancy, which makes it more susceptible to inflammation and infection. So what are the clinical implications of these hormonal influences? This means that as a periodontist or as a dentist, we need to understand these hormonal influences that a female patient may have, or patient who's visit us, okay? And our treatment should be tailored, or we should have a tailored diagnostic as well as therapeutic approaches based on that woman's hormonal status at that time. So understanding the hormonal influences is crucial for decision making for us as a dentist. And also the clinician should consider a hormonal status when you are evaluating a periodontal health of the patient, when you're making a treatment plan, so that you can come to an optimal outcomes. Okay? There is no one recipe for all. Every patient, female patient, may have a different hormonal profile, and you need to understand that. Okay, so your periodontal treatment has to be adjusted based on the phase of the menstrual cycle or the hormonal conditions of the patient so that you can mitigate potential exacerbations of the inflammation or tooth sensitivity. As a clinician, we play a very important role in recognizing and addressing these hormonal influences to provide effective periodontal care tailored to individual needs of the woman at different stages of life. At this time, whether it is medicine or dentistry, we all talk about precision dentistry, which means that your treatment has to be tailored according to the needs of the patient. So let's start with puberty. So what is puberty? Usually starts around 11 to 14 years of age. And during puberty, there is an increase in the hormonal effects. And that hormonal effects affects the overall body, also affects the oral health. And during this stage, you would see that, female patients, they will have, because of this heightened hormonal response, will have a gum sensitivity. They will have increased bleeding on probing. You will see some gum, you know, gingival enlargement and increase and an exacerbation of response to the plaque. We all know that plaque is a primary etiological factor for periodontal disease. A patient who's not maintaining so well, because of the hormones presence of those hormones at that time, or exaggerated hormones at that time, the response to this small amount of plaque may also be exaggerated. And here's the studies which have shown that these sex hormones, okay, can definitely cause and change in the microflora because of the presence of especially increase in the capnocytophagia series, etc. species during these changes in the hormone. So what you see during puberty is you see a characteristic feature is you see puberty gingivitis, which is characterized clinically by the onset of exuberant inflammation of the marginal gingiva and may extend to the attached gingiva. And mostly what you see, it also involves the interdental gingiva. You see puberty gingivitis, puberty gingival enlargement. How do you manage such patients? Okay, first is importance of periodontal education. As a dentist, it is our duty to educate not just the patient, but also the caregivers, the importance of maintaining periodontal health. Okay, and so as I said, prevention is better than cure. So please ask, inform your patients about how to maintain good oral health, and you may have to have your periodontal maintenance appointment may need to be more frequent during this phase of life, especially in cases who are unstable and who are not responding well to therapy. So how do you manage? First, as we know, the primary etiological factor is always plaque and calculus. So first, in mild cases, in any case, you would start with phase 1 therapy, that is, you would do scaling and root planing. However, if it's a severe case, you may need to go for an antimicrobial mouthwashes. You can do a microbial culturing and maybe start with an antibiotic therapy after you've done the scaling and root planing. Patients who are not responding to the therapy, okay, you have to should get the hormonal profile done. And sometimes you may have to refer to a gynecologist, okay, and work along with them. Usually in young such patients during puberty, they are very conscious about their looks. So what they start doing is they start practices like bulimia, etc., which can cause enamel erosions and cause gland enlargement. So be aware of these things. Look at these features also, and you may need to counsel such patients. Coming to menstrual cycle, how, during menstrual cycle, our sex hormones changes and how they have an effect on inflammation and as well as collagen formation, leading to influencing our gum health. Okay. As a woman, our menstrual cycle goes through phases of active menses to follicular phase, ovulation, and luteal phase. And hormones that play a role during these phases are your follicular stimulating hormones, your luteinizing hormones. These actually, you know, uh, show if has an effect on estrogen and have an effect on progesterone level. So an increase in the estrogen level during the peak reaches the ovulation phase can, as I said, estrogen has an effect on microbial flora, okay, and there's always an increase in Prevotella intermedia microorganism and Porphyromonas individualis during that phase, and this also has an influence on release of inflammatory cytokines. Okay. So how do you, and after that phase has gone during the luteal phase, the progesterone and all starts increasing. So how do you manage? Management of periodontal health in women influenced by menstrual cycle hormone requires a proactive approach. First is awareness of timely intervention. You have to be being aware, make the patient aware about changes that can happen during the menstrual cycle. Once the patient is aware, they would definitely pay more attention to the oral health and may seek your your services when required. Okay. Then periodontal monitoring, increased gingival bleeding and tenderness during such phase may necessitate frequent periodontal maintenance. Typically, for such patients, you may ask them to come every 3 to 4 months and schedule manage cyclic. This will help in manage the cyclic inflammation effectively. Oral hygiene emphasis, very important. You need to educate your patient about the cyclic nature of the hormonal effects on the gingival health, and make them understand the importance of oral health, how they should, include your flossing and mouth washing, etc., in their routine oral health. Timing of the procedure in case a surgical intervention has to be done. If the patient has developed some kind of enlargement or you need to do a surgical intervention or any other surgical intervention, then the surgical intervention should be scheduled the post menstruation to avoid any complications which are related to increased menstrual flow, and also because of the heightened sensitivity during the menstruation period. Sometimes you need to collaborate with healthcare providers, and given the potential impact of menstrual cycle related changes to the oral health, collaboration with your gynecologist or healthcare providers may be necessary, especially in case of patients who have severe cyclic symptoms or systemic complications like anemia because of a heavy menstrual flow. And a lot of time we as a dentist have seen that we are the first one to diagnose such conditions, patients who have developed anemia because of heavy menstrual flow. Okay? Because they come with gum problems, and when you start taking their history and when you ask them to go for the blood test, you are usually the first one to diagnose. Okay, just like you are as a dentist, we are the first one to diagnose sometimes a patient who has diabetes. Okay. Coming to symptoms management, for women experiencing premenstrual syndrome symptoms, okay, they are usually will have a very heightened gingival sensitivity. Okay. Most of us, will have gone through a PMS symptoms. I go through every time, and it's not just of pain and mood swings. We have heightened gingival sensitivity. So and at that time you may have to start a supportive care for the patients, and sometimes you may have to give, but in medical under medical supervision, you may have to give an antidepressant for the patient, and for pain you can give an NSAIDs to the patient. So understand that periodontal care should be personalized based on the individual's hormonal profile and menstrual cycle phase, ensuring that a proactive maintenance and a timely intervention is done when it is needed. Coming to pregnancy and perinatal health, this is one of a beautiful phase of a woman life. So, what hormonal changes happens during pregnancy? Pregnancy leads to hormonal fluctuations, which can significantly impact the perinatal health and increase the risk for gum diseases. Pregnant women commonly experience pregnancy gingivitis, which affects about 30 to 100% of all the pregnancy. And pregnancy can lead to a localized gingival enlargement, which we also call as pyogenic granuloma or pregnancy tumor. There is a case of a pyogenic granuloma, and the other side you see a severe gingival enlargement because of pregnancy. So why does this happen? Because during pregnancy, there is an alteration of the microflora, and there is an increase in the level of anaerobic bacteria such as bacteroid species and Prevotella intermedia. And this is happening because of an altered hormonal environment, because of an increase in estrogen and progesterone, which actually these hormones love these microorganisms. So they selectively accumulate Prevotella intermedia, potentially acting for this microorganism. These hormones are acting as a growth factor. So what happens during pregnancy? During pregnancy, because of this dysbiosis, there is a change in the microbiota, and also there is an increase in the, certain inflammatory cytokines. There is all this leads to an heightened inflammatory response in pregnant female, and they develop gingivitis, pregnancy gingivitis, as well as sometimes pregnancy epulis. But it's like a two-way relationship. Now, this, if the periodontal disease is not controlled in a pregnant female, if they're not maintaining and they have severe periodontal disease and they do not come for treatment, it is seen that this periodontal disease can also lead to adverse pregnancy outcomes like premature delivery as well as a low birth weight of the infant. So your periodontal disease has both systemic and fetal implications, leading to adverse pregnancy outcomes as well as a low birth weight and premature birth and preeclampsia in pregnant female. So it is really important to educate the patient, a pregnant female, about periodontal health, about oral health, and it's better that we start this before they even conceive, and educate them, and to start any intervention, any treatment as early as possible. Okay, this is the same thing, trying to show you the link between periodontal disease and adverse pregnancy outcomes. So how do you manage? Clinical management, okay, requires in a pregnant female a multidisciplinary approach. You have to involve the obstetric care provider, and also make the patient, even sometimes you have to make the gynecologist understand that how important it is for the patient to maintain oral health. Show them the data that the studies have shown that there is a relationship between your poor periodontal status and adverse pregnancy outcomes. Okay? So periodontal maintenance becomes crucial. With you have to have a tailored strategies to mitigate gingival inflammation and minimize oral infection. Okay? So what you do as a healthcare provider, you have to do, meticulous oral hygiene practices. Whenever necessary, you may give an antimicrobial therapy, only those which are safe during pregnancy. What are the timings when you can do the treatment? Okay. During the first trimester, you can avoid, okay, but the second trimester is completely safe to do any periodontal therapy, but scaling can be done at any trimester. If the patient is not maintaining, cleaning is something that can be done at any trimester. Okay, this is one of my case. This patient, came to the department with this swelling, and this is a preoperative view. Now, because this patient was in her third trimester, but this was making it very difficult for her to eat, and we wanted to do something where we can avoid giving her any antibiotics and be as minimally invasive as possible. So we chose to do laser therapy and remove this lesion using the growth using diode laser. And this is a histological picture which confirmed that the patient was having a pyogenic granuloma. Okay. Now your EFP and BSP, that is British Society of Periodontology and European Federation of Periodontology, have given some guidelines on recommendations for women, pregnant women. So their guidelines, and you can go to the page and see their guidelines. And actually, I would recommend that all of us should, take a printout of it and put it in a clinic so that it helps our patients. So according to the guidelines, the recommendations for women, first is knowledge of the symptoms. Women during pregnancy should have the knowledge about the obvious signs of gum diseases. So as a dentist, we should educate them about what kind of gum problems that they could see during pregnancy, and so that they can do a self-evaluation. Then gingival changes, swollen and bleeding gums are frequent during pregnancy, but they are not normal. If these changes appear, they should be appropriately diagnosed and treated by the dentist. Prevention, even in the absence of any signs of disease, pregnant women should seek an oral health consultation with a dentist, dental therapist, or dental hygienist. And during this visit, they should ask the oral health professional about the appropriate plaque removal measures and tools that they should use during their pregnancy. Periodontal disease. If the periodontal disease is diagnosed, periodontal women should know about both gingivitis and periodontitis can be treated safely during pregnancy, and they should be informed that the risk of no treatment are significantly higher than the minimal trauma that might occur during therapy. Periodontal treatment has shown to be effective in improving periodontal status of pregnant women and poses no risk to general health. Pregnant women should also be aware that the periodontal treatment should be avoided in the first trimester and should be performed preferably during a second trimester. X-rays and anesthesia. Pregnant women should be aware that X-rays can be undertaken and local anesthesia can be delivered without additional risk either to the mother or the fetus. As I said, scaling and root planing is is really safe during any trimester. In case a patient, you will not, if the patient has so much of gingival inflammation, you're not going to wait for the second trimester to arrive. Okay, all emergency treatment can be done in any trimester, but the preferable time period is always the second trimester. Okay, here's a list of pharmacological agents such as anesthetics, analgesics, and antibiotics and antimicrobials that can be used by dental professionals, followed by special consideration about their use. You can use aspirin, ibuprofen, etc., but avoid them in the first and the third trimesters. Amoxicillin may be used during pregnancy. Drug antibiotics to be avoided completely is tetracycline, never used during pregnancy. Avoid ciprofloxacin, avoid uh, levofloxacin during pregnancy. Amoxicillin, metronidazole may be given during pregnancy, but you should always ask take a consent of the gynecologist. Antimicrobials like chlorhexidine, mouth rinses, xylitol may be used during pregnancy, but however, there are still some studies related to chlorhexidine effects, negative effects during pregnancy. So be careful in using that. In summary, pregnancy induces significant hormonal changes that profoundly affect the perinatal health. So understanding these interactions is essential for implementing effective perinatal care strategies that not only promote the maternal oral health, but also contribute to favorable pregnancy outcomes. And a collaborative efforts between the dental and the medical professionals are pivotal in managing perinatal health throughout pregnancy, thereby supporting both maternal as well as fetal well-being. The last phase of a female cycle is menopause. And why I put this picture is that this is not like an end of everything. We are so concerned about or at this stage of our life that when menopause comes, everything is going to end. It is a beginning of something. This is a phase of our life, and this is also beginning of something beautiful. Okay? So what are the hormonal changes that happens during menopause that can affect the oral health? So during menopause, there is thinning of the oral mucosa because our estrogen level starts reducing menopause. And so the thinning of oral mucosa makes it susceptible to injury and discomfort. And the patient usually complains of burning mouth syndrome and increased sensitivity. The gingival changes because of a decrease in the estrogen level that you see is inflammatory changes in the gingiva, such as increased gingival recession or atrophy or hypertrophy. These changes already, if your patient has some perinatal conditions, can get exacerbated because of the reduced estrogen levels. Patient usually complains of dry mouth because of a decreased estrogen level has also have an effect on reduced salivary flow and altered taste sensation. Menopausal hormone shifts may cause changes in the taste perception, affecting a woman's enjoyment of food and nutritional intake. Patients also start developing something like, a knee squamative conditions during that phase of life. And alveolar bone loss and osteoporosis. Estrogen plays a crucial role in maintaining bone density, including the jaw bones. So, menopausal estrogen deficiency contributes to osteopenia and osteoporosis conditions. And in the oral cavity, this can lead to alveolar bone loss and subsequent tooth loss as well. These patients would usually, it's not so common in India, but in foreign countries, they are usually taking drugs. And if you're planning to do any kind of an implant placement in such, it's important to understand the drug history that they are taking. Important to get the test for osteoporosis done before you start your implant therapy in such patients. Now, how do you manage menopause related perinatal issues? Okay. Hormonal impact changes. Menopause causes hormonal fluctuations that has, as I've already told you, can affect the perinatal health and increase the risk of gum diseases. So effective management strategies are essential so that you address the perinatal challenges during menopause, and the treatment needs to be tailored according to your patient. Clinical management consideration. Comprehensive medical history is important. So a clinician should routinely inquire about the menopausal status of a woman, and understanding the patient hormonal status can help the dentist to tailor the treatment plan according to the needs of the patient, and you can already anticipate the oral health challenges that are associated with menopause. So oral next is the oral hygiene and maintenance. Patients should be educated about maintaining meticulous oral hygiene like any other phase during menstrual cycle or pregnancy, even during menopause, because of the changes in the hormones. We need to educate the patient about their effects on the oral cavity and how is it so important to maintain a good oral hygiene. You can give the patient an alcohol-free mouthwash because they're already suffering from dry mouth and other conditions. And you can give a patient, mouthwashes which can increase the salivary flow. Collaboration with physician is important, and that is your medical professional essential for managing menopause symptoms and other health risks comprehensively. Dentists may need to consult with the patient physician regarding appropriate if an hormone replacement therapy needs to be started in case the patient presents with severe symptoms. Nutritional counseling, because after once we hit menopause, our calcium and vitamin D level starts going down, so and that weakens our jaw bones. So the nutritional counseling is important. Maybe you can add supplements of calcium and vitamin D. Symptoms management, addressing symptoms such as oral discomfort, dry mouth, or altered taste sensations can improve the quality of life of these patients. And as I said, hormone replacement therapy can be started for patients coming with severe symptoms, but you are not the one who's going to start. You have to refer the patient to the gynecologist, discuss with the gynecologist, and let them start with hormone replacement therapy. And these hormone replacement therapy studies have shown that, here I wanted to quote one of the study by Kral and colleagues, where they have shown that a longer durations of hormone replacement therapy can lower the risk for tooth loss, and thus this highlights the potential protective effects of hormone replacement therapy on oral structures. In conclusion, menopause brings about significant hormonal changes that influence various aspects of oral health, including periodontal tissues and bone density in the jaws. Dental clinicians are pivotal in recognizing these effects and implementing preventive strategies and collaborating with the medical professionals to optimize oral health outcomes for menopausal patients. By addressing hormonal deficiencies associated oral manifestations proactively, clinicians can contribute to enhancing the overall well-being and quality of life of menopausal women. This is, recommendation by National Institute of Health Sciences for optimal calcium intake for a premenopausal woman about the age of 25 to 50 years of age. You can give calcium about 1,000 milligrams per deciliter. About postmenopausal women, estrogen therapy about 1,000 milligram per day. Postmenopausal women with no estrogen therapy, you can give about 1,500 milligrams per day. And women and men above 65 years of age, then you can give about 1,000 milligrams per day of calcium intake. However, before I go to decide my calcium intake, usually what I do is I ask the patient to get a serum as well as a 24 serum calcium level done, as well as a 24 hours urine calciuria, so to decide how much is the calcium loss and how much calcium I should give to the patient. What are the preventive measures and maintenance in female patients? The importance of oral hygiene, preventing, throughout my presentation, I have been talking about importance of educating the patient, importance of maintaining good oral hygiene. So it is, very important that as a dentist, we educate our female patients, explain them that, periodontal disease can be prevented if a good oral, regular or good oral hygiene measures are taken care, as well as regular visit to the dentist is taken care. A regular checkup, importance of checkup. Regular dental checkups are essential for early detection of periodontal disease, preventing any further complications. Professional cleaning helps in maintaining gum health by removing plaque and calculus buildup, reducing the risk of gum diseases. Role of diet and lifestyle. A balanced diet is important. During puberty, we've seen a lot of girls start with fat diets, and their periodontal status, because of fat diets, they have this nutritional deficiency, and already they have this hormonal effect, and then the nutritional deficiencies make the perinatal status even more worse. Okay? So importance of balanced diet, not just during puberty, during pregnancy, during menopause, is really important every stage of life. Healthy lifestyle habits by engaging in regular physical activity fosters a healthy lifestyle that promotes prenatal health. Educate the patient to avoid tobacco, and stress management also helps in positively impacting the gum health as well as overall wellness. In conclusion, unique needs of the woman needs to be understood, and recognizing these unique needs of women in perinatal therapy is crucial for effective treatment as well as positive health outcomes. Hormonal changes can impact the perinatal health, and understanding these changes on the perinatal health, on our periodontium, allows for a better treatment planning to a tailored periodontal therapy for our patients. Okay? So, our tailoring the therapies to different stages of women can enhance the treatment effectiveness and preventive strategies. Thank you so much. I hope I'm well on time.
Yes, Dr. Meenu, it was a lovely presentation, and thanks for being kind enough to share the dosages as well as what are the preventive methods and mechanisms rather than just saying that avoid this antibiotic and all. So a very well thought about presentation, and I'm sure the audience has lot many take home points from you to take. Thank you so much, ma'am, for gracing us with your presence. And I have, as a mandatory questionnaire, I always ask one question to the
Thank you.
speakers. Just stop sharing your screen so that we can see you now. Yeah, what is that you would like to tell your younger self? Like, since you are talking about different stages of women, so what is it that piece of advice you would give in one line to your younger self?
Yeah, to not to worry about the future, stress less. I wish, we have a habit of, overthinking. I mean, at least me, and worrying about the future, and, we stop living in the moment. So I
Yes.
wish, I had this thing, I knew this thing before, these words of wisdom that to live in the moment and stop worrying about the future. That's not in our hands so much.
Maybe 20 years down the lane, you will remember this day when you reminded your younger self and the older self also that, okay, chill out.
Yeah.
Thank you, ma'am, for gracing us with your presence for this event. And yeah, you can just stop sharing the screen. We'll welcome our
Yes.
next
Thank
speaker.
you so much. Yeah, I'll do that. I'm not getting how to stop share. Oh, yeah, I got it.
Yeah, thank you so much. Thank you so
Thank
much.
you, Dr. Sohan. Thank you so much.
Okay, thank you. Yeah, on that note, we'll welcome our next speaker and the patron for the Congress, Dr. Shail Jaggi, ma'am. Dr. Shail, can you just switch on your camera and unmute yourself?
Camera switched on. I've unmuted myself also.
Yes, ma'am. And Dr. Shail Jaggi needs no introduction. And your video yesterday was so lovely for the inaugural ceremony. Thanks for that, ma'am. And thanks for taking out time in your busy schedule and being with us. Dr. Shail Jaggi, ma'am, she needs no introduction. Actually, whatever I say is actually just a sum up of her activities, whatever she conducts throughout the year. She's a microendodontist and a cosmetic surgeon, and founder of Dental Wiz Smile Institute, Pune, Maharashtra. In fact, I should call it a college only because the way she conducts the courses and teaches, it's not just the course that day. She will guide you and mentor you beyond those courses also. So it's a life lesson, and I am privileged to know her since I think almost 25 years. And thank you, ma'am, for being a part of this congress and being the patron for this congress. You'll be talking about minimizing failures in indirect restorations. I know this is a huge fellowship topic in itself, but I'm sure the audience will have a lot of take-home messages. Ma'am, I would like you to smile for the camera first. Yes, ma'am. Thank you so much. And on that note, can you just start sharing your screen, ma'am? The speakers who have already presented, please join the chat box. There are many questions for you from the audience. Yes, ma'am. All good to go.
So, hi everybody, good morning, and wishing all the lovely women here a very happy Women's Day. It's a Saturday morning. I'm sure we have lots of things to do. Some of us are celebrating, some of us are doing other things. But I'm going to talk about something that's something that all of us love doing, aesthetic work in our practice. Now, the slot that I've been given is really tiny. So I was thinking about how to go about this whole presentation. And I thought instead of rushing and trying to cover as much as I can in a half an hour slot, what I'm going to do is I'm going to take one particular segment of aesthetic failures and I'm going to try and work your way through it so that, you get an overview as to how we do things at the practice. And this is a case I'm currently doing in my practice. We are still in the process of doing this. And I thought, what better way than to share it with everybody around here and give you an insight of how our practice functions on a day-to-day basis, because typically we do a lot of aesthetic work in our practice. And a huge part of my practice, we have equal proportions of microendodontics and aesthetic makeovers. I'm passionate about both. So if you ask me what do you like more, I can't say, because I just love doing both the things equally. So today I'm going to talk about failures. Now, if you look at this picture on the screen, this is a patient who had come into us. Now, this is not the case I'm discussing today, but this is something that, has been done by one of our peers. It has been done by one of somebody from our fraternity. And when a patient walks out like this is not how we want to represent dentists, okay? This is not how we want people to look at, say, and, oh my God, who did this for you? When a patient walks out of your office, you want the person or people to say, oh, did you really get something done? I can't believe you got dental work done because this looks so natural and so amazing. So quickly, when I'm talking about failures in indirect bonded dentistry, now when I'm doing indirect bonded dentistry, my indirect bonded dentistry is anteriors and posteriors both. Today, obviously, I don't have the time to address everything, but I'm going to give you a gross classification of what my failures fall into, right? So my failures will fall into biological failures, mechanical failures, adhesive failures, aesthetic failures, and digital failures. Why I've included digital failures typically as a specific subheading is because today everybody is talking about digital dentistry. The buzzword today is digital dentistry. If you're not doing digital dentistry, you're not like a happening dentist. That is absolutely not true. So I have a huge segment on digital versus analog, which again, at some point in the near future, I'm hoping we'll address. But today, biological is basically decay, caries, things like that, that are, it could be negligence on the part of the dental surgeon because they've not looked at it well enough to see if they've excavated all the decay. It could be it could be a violation of a biological width. It could be something where your soft tissue is not being taken care of. So anything to do with soft tissue and the tooth per se, caries, decay, all of that is something that is biological. When you're looking at mechanical failures, mechanical, I do veneers. I don't see my incisal guidance properly. I might have a shear stress coming onto that tooth in my lateral excursion, in my incisal guidance. The patient comes back after about 15 days or 20 days and say, look, what happened to my veneer? I've chipped my veneer. Now that's a mechanical failure. How does this mechanical failure arise? Again, lack of planning. If you're not planning it well enough, and how are we going to deal with these mechanical failures? Again, a huge subtopic. So I don't really have the time to discuss it today. So yeah, that is your category of mechanical failure that you're looking at. When I'm talking about adhesive failures, what are we looking at under the heading of adhesive failures? When I talk about adhesive failures, I'm talking about, typically we are doing bonded dentistry today. So the basic criteria for bonded dentistry, what kind of isolation are you using? How are you going to isolate and achieve 100% isolation in that area? How are you going to go ahead and use the correct dual cure resin? Are you going to use a dual cure resin or not? What are the areas where you want to use a dual cure resin and where are the areas that you want to use a direct bonded? Now, if I'm doing a posterior, I would definitely want to use a dual cure resin because I'm looking at a depth of a restoration. I need something that starts to cure on its own. But if I'm looking at an anterior, I probably don't want to do a dual cure resin there. I want to do a direct bonded, right? Because I have so much more control over my bonding protocol. I have so much more control over my shade matches for my resins that I'm going to be matching with my veneers. So those are my adhesive failures. Lack of isolation. I don't use a rubber dam. If I don't use a rubber dam, and I have crevicular fluid coming in at my finish lines. I have a little bit of oozing or bleeding, which completely merges with my restoration, and my aesthetics are totally ruined. These are my adhesive failures. Patient comes back after a couple of months and say, look, my veneer debonded or my onlay debonded. Now that is something that I would categorize as adhesive failures. If I'm looking at aesthetic failures, now aesthetic failures is the most critical, because see, a biological failure, I can take care of chair side. A mechanical failure, I can repeat the restoration. An adhesive failure, I can rebond my restoration again. My aesthetic failure is the most critical failure, for the simple reason that when the patient walks in, now this all aesthetic work that we do is not mandatory, right? It's not like, oh, I can't live without this, so please do it for me. It's very often an elective procedure, which means the patient looks into the mirror and says, you know what, I don't like the way I look. Let me go check with the dentist if I can get this sorted. And then they walk into your office, and their only requirement is that, okay, doc, I don't like this spacing, or I don't like whatever it is, whatever the concern that's bothering them. Can we fix this? When the patient comes to you with that requirement, the requirements are very, very specific. The patient is very, very clear about the fact that he wants to leave your office looking good. Now, the screenshot picture that I showed you in the initial thing, do you ever think that the patient is going to be happy with something like that, where every parameter of aesthetics has been violated? Definitely not. So aesthetic failures is what I'm going to be discussing today with a clinical case. And I'll show you the case. I'll tell you the steps that were involved. I'll tell you how we went about the whole case. And we'll give you a little bit of an insight how to do like a detailed planning for aesthetic work, because aesthetics is the first parameter that you sort out in your office. Everything else comes in as a byproduct. If the aesthetics falls into place and the patient is happy with it, patient says, yeah, doc, this is looking great. Let's just go ahead. So let me discuss those aesthetic parameters with you and go ahead and show you a case and do a step-by-step thing for that. And why have I included digital failures? Because like I said, today, scanning is not like a magical wand. It's not that you hold a scanner in your hand, you scan and everything happens magically. No, I have seen situations where I've had people tell me, oh, I use a scanner, all my work is perfect. It doesn't work like that. If your finish lines are not perfect, if your retraction is not perfect, if your margins are not perfect, your scan, however expensive your machine, is still going to be improper, and the lab work that your lab delivers is still going to be very, very substandard. Not because the lab did a bad work, not because your scanner was bad, but simply because you did not follow the parameters of the guidelines of your preparation designs. So mentally, a lot of us, and this I know because I do so many courses, I talk to so many people, I'm mentoring so many young students all the time. And the whole objective these days is, if I have a scanner, one, I'm an ace dentist, and two, if I have a scanner, nothing can go wrong, because the scanner is like it's like Harry Potter's magical wand. You just do something and you say abracadabra and it's all done. It doesn't work like that. Some parameters, still the ground rules are ground rules. You have to stick by them and deliver. Now, another thing a lot of times we don't realize about scanning is sometimes you don't get a definite depth of scanning. There are situations that are now scanners are phenomenal. But remember, I don't want to go into a detail about scanners right now because we don't have the time. But remember, scanners, however evolved, do come with a learning curve. You need to understand how your scanner is working. You need to understand the settings, the depth controls, everything about your scanner before you scan and you go ahead. The second problem that we've been encountering, okay, it's not just the dental surgeons, it's also your labs. Every lab is now into digital dentistry. They will tell you, okay, doctor, ek din mein kaam denge. We'll give you work in a day, but because now we've got a scanner. But I realized for the longest time, I've been working for almost 25 years now. So I realized along over the way that when my lab shifted from analog to digital dentistry, they didn't have enough trained people who were doing the digital dentistry, right? So what started to happen was they were just training anybody who could handle a computer and doing a drag and drop, plan the designs and send it back. And we realized the margins weren't fitting, the restorations were too bulky, just so many problems. And we went back to the drawing board and we said, what's happening? Why is the work suddenly so inferior? You got a good scanner, you got people working. What is happening? But we also realized that people who were doing the work weren't trained either for occlusion or they were not trained for contacts and contours. So even if it's a drag and drop, even in the lab guys also need to have some very well-trained people who are doing the lab work for you, right? So that is again something that's very, very important that you need to keep in mind, that your lab work, even if they are digitally enhanced, do need to know how to do your work right. And this only happens when your lab work comes in, you evaluate it, you give them a feedback and you guide them about what you need. Because very often the lab is so rushed, they'll try and get away with whatever they can deliver. And it's very easy for them. Okay. So again, bottom line being, whatever equipment you have, whatever work you're doing, you need to be trained. You need to have in-depth knowledge about everything that you're doing. Only then can you have communication with the lab. Only then you can tell them what problems you're facing. Just calling up a lab guy and shouting at him, "Ye fit theek nahi hai, wo fit theek nahi hai," it's never going to work. It's like a marriage. You need to communicate and you need to figure out where it's going wrong. And for that, you need to be well educated to understand where the problem is. So that's a little about digital failures. Let's get into aesthetic failures now. Now, when I'm talking about aesthetic failures, let's look at this girl. Okay, very pretty girl. If you look at her, you can see that she's a very pretty girl. But what is that one thing that immediately catches your eye? It's the smile, and you can see that one tooth that's just popping out of her mouth, right? Now, when she came in, her history was that she was actually, when she came in, she was really upset with all the dental work that had been done for her, because when she went to whoever she went to, her requirement was very specific. I've taken 3 months off from work. I've got a problem with this tooth. I need to have it fixed and I need to have it looking nice. Whoever did the work for her just put her on the chair and say, yeah, we'll sort it out for you. There were no discussions, there was no counseling, there was no planning, there was no evaluation, nothing was done. The tooth was just prepped, measurements were done, and then she was just given a crown, which ended up looking like this. And this work was just about, so like I said, this is something we are in the process with this work. And this work is not even like 2 months old. So she's paid for everything 2 months ago, and now she's come back to us. But when she came in, she was very clear. She was like, I don't know. I'm very disappointed with this. Can you do something about it? She didn't even say, please do it. Now she's reached a level of distress. So can you do something about it? And I was like, yeah, let me just evaluate you. We looked at everything. The first thing we realized was she had a deep bite. Because she had a deep bite and the crown was bulky, that the central incisor, the one was had a grade 1 mobility. Now that is the next level of almost negligence that I can say. And this is something I'm very unhappy with. This perfectly healthy tooth now had a grade 1 mobility, which we needed to rectify. So that was my first problem or evaluation. The second, obviously, that the crown looks really bulky. You can see that the crown's not looking good at all. The third was she had aesthetics were all over the place. If you look at her soft tissue, you can see that the soft tissue is also gone for a toss. So the first thing we did for her, when we put her on the chair, I wanted to do a smile assessment for her. How do I do a basic, very basic smile assessment? And all of y'all can do this on your chair side. Take a picture, put it on your screen. You have the horizontal and the vertical lines of orientation. If you look at this picture and the way I've divided it, you can see very clearly, right, that her aesthetic parameters are very much in place. Her smile line is perfect, her pupillary line is perfect, her midline is perfect. Every parameter that you're looking at, she's very, very well balanced as a person. As her facial proportions are superb. She has zero problem with the facial proportions. Now, with that in place, I knew that I needed to zero into what is it that I need to address. And now it was very clear that we only needed to address her smile and nothing else, because now we were going into a closer into her macro anatomy or her micro anatomy, where now I'm dealing only with the oral area, her tooth area, and her gingival area. I know I'm zeroing in into that because facial proportions look pretty okay and they're very sorted. Now, if I'm doing a close up of this, look at this. Can you see what this is? Again, She's got a slight midline shift if you look at it. Look at that bulky central incisor. Look at her gingival line. You can see there's a variation in the gingival line. Also notice that she's got a slightly high lip line. So that gingival zenith is very, very clearly visible. Now, this is again something that you don't want to do. And why has this happened? It happened because of violation of the soft tissue over there, because her crown cuff fit was a very perfect. Also, if you look closely at this picture, and I'll show you a couple of other photographs, can you realize that she does something funny with her lips? She's trying to cover her teeth with her lips. She almost rolls her lower lip over her teeth to cover it. Now, that's a very specific sign. It's an involuntary response that the patient has to knowing that my smile is not looking good. I'm going to try and hide my smile. And that's why they roll their lower lip over their smile. It's very subconscious and they don't even know they're doing it till you point it out to them. Okay. Now, this is another close-up. Again, you can see the 2-1 was also treated. The shade match of the 2-1 is completely off. As we go closer and closer, what am I doing here? I'm going closer into only my dental aesthetics now. And what we see is something that I'm not at all happy with. And everything just seems to be all wrong. Okay. So this is aesthetic failure. Now, when I'm doing something like this, I need to go ahead and look at that. That's another close-up of the same thing. If you look at all her soft tissue, look at everything. It all looks good, but her front is... Now, again, I might have somebody ask me a question and say, okay, why wasn't she orthodontically treated? Why go through all of this? So we did have a very detailed counseling session with her. But like I said, she had already had enough and more of the dentist. She did not want orthodontics. She said, I don't want any ortho. I'm very happy with my slightly rotated lateral incisors because that's what defines who I am. That's my personality. And I said, fair enough. We were happy to respect that and said, if you think that's your personality and you're happy with it, I don't want to push you into it. But at some point, if you ever want to do, but she said, at some point, if I ever want to do orthodontics and correct it, then what? I said, so we can rectify it very easily because what I'm going to do now is sort out all the proportions for you. And if you need to do orthodontics, all we need to do is derotate your teeth and you should be perfectly fine. So we did put another parameter into place where as we went on to the next stage of treatment, if she was ever interested, we would not need to undo everything and redo it, but we would just continue to the next step and make sure that her smile look absolutely perfect. Okay. Now, over here, color is all bad aesthetics. Gingival zenith is all wrong. Emergence profile has all gone for a toss. She's got poor finish line. So you can see, look at the cervical margin of her crown. Very bulky and just like an overhang cervical margin. And the composite layering that you see for the 2-1 is a really poor layering with absolutely no concept of finishing, polishing, shade match, color, nothing. Nothing's in place. So all in all, not a very happy situation to be in for the patient. Okay. So how did we go ahead? Now, this is another image that I need you to see. This is my occlusal image. Like you can see, my laterals are rotated any which ways, right? So I'm not going to really worry about those. But what I am seriously worried about is the bulk of that central incisor. Look at that bulky central incisor. Look at the finish. Look at the margins. This is not how we want to do our dentistry. When you do our dentistry, it should be aesthetic work should absolutely be flawless. There have to be some significant parameters and scientific guidelines that we put into place before we deliver anything like this. You can't just place a crown and say, this is all I can do. We can't do anything better. So let's just leave it at that. That's really not a great attitude. So here you can see everything is bulky, not looking good at all. Bulky and bigger in size, not matching the 1-1. And this is how we finish. If you also look at the palatal design of that crown, you can see very, very clearly that it's really bulky, which is why, because she had a deep bite, it kept hitting the bulky crown. And that's the reason over 2.5 months, she developed a first grade mobility in that central incisor. Now, is this mobility reversible? 100%. Fortunately, she came in at an early stage. So if the crown is taken off and the tooth is rested, the mobility will stop and it will go back to being normal. So that fortunately was not a problem that we had to deal with. We could easily reverse it. Also, if you look very clearly, very closely at that lateral incisor, You can see a dark shadow under the lateral incisor. Now, she kept asking about what about this dark shadow over there? Is it something I need to worry about? And she was said, no, it's just a discoloration. It will settle on its own once we polish it. When we actually did radiographs for the patient, we realized that it was a very deep cavity, and ultimately that tooth did need to go in for endodontic treatment. Similarly, for the other tooth where the composite layering was done, same thing. She had a very poor layering technique. It was really close to the nerve. Tooth was super sensitive. That also went into endo. So all in all, we had two teeth where we did fresh root canals, and this particular tooth in question, we had to do a repeat for that tooth. So what I'm not happy is today the whole world globally, we are all progressing towards non-invasive dentistry. We're talking about biomimetic principles, and we're talking about so much more. And when I have somebody who comes in like this, and I have to innovate and do double the amount of work than what the patient actually needed, it's not a very nice feeling, and it's not a nice space to be in. So this is again something, guidelines, follow guidelines, have a checklist, do things the right way, and follow a sequence, which is very, very critical. So okay, this is her 12 o'clock position. Again, from every angle, why am I showing you these pictures? I'm not showing you these pictures to showcase it. I decided to showcase this case for the presentation because I was already doing it. But this is something that we do very routinely for our patients. All our patients go through an initial complete sequence of dedicated photographs in different angulations, the frontal smile, the lateral smile from both the angles. You can see the crown is really bulky. Then, so the question was, how do you give her back her smile? She doesn't trust the dentist anymore. So we had to really work around her. Now it's become more than us showing her our dental skills or showing her what we could do. It was more psychological now. We had to get her to regain her trust back in a dentist. And I'm not saying this because we did this for her. What I'm trying to say here is, when you start your aesthetic work, your first line of treatment should not be putting the patient on the chair and just starting your dental work. Your first line of treatment, and always, always, and always, has to be very detailed counseling, some great models or scans if you believe in digital dentistry, some very good pictures, some cases that you have already done for other patients, which are like a before and after. So the patient knows what kind of work you're doing in your office. And then after you've counseled the patient with all of this, that's at that point, you go ahead and discuss with the patient the other things. Now, very often when we are doing stuff like this, we don't even discuss estimates or costing. What we actually discuss is only one thing. We discuss the costing for a trial smile. You know why we do that? Because when we do smile makeovers, they're not cheap, okay? They're not cheap for me where my lab is concerned. They're not cheap for the patient where they have to pay up for everything. So sometimes the patient might just be in a little bit of a doubt, oh, is it really worth it? Why am I spending so much? I've lived like this all my life. Maybe I can continue living like this. It doesn't really matter. But you know what happens is, you're selling the patient. You're not selling. Selling is the wrong word. You're giving the patient a feeling of goodness, a feeling of well-being. How do you give that to the patient? When I try and tell the patient, oh, I'll do this and I'll do that and look really nice, the patient just nods their head and say, yes, doctor, yeah, doctor, sounds good. But when I actually deliver a temporary smile and do a trial run with the smile, you can see the patient's eyes light up because they, doc, this looks great. Is this my final work? And that's the point. You say, no, this is not your final work. I'm just trying this smile out. Do you like it? And once somebody gets used to a good thing, it's very difficult for them to get unused to a good thing. Think about it. When you are used to certain luxuries in life, you don't want to give up on them. And then you work that little bit harder to make it happen, right? This is what you're doing to the patient. It's a very bad idea to start discussing costing and estimates and everything. What you want to discuss with the patient, and then the patient is going to say that, oh, and put a price on your trial smile, put a costing. Very often, what you can do is put a costing on it and say, if you do decide to go ahead with the final work, then we'll absorb this costing of the trial smile, which is great because then the patient thinks, oh, okay, this might end up being free if I do the work. Understand that if the patient is already come to you, they have already more than halfway there made up their mind that they want to get the work done. What you are doing now is doing a great delivery, giving them a trial smile which looks absolutely beautiful. So at this point, there are a lot of people who will ask me, but if I give her something that looks really nice and I send the patient away like that for a couple of days, maybe they won't come back. They'll always come back because what you're doing is temporary. And for that temporary bit, you're charging. So whatever you think is a charge for whatever you're doing at that point, please charge them for it. You might decide to absorb the cost at a later date. You might decide to charge them separately for it. That totally depends on the kind of practice you run. So this is more like you are selling them a concept of luxury. You're telling them, this is how you'll end up looking. You can look fabulous. And what I'm doing for you now, you're hardly paying for it. If you say, okay, it's going to cost you like $5,000 or $3,000 or whatever, depending on what practice you do. And they might say, yeah, doc, okay, let me try it out. The second they say, let me try it out, you're good to go. Because if you make the trial smile look fabulous and say, you know what, this is only a trial, your final work is going to look way better than this, do you think the patient's ever going to say no? And when you do this trial smile, leave the patient with the trial smile. Let them go home because it's a change for them. It's a new thing. So let them go home and let them discuss it with their family members. Let everybody in the family look at it and see how they like it. 99 out of 100 times, the patient will come back and say, doc, when can we start? And that is the point where you discuss the costings and everything else. So the other thing that's happening here with your trial smile, remember? So today I have digital dentistry, I have great labs at my disposal, I've got hundreds of other things. But sometimes when I'm evaluating a case, I'm not so sure whether I want to do endo for that case or I don't want to do an endo for that case. But when I do a mock-up or a trial for the patient, I get very clear about, should I be involving 40? Should I be involving 60? See, digital dentistry on a screen looks great. Analog, when it's actually in the patient's mouth clinically, is a different ballgame altogether. And there are times we have given patients an estimate for 6 veneers, but we realize 4 look great. And we say, oh, you know what? It's going to be less expensive for you because we've decided to go ahead with just 4. Or we give an estimate for 4 and say, you know what, my proportions, I'm not happy with the way my proportions are matching up. I think 6 is what you need. What are you doing? You are not suddenly at the end of one step saying, oh, you know what, I think let's just do 4. Let's just do, no. You're very sure about what you're doing, and having that confidence and dealing with the situation confidently is something your patient will look forward to. They will want to know for sure, because adding a small cost again and again and again after every step is very frustrating for the patient. When people are looking at big estimates, however moneyed your patient is or willing to pay whatever, everybody wants to know what they're going to pay for it. So when you are doing the trial smile, you're also putting a rider into place where you say this. So what you need to tell the patient, when I'm doing this trial smile for you, I am also deciding what I like and what I don't like, so I can give you the perfect smile. Because very often the patient will keep pushing you, okay, doctor, give me a ballpark figure, give me a ballpark figure. And you have to absolutely refuse to give that ballpark figure, because when your patient sitting across and they're pushing you to give a ballpark figure, in your mind, you're like little rushed, oh yeah, do this. And sometimes you forget to include an endodontic treatment. Sometimes you forget to include soft tissue management. Sometimes you forget to account for the cauterization. There are so many parameters that when you're rushed, you don't know. But yes, when you're sitting on your computer, evaluating your case and sitting with a paper and a pen and writing, okay, I need to do this, I need to do this, you've got a very definite treatment plan in place. And when you talk to the patient, that comes across very confidently. So this is something that I need to tell you, that please don't be pressurized into giving a costing for the paper. Tell the patient, I'm going to do models. I'm going to do some scans for you. I'm going to do some pictures for you. Without evaluating all of this in detail, I cannot give you a costing, because I need to give you something that's perfect. And that's going to take me a day to do. In the meanwhile, if you're okay with it, we can do a trial smile tomorrow for you, which is going to cost you nothing. And once we are at that point, when I do the trial smile, simultaneously after that procedure, I will discuss the costing with you. That gives you the breathing space. That gives you the time to plan. That gives you time And why am I saying all this? Because once you embark on this, remember, most indirect aesthetic work is irreversible. If you've prepped a tooth and you've done something and given the patient crowns or something or veneers, and they say, I don't like this, you're really stuck. You can't do anything. But when you're in that planning space, also when you're doing a trial smile, it gives your patient a huge amount of confidence to say, you know what, let's just do this. If you don't like it, I'm just going to take it off. You're not stuck with something I'm going to do. So it's like you're giving the patient 20 wigs to wear before they decide what haircut they want. You're not just chopping off the hair and say, oh, this is what looks best on you. And remember, hair grows, teeth don't. There may be labs in Japan and everywhere else where they're saying that teeth are going to be grown in labs and everything, but we are still far away from a situation like that. So for the time being, when we touch a tooth, instead of using your drill like a sword and just cutting everything that comes in your way, please plan and deliver. And the first stage of planning is do nothing, only deliver, get the patient to say yes, and then you go ahead and start whatever you're doing. Okay. So how did we go about this case? Well, what we did for her is some trust building and restoring her lost confidence and her smile. We did a trial smile for her. This trial smile, what I did for her was a little different. Okay. See, this is what I did for her. Can you see that now? The teeth pretty much look very similar. I changed the 2-1 restoration. The layering was changed. The 1-1, okay, I cut out the old crown. Then I did an accurate shade match. I did direct build up for the prepared tooth in resin with perfection. So the crown that I took off, I built it up in composite. Now somebody will ask me, anyway, they want to do a final work in indirect. Why bother so much? Remember, I'm doing a trust building exercise here. I now need to prove to her that I can give her what she wants. This is not to prove my superiority over anybody else. This is to prove to the patient that yes, get into that space where you can trust a dentist again, because dentists do some great work also. So we etched and bonded the tooth and built out that tooth completely in composite. Now when you look at that, you see she looked at her mirror, into the mirror, and her face lit up with a smile, and she said, oh my God, I look so much better. This is how I used to look. This is what I wanted. Is my work done? I said, no, we've not even started yet. Okay. So when I leave her like this, I said, now this is done. Go back home, see if you like it, and then we can discuss the next few steps. So when we left her at this point, can you also realize that the 1-1 still has a gingival zenith that is 2 different levels? But you know what? Gingiva like this comes back to its normal architecture and anatomy if you leave it without any irritation. So that's what we did. We just left it. And when we saw her 2 days later, her soft tissue had built back completely, looking absolutely beautiful. Now, there you can see, it's almost getting better. She's smiling again. Notice the gingiva. It's still showing a little recession. But when she came back in 2 days, the anatomy, the gingival architecture was identical to the 2-1. So that was another thing that she was super happy about. And she said, doctor, I can finally smile. Thank you so much. I'm really happy. What do we need to do next? Now I'm not telling the patient I want to do this. The patient is asking me, what do we need to do next? How soon can we do it? And what is it going to cost me? At this point, whatever I decide are her charges or whatever, and whatever it is that I quote, 99 out of 100 times, she will not go back and say no, right? So you can already see the difference in her smile from the before and after. If you notice closely, you will also see suddenly she's not rolling her upper lip or the lower lip over her teeth. The smile, it looks a little wider and it looks a little better than it was before. Now this is her new smile post-op, and this is the immediate post-op, already starts to look a little better. Now, after 3 days, the soft tissue healed beautifully and it came back to its original architecture. The smile assessment parameters showed her teeth were tiny according to normal smile design proportions. So we did a whole smile design analysis for her. How we do a whole smile design analysis? I have a worksheet and a questionnaire for the office that everybody who's in my office and looking at the case will read the question related to that particular smile and take. Whatever is not matching, they'll cross. So by the end of it, depending on the number of yes and the number of no's we have on the analysis sheet, we make a whole protocol for the patient and we say, okay, this needs to be fixed, this needs to be fixed, this looks okay, this doesn't need to be touched. So that's how we do an analysis. And again, that's a discussion for another day because today I don't have the time. But yeah, after an analysis, we realized that the teeth were tiny according to normal smile design proportions. But if you also noticed, she had very bulky gingiva. Okay. So a gingival contouring would actually make them look perfect. And so we proposed a gingival contouring for her. Now, patient was really apprehensive, like I told you. She's been apprehensive all through. The second I propose a new thing, she gets apprehensive all over again. So we go back to the drawing board again and we say, if you're apprehensive, whenever we have an apprehensive patient, we don't touch the patient. I said, I can do it for you. Let me show you a trial. And she said, yeah, will it be permanent? I said, no, it's a trial. Let me just show it to you. If you like it, we go ahead. You don't like it, we leave it. Okay. So that's exactly what we did for her. We did a reverse mock-up for her. Now, what is a reverse mock-up? Okay. Now, what we did for her, if you remember, both the central incisors, I've already built them up in composite. We just took some old composite that was lying in the practice. We matched the shape to her existing build-up. And what we did was, we just rolled that composite, gave it a contour, and bonded it onto her existing composites. Now, what suddenly happened was, I did not touch her teeth. I just built the composite over her gingiva, and I bonded it there, and I left it there. I said, this is how it's going to look, something like this, after I finish. Now she said, oh, but doc, I can't decide. My mom needs to look at it. I said, yeah, please feel free to go home. We won't do anything today. Go home, let your family look at it. Then you decide and come back. By now, we had also done an endo for the 2-1. So, and I told her, now, if you're looking at perfect aesthetics, doing veneers for both the teeth is an ideal situation. She had actually come in only for a single tooth. But ideally, if you're doing veneers for both the teeth, I get a perfect shade match. I get perfect proportions. I get everything is absolutely optimal. By now, I also told her to discuss with her family if they were open to doing 2 veneers instead of just 1. So the reverse mock-up and 2 veneers vis-a-vis just 1 veneer is something that she went back to the family and she discussed it. When she came back 3 days later, and for 3 days, the bonded reverse mock-up stays because we bonded it to the tooth. So when she came back, she was like, okay, I'm happy to do the contouring and I'm happy to go ahead with 2 veneers. So look at the transition of a patient who has no trust, who came in with really bad work, who came in very disappointed with everything, has now transitioned not only to agreeing with what we were saying, listening to what we were proposing, and also being okay to do more work, right? And this is not unnecessary work. This is something that is going to make her work absolutely perfect. It's going to make her look, her requirement was aesthetics. We are giving her a solution for perfect aesthetics. So at no point have I sold her anything. At no point have I pushed her into anything. We've led her to a point where the patient and you together make a decision. You let the patient say, okay, doc, I'm okay, let's do this. Or okay, I'm not okay to do this. If they're not okay to do that, we say, oh, okay. If she had come back and said, just do 1 veneer, I'd say, okay, I'm happy to do that because I respect it. I'm going to try my best to match the shade because I have a third party involved. I know I can do a great job, but there's a third party involved and it is going to be slightly more challenging, but we can do it. But she did go ahead with 2, which made our life a little easier. So that is how she looked with the reverse mock-up. Now with the reverse mock-up, when she came back, you can see her lower lip is not rolling over her teeth anymore. She's so much more confident. Her smile is so much more confident now. She's trained her lips to relax. She's not putting them, they are not in a state of rolling up her teeth all the time. She's just so much more relaxed now. Okay. That is what she looked like. Suddenly you can see a transition. Now, the other thing that's really important as we do these pictures and we transition from one step to another step to another step, all these pictures are also mailed to her so that her family can look at these pictures. They're looking at her for sure, but they also look at the photographs on a big screen. When you're seeing something objectively on a screen and when you're looking at somebody, they're 2 very different things. The perception is very different of looking at a photograph and looking at a person per se. So this is also something that we did. Again, if you look here, now it looks relatively balanced. It looks good. Everything seems to be falling in place. She's got a happier smile. Can you see? It's wider, it's happier, it's nicer. So she's in a happy space already. Okay. So we let her go with the reverse mock-up for a couple of days so she could decide about the contouring. The next appointment, she was happy to go ahead and give her consent for the gingival contouring and 2 veneers. Now, This is immediately post contouring, immediate post-op. Now you can look the kind of cauterization technique you have, the kind of cautery you pick from the market is very, very important, because this is immediate post-op. Like I did the contouring and we did a picture. Look at the quality of the contour. Now you can see that the soft tissue has tiny jagged edges here and there, but in a week that will settle completely. So we just contoured off the gingiva, and you can see we've got a vertical height of at least 3 millimeters to 2.5 to 3 millimeters now, which makes it look so much nicer. Okay, that's another closer picture of the contouring, immediate post-op. Slight oozing there. Now, in this close-up, you see that the build-up that I'd already done for her, for the two central incisors, the shade match, the contour, everything is looking relatively perfect and precise, right? Now, immediately we went ahead with the veneer preparation. Somebody at this point might want to ask me, why did we do a contouring and not wait for 6 weeks? Because we did a very superficial contouring. We still had a great, not a pocket, a collar there. I had everything that was going to be healing would just heal with regular healing. There's going to be no recession. We've not done anything aggressive. We've not damaged the papilla. We've not done anything aggressive. So everything is very, very safe and it's very, very normal. So that's why we went ahead with the veneer preps. There you can see I have got a depth cutting burr there. I'm doing the veneer preps. And after that, we went on to do her provisionals. Now, this is how we did her provisionals. Again, you can see the provisionals don't look that great because this is immediate post-op, plus her soft tissue was oozing just a little bit. At this point, we don't try and struggle too much with the provisionals because everything we do will create more gingival irritation. So we leave it like this. Just make sure that nothing irritates her soft tissue and the finish lines are perfect. And we send the patient away. In about 2 or 3 days, the soft tissue heals, and then we finish and polish the provisionals to perfection. Now, this again is a very, very critical step, because when we are doing these provisionals and when we send the patient away, those 2 or 3 days the patient is living with the new provisionals. Even at that point, if they have a feedback that, doc, I don't like this shape, or can we just change something a little bit, or whatever it is, we still have the provision to perfect it before the final work comes. Because when we do our provisionals, the provisionals have to be an absolute duplicate of what the finals are supposed to look like. Our provisionals is what my duplicate is a duplicate of the finals are a duplicate of what my provisionals look like. So I might spend 3 hours doing a provisional, but I will make sure that my provisional looks absolutely perfect, because at that point, when I scan that provisional and when I do an impression of that provisional, I send it to my lab. All my lab needs to do is cut that provisional and overlay it onto my final work, and then mill and CAD and mill my final veneers for me, which makes his life very simple, because now he's not using his brain to do anything. He's not using his creativity. The creativity has all happened. So that's one huge advantage of digital dentistry. Today, I can just scan and overlay everything. He just picks it from my scan. He copies it, and they mill an identical looking overlay for me. So when the final work comes in, including texture, shape, alignment, finish lines, my designs, surface texture, everything is par excellence. There's hardly any variation that I need to do in my final work. But that is only if my provisions are perfect. So I've seen a lot of situations where people will say, oh, just live with these for a couple of days. They may not look that great, but your finals will look great. But remember, when the finals come in, you only want to take your provisions off and put your final in. The patient should not realize that there's been a change. Because you may have a situation where the patient starts loving the provisionals and the finals look totally different. And he says, oh, I don't like this. This is horrible. Please take it away. What you had was well. So you want to eliminate that little area or gray area also, so that there is no, when you transition from here to here, this should be identical and this should be identical, and the patient should say, oh wow, this looks so good. I can't see the difference because they look identical. So always spend time on your provisionals, because that is the key to doing perfect work. Okay, so these were her provisionals. Now we did some scanning. If you look at her preps now, these preps, they were in all the teeth were endodontically treated. So the preps may be looking a little aggressive here, but they're not. Remember, one tooth was already prepared for a crown. Now, when we analyze this crown, we realized that we couldn't do another crown for her again, because my problem was the same. I had a deep bite. So if I did another crown, I'd be stuck with the same problem again. So what we did instead was we finished the palatal surface to perfection in resin, and then we created a finish line and gave her only veneers for both the teeth. So the palatal incisal guidance was perfect. Lateral excursion was perfect because that is what I had stabilized. What I was doing was only giving her veneers on the top. So this is what her preps look like. Great finish lines, good finishing on the palatal surface. You can see my palatal surface is finished to perfection. So there's no interference or anything else. And this is how her preps were finished. This is how my lab plans everything for me and sends it back to me. They designed the provisionals for me, the final work for me. This was done finally in lithium disilicate. We did EMAX for this patient. For both the crowns, we're doing EMAX. Look at the deep bite there. Can you see how deep that bite is? How am I ever going to fit a crown into that space? It's impossible. So veneers is the go-to thing. So that's how my lab has sent me the CAD planning over here. And this is the final work. Now he's just going to pick up this work. He picked up my temporization of provisionals. He overlaid onto the final work. And this is what they're going to be pressing and milling and sending it back to me. Now, when it comes from here and I bond it into the patient's mouth, there's going to be hardly any variation. So it's going to look great. Okay. And this is already, can you see? Now she still has a provisionals in because we still not bonded her final work in because we're still in the process. But look at the variation in her smile. Look at the progression from what she was to how we've created it. Took me a couple of days, and I told her right in the very beginning that it is going to take me a couple of days. Don't rush because you've come from a space where you've been unhappy. I need to, this time around, to make sure that everything is par excellence. And she was okay with that. And she said, I'm not in a rush. Let's do it. And this is how we did it. Now, the final work is supposed to come in on Monday. We don't have the final pictures now, but for anybody who's interested in seeing how we finally close this case, please follow us on Instagram. I normally put up a lot of my cases on Instagram and my teaching institute handle, and you can see all the aesthetic cases there. So this is how she looked after we had finished with her. Now, what are the key takeaways from this discussion that I've had today about aesthetic planning? So aesthetic work is demanding. Don't do it casually. That's a request. There's nothing like, let me just put you on the chair and start your work. I'm a pro. There's nothing like I'm a pro because every patient is different. Every patient needs planning, however simple the case looks. You have to have immense amount of planning because not only the patient, but you're also paying a huge amount of money to the lab for aesthetic work. If the patient wants a repeat for anything, you're going to do it at your own cost, remember? Then you end up making no money. So aesthetic work is great, but it's very challenging. Always, please learn how to document, because when you show documented professional pictures to the patient, it's a huge positive because the patient says, wow, doc, that looks great. Oh, wow, doc, you've done this case. And is this how I'm going to look? Or did you do this case or is it off the internet? And we very proudly tell them that we don't have any downloaded pictures. Everything we do is in-house. We've got a whole setup for professional documentation, and that's how we work on the patients. And that impresses the patient. So learn how to document. Everything has a learning curve. It's okay. You will take some time to do it, but the kind of results you have will be amazing. So always do a trial smile to see if the patient likes it. Always take a consent before any irreversible procedure. Consumer protection is big these days. If the patient just decides to create an unhappy situation for you, there's nothing you can do. If you have your documentation, if you have your consents, nobody, no law can touch you because you know that you've done everything in a similar way. Again, for consent forms and for documentation and everything, anybody needing some help or anybody knowing how we do it in our practice, please feel free to get in touch with us and I'll be happy to help. That is something anyways I do as a part of my program. So it'll be great if to help you if somebody needs that help. And plan each step with precision to minimize the failures, right? So this, if you can scan this code, that's the Dentalwiz Smile Institute teaching page where we put up a lot of clinical pictures, a lot of clinical cases, practically every second or third day. Whatever we're doing in our office, it's like a real live feed, a live diary of what happens in my office. Failures, success, difficult cases, easy cases. I love this case. I made so much money case. Those are my favorite ones, but that rarely happens. But yeah, everything that we do is like a live feed. So yeah, feel free to scan that code and follow us on Instagram. Now, These are my 3 Instagram handles: Smiles by Shell for all the aesthetic work, dentalwiz_smile_institute. That's my Insta handle. And we have a third Insta handle called dentalwiz.in. They all cater to different segments, but they're all my Instagram handles. Okay. Okay. We are also available on Facebook, YouTube, WhatsApp. I mean, just about everywhere. So social media, we are big on social media. If you're keen on learning, upgrading, evolving, product launches, then please join the study club. Send me a message on this number and I'll add you to the study club. So that is another way we foster learning between ourselves. So that's another thing you can do. Join me on my study club. And I have Aesthetic Pro Masterclass coming up, where I'm going to be dealing with smile design, veneers, posterior bonded, onlays, inlays, overlays, tabletops, endograms, and we're giving away some free material. So that's from the 24th to the 27th of April. 4 days of crazy learning, solid learning, which is going to take you to the next level. You're going to be like passionate about indirect bonded dentistry. Only for today, this course we are giving away for participants at 36,000. And if you want to pre-book the offer, you can just pre-book by paying 5,000 bucks. And that's only for today. So here I have, for anybody who wants to pre-book, we have a scan code here. You can just scan this code and pre-book it and send me a message saying that you've pre-booked, and we'll send you all the details. If you want more information, please feel free to connect with us and we'll help you with the details, the book brochures, the case, the course fundamentals and everything else. So it's going to be easy, and it's going to be, we've got some fantastic models made. We've got some different models. I mean, the learning is going to be crazy. We've had so much planned out for these 4 days. It's going to be like a different level of teaching because this is a completely upgraded course. Yeah.
Thank you so much for this. It's a surprise for me also. Thank you so much.
So this is only for me being on this platform here, and for being, so that I can, for anybody who's passionate, to take you all to the next level of indirect bonded dentistry and just see the crazy way your practice can do marvelous things with aesthetic dentistry. So my WhatsApp number is 98220-32260, just in case you all want to pre-book. And for anybody who wants a scan code, Dr. Sonal can help you. I'll send it to her. She can put it up and you can scan it. So with that, I come to an end of this presentation. I don't know if this was good enough, but this I thought was the most relevant in aesthetic. And I started with a failure. I showed you how I transitioned a failure into a success story, and not just a basic success story, a success story that actually paid us dividends because the patient paid us more or did more with us than he actually came in for. So that's a feel good factor. And there was no selling, there was no marketing, there were no gimmicks. It was a pure science thing, scientific basis. Everything was done according to the way it's meant to be done. And we had the patient asking us to go ahead with the work. We did not upsell ourselves even once. And that's the basic fundamental of my practice. We never sell. We only show, and the patient asks us and we deliver. So that's how I want you all to do your dentistry. If you need any help, if you want to work with me, if you want to learn with me, please feel free to get in touch and I will be very, very happy to help. So thank you so much, IPD.
Thank you, ma'am, for being a part of this conference and being the patron. And it was really lovely to see your case and the way the workflow had been. And we will definitely log into the Insta account and check the final results. Thank you so much, ma'am. And on that note, ma'am, can you just stop sharing the screen so that I can take your picture again?
I just have to stay.
Stop share.
Can't seem to. Okay.
Yes, yeah, just smile for the camera, ma'am. Okay, that was Dr. Shail Jaggi for you all. And now we have our next speaker, Dr. Soumya Ananthan, and she's logging in from US. I know it's like late. We are like, it's late in the night for her to be here with us. Thank you so much, ma'am, for joining. Dr. Soumya, can you just switch on your camera?
It's on.
Hello to everybody. Yeah, just smile for the camera. Thank you, ma'am. Dr. Soumya is Associate Program and Clinical Director at Orofacial Pain Residency in Rutgers School of Dental Medicine. Dr. Soumya, it's a pleasure to have you and an honor to have you here on board. And thanks for waiting for us. I know it's like I think 12 a.m. in the or almost 12:30 there in US. I understand totally, and you are here giving us knowledge regarding trigeminal neuropathic pain. Thank you so much, ma'am, and welcome to International Pink Dental Congress. The stage is all set. Your slides are visible, ma'am. Please go ahead.
Okay, thank you so much. So I want to start out by wishing all the ladies up in this conference and everyone else who's watching, all the women dentists watching, a very happy International Women's Day. And a special shout out to Dr. Sonal and to the organizing team, including Dr. Jaggi and Dr. Pujari. And just want to let you know that, the previous speakers, I really enjoyed your talks as well. So, in deciding what to present today, my understanding is that, in the previous couple of years, other speakers have spoken about orofacial pain. So, I said, okay, let's just pick a topic in orofacial pain where, we as dentists, encounter patients quite often. And the two conditions I chose to highlight today we'll discuss like in the coming slides. But before I get there, I just wanted to talk about what orofacial pain is. This is the newest specialty of dentistry that encompasses the diagnosis, management, and treatment of pain disorders of the jaw, mouth, face, head, and neck. And this includes, but is not really limited to only the TMJ disorders, which includes your disc displacements with without reduction, hypermobilities, and the myofascial pain syndromes of the masticatory muscles, jaw movement disorders such as orofacial dystonias, neuropathic disorders, which we're going to talk about today, and then neurovascular disorders such as migraine headaches, the trigeminal autonomic cephalalgias, and sleep disorders, that is the dental management of sleep related breathing disorders such as the management of obstructive sleep apnea with mandibular advancement devices. So, like I mentioned earlier, this has been a specialty of dentistry since the COVID year pandemic. The 2020 of March is when it was recognized by the American Dental Association, though it has been in practice for decades prior to this recognition, and it's a specialty in many different parts of the world. And there is like a document that is called the International Classification of Orofacial Pain that also came out in 2020, which makes it like a landmark year for us in the field of orofacial pain. So really, this is a specialty that bridges the gap between dentistry and medicine, which is why it makes it very enjoyable to me. So coming to the topic of today's talk, I just want to start out by the definition of neuropathic pain, which is defined by the International Association for the Study of Pain as pain caused by a lesion or disease of the somatosensory nervous system. So you can have, is manifest as a neuralgia or a neuropathy. And of course, you have burning mouth syndromes that an earlier speaker mentioned. And then you also have conditions such as post-herpetic neuropathy, so on and so forth, which I'm not going to discuss today in the interest of time. But trigeminal neuralgia is the one that we're going to talk about. And this is really the pain in the distribution of a nerve or any or a few branches of the same nerve. And it can, manifest as glossopharyngeal neuralgia in the head and neck area, or as superior laryngeal neuralgia or nervous intermedius neuralgia, so on and so forth. And as for neuropathy, it has been defined as a disturbance of function or a pathological change in a nerve. So if you look at trigeminal neuralgia, this is a sudden, unilateral, severe brief, stabbing, and recurrent pain in the distribution of one or more branches of the fifth cranial nerve, that is a trigeminal nerve. And this is very commonly confused with a toothache, with a temporomandibular disorder. And as a result of this, patients can undergo quite unnecessary and very aggressive dental treatments, which are many a time irreversible. And the estimated prevalence of misdiagnosis in these cases is 48%. So just take a minute to think about it, right? So every other patient that comes with this potential diagnosis has has the possibility of being misdiagnosed and getting irreversible dental treatment done. And, it goes to the point of no return. So it occurs along the course of the trigeminal nerve, and out of the three branches of the trigeminal nerve that are the ophthalmic, maxillary, and mandibular, this more commonly involves the maxillary or the V2 and or the mandibular or the V3 division of the trigeminal nerve. Some points to remember, it's always unilateral, but it can switch sides. And for whatever reason, the right side of the face seems to be affected more than the left side. And as with any other pain disorder, it seems to affect us women more than men. So, a few things to remember about trigeminal neuralgia. So, the first thing is the trigger zone. So, these are areas that are present in about half of the patients with trigeminal neuralgia, and generally they are present in the central part of the face, around the nose, the mouth, or the nasolabial fold area. And then you can have these trigger zones also present intraorally, which can be either a tooth or the gingiva. So, if you look at this coming picture here. So you can see that the extraoral territories have been mapped in this excellent paper by Kruku et al. But also the intraoral trigger zones, which are present in the gingiva or the teeth, so on and so forth, which makes it very confusing for the patient and the clinician as well to diagnose, because whenever the patient is eating or drinking something, the soft food or liquid can trigger the severe pain. And if you do a normal neurological exam, they could be subjective paresthesia, but essentially the exam will be normal. And the other thing that you need to remember about trigeminal neuralgia is that there is something called as a refractory period that follows an attack of trigeminal neuralgia. So this refractory period is several seconds or minutes during which a second pain paroxysm cannot be provoked. And patients know this very well because they know that when they are in this refractory period, they can eat, drink, shave, or do all of those things that they were not able to do previously because they kept getting these sharp shooting pain attacks of the trigeminal neuralgia. So if you look at the medical management of trigeminal neuralgia, this essentially includes anti-epileptic medications such as carbamazepine, that is Tegretol or oxcarbazepine, and then the gabapentinoids such as gabapentin or pregabalin. And then you can also have the add-on medications such as baclofen or lamotrigine that are not the gold standard medications but have some efficacy that have been shown in clinical trials. So now moving along to the second type of neuropathic pain condition I would like to discuss. This is trigeminal neuropathy, or the new name in the ICOP is a trigeminal neuropathic pain, but in the interest of for the ease of understanding, I will just call it as trigeminal neuropathy. So as dentists, any dental treatment that we potentially can do for our patients has chances of causing damage to adjacent nerves, which can result in altered sensory perception, resulting in a sensory neuropathy, or a frank neuropathic pain resulting in a painful neuropathy. So, for instance, injections can cause it. So if you inject like within a neural bundle, there could be like chemotoxicity from the local anesthetic agent, and also, the mechanical pressure of disrupting the neural structures that can cause the neuropathy. If you don't pay attention to anatomy of the adjacent neural structures while you're planning your extractions or implant placements or endodontic treatments, then, that can cause a neuropathy as well. For instance, here you see the extrusion of your filler paste into the IAN, that is the inferior alveolar nerve canal, that has caused the neuropathy in this type of clinical setting. And then, dental implants themselves, when they are not planned properly, they can cause like transections of the nerve, and that can result in a neuropathic type of pain situation as well. So to summarize, if there is a nerve injury, look for clinical signs if you suspect it. If there are no clinical signs, then expect that the recovery would be complete and there are no sequelae. Whereas if you see clinical signs with pain, then you can term that as a painful neuropathy. And if there is no pain, then that can be termed as a non-painful or sensory neuropathy. So the diagnostic criteria for your painful traumatic trigeminal neuropathic pain or your trigeminal neuropathy is that the pain should be present in a neuroanatomically plausible area within the distribution of one or more branches of the trigeminal nerve and persisting or recurring for more than 3 months, which basically establishes its chronicity. And there should be a history of mechanical, thermal, radiation, or chemical injury to that peripheral nerve branch. And then a diagnostic test will confirm whether that peripheral nerve branch was damaged, explaining the patient's pain complaint. And if somebody had, say, for instance, an implant placed 2 years ago, and now they're complaining of pain, that is not a trigeminal neuropathy. You have to basically look for other causes for the pain. So the onset of pain should have occurred within 6 months after the initial injury. And this should be associated with somatosensory symptoms or signs in the same neuroanatomically plausible distribution of that particular nerve. Another way to look at this is, the chicken and the egg type of a question, right? So it is like, did neuropathic pain start on its own, or was it like an atypical presentation of a different type of clinical setting, and that now has converted into neuropathic pain? So to give you an example, like yesterday, I saw a patient who, had endo for various reasons, like he had a big cavity, tooth was sensitive, and then endo was done, but then he continued to have pain, so the endo was retreated, again continued to have pain, had an apicoectomy, continued to have pain, tooth was extracted, pain did not go away, had a dental implant placed on top of that, continues to have pain, and finally the implant was removed and he still had pain. So now the question is, what was the initial diagnosis? It was something that was odontogenic, tooth related, but what was the reason why he continued to have pain? And some of the reasons could be, did he have like an atypical neurovascular pain presentation? Meaning, did he have like a migraine in the midface area that was misdiagnosed and, he needed the root canal for that reason? Was it a referral from a muscle such as the temporalis muscle or the masseter muscle, which very commonly refer to the teeth, or is it an atypical neuropathic pain presentation that was misdiagnosed as a dental or an ENT type of pathology, and because of this, multiple invasive dental procedures were done, and finally the patient ended up with trigeminal neuropathic pain. So again, this is a very difficult question to answer, and many a time, like the patient in question, the one that I saw yesterday, he was an attorney, and he asked me, "Doc, do you think something wrong was done? Why do I have this pain?" And it's a very tough question to answer because, again, you were not at that point of time when the root canal was decided to be done, because for all intents and purposes, there could have been a dental reason for it. But hindsight is 2020, so it's you cannot really go back and blame people saying, what, this should have never been done, that should have never been done. It's the blame game is not going to help anyone. So I always tell my patients, I wasn't there at that point of time, so I cannot answer. I can only tell you from this point of time how we are going to get you better. And most of them, they're okay with that. So if you look at the late pharmacological treatment algorithm for neuropathic pain, that is the neuropathy, you look at the medical status of the patient and then decide whether the patient can go on tricyclic antidepressants or your gabapentinoid type of medications. So these would be your amitriptyline, nortriptyline, or gabapentin or pregabalin. And the second tier would be to combine them if either one of them is not working well on their own. And then the third level of evidence is for combination of medications such as your serotonin, norepinephrine reuptake inhibitors with the gabapentinoids. And then the evidence for opioids is very low, as is for the use of tramadol or topical neuropathic pain medications. So just to summarize between the two conditions, so if you look at trigeminal neuralgia, the pain duration is episodic, meaning, it comes and goes, and, the pain can last for anywhere from a few minutes to a few seconds. Whereas with the trigeminal neuropathy type of condition, the pain is more or less continuous. Trigger zones are present in about half of the patients in trigeminal neuralgia. You don't have trigger zones in trigeminal neuropathy. Is there a refractory period in trigeminal neuralgia? Yes. And you don't have that in neuropathy because the pain is more or less continuous. Remission period, that is the time in which the pain of trigeminal neuralgia is gone for a few months to a few weeks, and then it comes back full blown, that is present, whereas in a neuropathy, you don't really see that. The intensity of the pain in trigeminal neuralgia is pretty severe, whereas in a neuropathy, it's more mild to moderate. And then sensory changes in trigeminal neuralgia are very rare. If you do have them, then you have to suspect a secondary pathology such as a tumor or something like that that could be causing the numbness or the tingling that the patient could be complaining about. Whereas in neuropathy, remember I said you could have a painless neuropathy with just the sensory changes. So you do see that in the trigeminal neuropathic pain type situation. Does the pain cross the midline in trigeminal neuralgia? The answer is no. But with neuropathy, it is possible because of a phenomenon called as central sensitization, where the pain can spread from the initial site of injury. So I think I'm at the end of my talk. I just want to end by saying, I really hope this war in Ukraine ends, and big shout out to President Zelensky for leading his country, through this tumultuous times. And this is my contact information. So, both my private practice information is up there, and as well as my university address. So feel free to contact me if there are any cases or something that I can help you about. We'll be happy to do so. And again, thank you all for having me. My pleasure.
Thank you so much, Dr. Soumya. It was like sitting in your class again and listening to your lecture. Pleasure to have you on board. And ma'am, the mandatory question, what is that one thing you would like to tell your younger self?
So thank you for that question, because I did have some time, because I saw you ask the other speakers as well. So I think the first thing I would say to my younger self is to be kind, to myself, because you push yourself without really caring for yourself, your bodily discomfort or your mental discomfort. So I think the first thing would be self-care. If you need the time to rest, just do it. Put yourself first rather than putting everybody else first and yourself last. So I think that would be one thing. The other thing is to never turn down an opportunity without trying it at least once. And I tell that to my kids as well as to my students, because there are a couple of things that I regret not doing. So I think, going back, I would have maybe tried it at least, for a few times and say, what, like say a new job position or something. And if I didn't like it, just walk away. But always, never turn an opportunity down without trying it at least once. That would be my advice to my younger self.
That's so meaningful, ma'am. Actually, most of the time we females, we take a back seat always. So first thing, prioritize yourself.
Mm-hmm.
That is
Absolutely.
very
Then you can take care of everyone else.
Yes. Thank you so much, ma'am. And it was a pleasure having you on board. And we would like you to join in our next Congress also. Thank you so much.
Thank you so much for inviting me.
On that note, I would like to invite our next speaker, Dr. Ramya.
Hi, Sonal. Good morning.
Good morning, ma'am. Smile for the camera. Yes. Okay. Dr. Ramya is a known name with National Health Academy and Med Skills. We all know her, but in short, I'd like to introduce her. She is professor and head of Department of Oral Biology, Savita Dental College, Chennai. And today she's going to be talking about the resilient mindset, how to thrive after setbacks in life. Ma'am, last year's presentation about the difference between men and women brain I still remember whenever I have an argument with my husband, the first thing I remember is calm myself. He is totally different. He is not understanding. Let me understand the situation. So thank you so much, ma'am, for bringing in that thought process in us, that we need to understand ourselves first. And with that note, I would like you to start today's presentation on how to thrive after setbacks. Thank you so much, ma'am, for joining in the International Pink Dental Congress.
Thank you, Sonal. So I'll come to that last year's thing later. So thank you once again, Sonal and Mariskill and Academy for bringing me here again. And today's topic is about resilient mindset and how to thrive after setbacks in life. So this is something, a very important topic I feel is very, very close to my heart. And so to quickly begin about today's topic, resilience is a very, very interesting word. And being in the dental fraternity, we have all heard resilience enough number of times. We have read that enough number of times in our material science textbooks. And especially the impression materials, which are said to be more resilient, we love them to make good impressions. So the same important characteristic is what we also should imbibe on, and that is what this lecture is all about. So to simply put, it's not just a very science definition as far as material science is concerned. Resilience in life is about the ability to bounce back in whatever adverse situation life puts you in. The ability to adapt to change and keep going in face of adversities or difficulties is what resilience is all about. So importance of why you should have a resilience mindset is because it is going to have a very, very significant effect on your mental health, your personal growth, and overall success. And having a resilient mindset, I feel, is one of the very, very important life skill which all of us should possess. So in general, putting together, so when do we have to develop such a kind of mindset, or what are the kind of challenges which we face? So just from the moment we wake up from the bed, there are so many challenges which keep coming to each and every individual. So that is what we should know, that no one is spared and everyone has something to face day in and day out. So that is one thing which all of us should know, and you should know how to handle that situation. So setbacks can be personal, professional, health related. It can be in any form. And whenever there is a kind of setback or any incident which is not very comfortable to us, the immediate thing is the other part of the brain, the happiness quotient decreases, and we start reacting it in a different way according to every threshold. Again, the reaction varies with every threshold. I mean, every threshold which every individual varies about. So the best thing is, I would say, is to be less reactive to situations. So that is one single word which I would like to emphasize here on. And always consider and understand, like the first point, as what is very important is, challenges are going to be there, and challenges are there for everyone. It is not that she is spared or he is spared. There is nothing like that. Everyone has their own set of challenges day in and day out. Having said that, this is a second statement which all of us should understand. By universal law, nature itself has two extremes, and there is a merger in between in everything. So if you go into deeper spiritual science, you know that there is actually no good and bad, and it's all a merger, and there is always a gray area in between. So if you really go into the depth of understanding those concepts, understanding challenges will be super easy. So setbacks are a basic universal phenomenon, because that is how nature is. That is how nature is made of. Because for the level of complexity it always traverses through extremes, and there is always an intermediary phase as well. So please do understand that these are a part of the spectra, and it is very, very normal to undergo challenges or to face challenges. And there is no alternate, as you can't escape, you have to face it. So it is a normal part. So how are you going to develop the resilient mindset? So resilient mindset can be achieved by many, many ways. And the most important is prioritize yourself. Sonal, you put it in a very, very short, a tagline-like sentence, not even a sentence, just two words, and that would say it all. So prioritize yourself. That is the most important thing which all of us have to do. If you are very, very comfortable within yourself, if you are happy about yourself, if you're content within yourself, if you are confident about yourself, and if you're celebrating the person who you are, then automatically things would reflect outside. And believe me, the immediate vicinity or the immediate vicinity of surroundings, the action everything would actually reflect on from the person who you are. So that is how the power of manifestation and things like that work out. So the first most important thing is, again, prioritize yourself. And that can also be put in other words like being self-aware and be happy within yourself. You are the best. So that is something which you have to keep telling yourself. You are the best. You don't have to listen to anyone's judgment about you at all. Just keep telling you are the best. And believe me, that will slowly give you a lot of confidence, and you would really be super successful if you just keep believing in yourself. So that is the first point which all of us have to remember. And then that in turn, again, very high self-esteem about who you are. And the next thing, once you are very, very happy about yourself, when you are in your fullest energy, when you are utilizing your fullest potential, automatically you would have the best of qualities which a human should possess. So with that comes adaptability or flexibility. With that comes beautiful relationships around you. People will want to be in your presence. So that happens automatically when you as a person evolve and you shine across, and people would automatically be attracted towards you. The next important point happens is the spiritual freedom. Spiritual freedom, again, happens in synchronous with whatever I mean, and as you evolve as a person, the spiritual freedom also happens along with it. And of course, coping strategies comes along with flexibility. Emotional regulation is something which is very, very challenging, especially for the female brain. I would not very quickly just put out as a biased statement that females are more emotionally vulnerable. Believe me, chemically, the body is tuned in such a way that we have over time evolved that because of our physiological mechanisms, the vulnerability is slightly more. Emotionally, we are more vulnerable. There are some reasons why nature has made us like that. But what we should understand, having taken the physical form of a female body, you should understand that those have advantages and disadvantages as well. So being a professional, you should be able to master the art of having a very high emotional quotient. Mindfulness, again, that is not very gender specific, it is common to both. Being mindful in everything what you do, being at the present moment is all about mindfulness and non-judgmental. Don't bother about others' judgment about you. The same thing, don't bother about what others are as well. So with all these points, you would definitely have a resilient mindset. And above all, be positive always. Having said that, the normal phenomenon of universe is having both the extremes of being negative and positive, of good and bad. Why should you keep holding on to positive? Because as you keep holding on to positivity, you would tend to look at everything from a positive perspective. Anything happens, you would try to derive the goodness in whatever happens, and that is very much possible. Come what may, whatever bad might happen, there would be a underlying goodness in every event. There will be a reason, and please leave it to the universe. If nature causes some damage, or if nature throws a challenge at you, there is a reason. Believe in that very, very strongly, and if you develop that kind of mindset, believe me, you would be awesome. You would be super successful. And that is where lies the power of optimism and the belief that you are already blessed by being in the human body. You're already blessed, and you have to believe in the universal laws and system, and that would give you a lot of positivity. Emotional regulation, as I already mentioned, being in the female body would definitely make you feel more vulnerable because of the hormonal challenges, but still you can be alert. And if you are mindful, believe me, this can be easily managed. And if you are very stable emotionally, if your emotional quotient is higher, then it would again make you very, very successful in whichever action you do. whichever, even the common actions to professional excellence, whatever you are wanting to do, you would really make it super wonderful. And this is ability, you already have a positive mindset. So you would definitely be adaptable or flexible and always have a growth mindset. And growth mindset is anything which happens, any challenge which happens, take it as a good opportunity to grow. Come what may, believe that it is going to help you in progress and never the other side of it. So keep believing, and every challenge is a chance to grow better and better. Building a support system, again, it is quite easy nowadays because of media and things like that. I mean, the outreach, you can reach out to anyone. Always have a group of like-minded people, or someone whom you can actually go and confide on, you can make friends with. So building a effective support system actually makes a very big difference. But again, I would say when we started the word prioritize yourself, if you are really very happy within yourself, would you be needing another person? It's a very big question. But again, I'm trying to tell you that as you keep prioritizing yourself, that the end result or the outcome happens on a slower pace. During that process, you need this support system to make that end point happen, where you realize yourself fully, where you realize yourself as how you are the best, and you start celebrating yourself. So that completion of being in yourself comes during the course of, and that path requires the support system. And adversity, again, so challenges, adversity, all means the same. So they are the most powerful teachers, and please take challenges as the most important opportunity to grow, and they are the amazing opportunities to create chances. And as you keep growing, the thought process of beating around or just setting aside adversities, there is always a fear of facing new challenges. So that is something which I keep seeing in this younger generation. And there is a tendency to move away from challenges. And please be informed with whatever experiences that we have faced in life. If you think that one path might give you might be very challenging, and if you try to avoid and take an easy path, believe me, challenges will be there in another form, which you may not anticipate. So just avoiding taking a career path because of too many challenges may not actually be a very good opportunity. So please think big and set new goals and take actionable steps, and that would really make you a superpower. And keep fighting adversities, because they're not going to stay for long. They're just going to move away as you sail through undeterred. So that's a very important thing. And as you keep moving on a positive mindset, these are something very, very important. So having a very healthy lifestyle, so discipline is very important. I'm not sounding like a very typical teacher here. Even if you have some lazy practices, it's okay. Keep evolving, keep changing very small habits. So small changes would slowly make you into a better person. And exercises are something which will really make a difference. Every time I talk about exercise to my students, to my friends or my colleague, the next second people blurt out is, I don't have time. Okay, so, okay, fine. We agree that you don't have time. And even if you don't have time, wherever you're sitting, where you're sitting in a chair, or where you're sitting on the floor, or wherever, there are so many exercises now which are super good to be done even while lying on the bed, while sitting on the chair, or while just walking or whatever, or while you're just holding your mobile and browsing through the internet. Everywhere, wherever you are, there are possible innovative exercise solutions, so you can keep shaking your body. And believe me, even a small single shake in the right direction would just surge your happy hormones, and that would give you so much of happiness. And all that is very important to be super resilient. nutrition is something I'm extremely obsessed about. And that again makes a very, very big difference. And again, I'm not trying to be uh, over pushing about nutrition. You can keep cheating for a few days, say 7 days, you cheat for 2 days, but predominantly take super good food and very healthy nutrition always matters a lot. Sleep again, I don't have to tell more about that. So take adequate amount of sleep, which your body requires. No one has the a timeline as this amount of sleep is required for this individual, or this is, I mean, sleep wise, I feel there is no fixed timeline, which we can't say an average for an individual. It is absolutely the individual's need, which the individual has to understand and then utilize. So if I need 5 to 6 hours of daily, I can stay energetic throughout the day, but it may not work out with others. So sleep is something which is very, very individual specific. And other daily habits are something which you can keep practicing. Journaling really helps, because something which might have been very, very daunting to you at that moment might look super humorous at a later point in life. So journaling is something which would really be helpful, especially for youngsters out there. And a quick recap of what was spoken. So resilience is a skill. You will have to develop it, and it can only be cultivated as you keep practicing. And all that comes because of just be alert as what happens. And setbacks cannot be avoided. They are going to be there. They are inevitable. They are going to be there. And every time something negative happens or something which you do not like happens, please understand that there is a hidden beauty inside that challenge. So keep remembering that. And the way you see that makes a lot of difference. And that is when your perspective comes. So please do believe that every achiever till date, the world's record shows that growth or success comes with discomfort. It is never an easy task. It is never a cakewalk. And that is the beauty of success. And you can proudly claim that I've straddled a tough path, but I've emerged victorious. So that is the beauty of facing challenges and coming out with flying colors. So always tend to make a difference in whatever you do and everything what you do. And I thank all my mentors out here in the institution for giving me these opportunities to participate and present amidst this wonderful crowd. And thank you for patiently listening. I thank Sonal for remembering the talk which I gave last year. That was really heartening, and it feels so nice. And you made my day, Dr. Sonal. Thank you so much for this wonderful
Thank you,
opportunity.
Thank you, Dr. Ramya. And it's always a pleasure listening to you. It's not only about dentistry. When I say life beyond dentistry, so you are someone who I look up to in case if I have something, something is not going right. I always look up to your presentations. That's what I say always. And ma'am, very well put. One question which I have been asking each and every speaker. So what is it that you would like to tell your younger self? I know you have covered that point in your talk, but then something in one sentence, if you want to tell her, if you want to look back.
So, like what you said, the best word which I keep telling myself is never give up. Come what may, never give up. So that's a favorite statement of mine always.
Thank you, ma'am. And it's always a pleasure listening to you. We'll connect soon on the same regarding next conference also.
My
Thank you
pleasure.
so much. Thanks for being a part of International Pink Dental Congress, ma'am. And on that note, I would like to welcome our next speaker, Dr. Sangamitra Das Gupta.
Hi,
Hello, doctor. How are you?
I'm good. How are you doing, Sonal?
Great. So, Dr. Sangamitra Das Gupta, actually, she is also one person who does not need any introduction, but let me be humble enough to just say a few words about her. She's a director of core and dental and face and hair clinic in Bangalore, India. So this is the only specification she told about herself. But I'm sure when you start reading her profile, this whole 20 minutes of session will be in just reading the kind of work she's doing. Today she's going to be talking about harmonic oral health for healthier life. And before we start that, can you just smile for the camera, ma'am? Thank you so much.
Thank you.
Yeah, can you just start sharing your screen, ma'am?
Yeah, how do I do this? Share. I
This
have
is
to click on share, right?
Share. And welcome to International Pink Dental Congress. Hope you're enjoying all the speaker
Oh,
session.
I am, but how? Just a second, let me share.
Yes, you started sharing the screen. Yeah, click on your presentation, ma'am. I can see that on the screen
Where is this?
below your photo.
I think this is the one. No. Where did my presentation go? One second.
On the screen, ma'am, on the left-hand side.
This one, right? I have so many things on my screen. Just a second. Yeah, this is the one. So,
Yes, ma'am. Go on the full screen or slide share mode. Yes, ma'am.
this is perfect.
Welcome. Yes, welcome to International Pink Dental Congress. And speakers, please answer the questions in the chat box if you may. Thank you so much, ma'am. The stage is all set for you.
Thank you, Sanu. And at the very outset, I would like to, thank Sonal, Shell, and the team for putting up this Congress. So wonderful of you. And a very happy International Women's Day to all of you. So without much ado, let me begin this presentation. So one second, I think everything is coming on my screen. How do I move it to the side? Yeah, wonderful. So the topic of my discussion is harmonic oral health for a healthier life. So the basis of this presentation is biomechanical dentistry. And Sonal knows that I'm very, very passionate about this. So what is biomechanical dentistry? What is the basis for this? You see this Mount Meru or Meru Parvat as we call it. It's called as the axis of universe. It's called as a holy Mount Meru. Why do we call it holy Mount Meru? It's because it's everything they say physical, metaphysical, and spiritual world revolves around Mount Meru. And in Sanskrit, our spine is also called as Meru Danda. This Meru word comes from Mount Meru. Why? Because the spine is the axis of our body. Every action in our body, like I'm talking to you, I'm moving, every action, whatever we do is routed through spine. Spine is known as the communication center between the brain and the rest of the body. So let me give you an analogy. You have a fancy phone, right? But you will not be able to make a phone call, no matter how expensive it is, unless until you have the network or the tower to receive the signal. So this is exactly what our spine does to our body. It acts as a network, and all the nerves and stuff are the signals. Having said that, why am I at the dental conference? Why am I talking about spine? Because the cervical spine plays a major role in how we do our dentistry, and this is the basis for this biomechanical dentistry. Now, at the age of 6 to 7, the first permanent tooth that comes into the mouth is the first molar tooth. Now, have you ever thought why does it come first in the mouth? The reason being, 5 to 6 years the time when our spine, is formed, and now it requires growth and stabilization. That stabilization part is provided by first molar tooth. And in dentistry, it is also called as the anchor tooth. Why do we call it an anchor tooth? Because all the orthodontists use anchor tooth to align the rest of the teeth. Angus classification is based on molar relationship. It is the first tooth, as I said, to appear in the mouth. And the most important, the first molar tooth dictates the posture. How? Let me show you. If it is in a class 1 relationship, we all have done in our, graduate and postgrad days. So first molar relationship, if you have, irrespective of how the front teeth are, your head remains straight. Okay, that's a good posture. Head remains firmly on the shoulder. If you have class 2 relationship, irrespective again how the front teeth are, head falls forward. This situation is all called as kyphosis. Then we have a third situation wherein it is a class 3 situation, and you will feel, no matter how much workout you do, but head would tend to fall backwards. It is called lordosis. It is after how, the lords would walk with the head held high. So it's after that. Then there is another situation wherein, we most time, like in yesteryears, we used to see great actor Devanand. He could never keep his head straight, and it became a style statement. That's a different thing. But of all that possibly his lower jaw was rotated or moved to one side, which caused his head to move to one side. Like in this picture, you can see this is a very beautiful girl, but her head is slightly tilted to the right side. And if you see her dentition, you see that there is a midline shift, and the lower jaw has slightly shifted to the right side. So this situation is called as the scoliosis. Okay, the one side of the neck looks longer, the other side looks shorter. It's all because the head is tilted to one side, and it is all done by the muscles which are from the cervical spine area are connected to the jaw. Now, what do we require? There are certain principles which guide this, biomechanical dentistry. First and foremost, we analyze the face. So what do we do in the face? We need to know that there are, the face is divided into thirds. We have upper third, middle third, and the lower third. Upper third, we don't take much into consideration because of the hairline. Like I have a bigger hairline, so, or some people have a shorter hairline. So it's not very definitive. But the middle third and lower third must be equal. The thing is, in the Asian, South Asian, East Asian countries, if you see, we are short facial types. What does that mean? We think we look nice, we are petite, we are thin, we are very delicate. But of all that our muscles are extremely powerful. Till the age of 40, 45, we look really nice, especially, the Southeast Asians. You see, and the minute they are above 40, 45, even if the most pleasant person begins to look angry. Why does that happen? Because of the musculature. It's so strong and the lower third drops. So lower third contributes hugely to how facial appearance and how the muscles from head to toe behave. Then we have a right and left should be equal. Does this happen all the time? The answer is no. But here applies the rule of 80-20. If 80% symmetry we have, that means our muscles are more or less in alignment and we have health. Okay. Now, if you see this picture, the picture is original, that picture number 2. If you see what I've done here, I split her face into halves, and the right half I put on the picture number 1, you can see on the right, and picture number left, you see, third picture, you see, left side is onto left. So what do you see? Her left side is younger. That is most women, we love taking our selfies. So we have a younger side and we have a older side, the one which makes us look not so nice. So you'll realize that, we subconsciously, we tend to take that side of this, face towards the selfie. So this tells us that the right and left are not the same. There is an asymmetry. Then what else do we do? Then we have a posture analysis. So it was long ago, a BBC picked up some 100 random people and they checked their occlusal plane. And then they found out that if the person had a cant, saying maybe the right side teeth were a little longer than the left side, and that's how the head got tilted to one side. So that occlusion plane is equal to the interpupillary line. It is parallel to the line passing through our eyebrows, a line passing through our shoulder, navel, hip, knee, all the way till feet. To see the power of occlusion. One occlusion plane can affect the posture from head to toe. As I said, look at this girl, head is to the right. And if you see the feet, look at the right foot is out. Then after that, what else do we require? We require intraoral pictures, we require intraoral scans, and we do the model analysis. So if you see in the picture, what do you see? As the head is tilted to the right, and you see the lower jaw is slightly tilted, shifted to the right side. Then what are the other principles? We require anterior guidance. What do you mean by anterior guidance? When we bring the lower jaw forward, edge to edge contact, our lower central incisors must touch the tip of the upper central incisor, and rest of the teeth must disocclude. That is what is required for to be carved or created in biomechanical dentistry. Then is the canine guidance. The first picture that you see that it is a canine guided occlusion. What does that mean? When we take our lower jaw canine touches the upper jaw canine, rest of the teeth disocclude. And if they don't, what do you see? In the second picture, you can see there is abfraction, there's attrition, whole lot of problems start, because if the occlusion is canine guided, it is guided by the our what muscle do you call it? I get, okay, this muscle here, this muscle guy, and it cannot generate more than 75 pounds per square inch of force. So the teeth are not overloaded. When I say this, teeth on their own cannot generate any force. It is generated by the muscle. Muscles bring about the movement, and the ligaments limit it. Okay. Then there's another principle called as the principle of arc. Our body is the principle of arc. Arc is supposed to be the strongest engineering principle. If you see our body is from head to toe, arc into arc into arc. If you have a flat foot, you see there's a lot of load that falls onto the spine. And in armed forces, if you have a flat foot, you are not selected in army, because it's considered as you are medically unfit, because you are not going to be as strong as the other people. So likewise, if you see, the arc is not just in the structure, it's also in the movement. We don't do like this. Every movement we take is in a arc. Our jaw opening is also in an arc. Everything, whatever you're seeing in this picture, is arc into arc in arc. And that makes us extremely strong. And what caused the break in the arc? If you have missing teeth, if you have mobile teeth, irregular teeth, fractured teeth, or any jaw defect. Then we do the radiographic analysis. What do you see in the radiograph? This is the OPG. If you see the right and the left condyle and the midline is matching, and more or less it's a good situation. This has been taken. I don't put jig in between the teeth to take the OPG. And the second one, I take an anterior guidance. Now, if you see, there is a midline shift, and if you see the jaw has slightly shifted to the left side, and you can see the right condyle is right under the eminence, and the left one is more shifted to the left. This is another picture. This is an MIP, and this, if you see in the canine where there's a yellow marker, you see there is an interference, and the other yellow marker on my right side, that shows that antigonial notch is strong. So this picture itself tells me that he's a person is a clencher, and it's a masseter is hyperactive. Then we do proportion analysis. We take a Ceph, we trace on this. Our orthodontist does this, and we do all airway analysis and stuff like that, and a whole lot of other analysis for the proportion analysis. So what are the diseases which we can treat? We can treat headache, tinnitus, vertigo, jaw pain, sinusitis, watery eyes, dry eyes, spondylosis, shoulder pain, frozen shoulder, radiating pain in arms, snoring, sleep apnea, numbing of fingers. Do you realize one thing? All these problems which I'm telling you, they are associated with cervical spine innervation. So what is the treatment protocol? First and foremost, you need to deprogram the muscle. You need to relax the muscle even before you get into the mouth. So Rio is something which we use. It is a removable ideal occlusion deprogrammer. And till the time we get the stable datum, patient continues to wear Rio. Then we do orthotic with either PMMA or acrylic. And then either we treat with composites or with orthodontics or with glass ceramic implants or combination of any of these. So for Rio, what is the reference point? If you see this 19 plus minus 1 mm is the Shimbashi. This is called as the Shimbashi number. And this gives us the reference point that if the patient has less than this, that means there is a lower drop in the lower third, and this needs to be restored. And this we take as a reference point to make our Rio and also subsequently replicate Rio position into the mouth in the form of acrylic teeth or in the form of overlays, or in fact, even in orthodontics. This is how Rio looks. We have carved both buccal and the central fossa lines on this. This is the lower, most times we make it in the lower jaw. When do we make it for the upper jaw? When the patient is in a class 3 situation, that's when we make it for the upper jaw. So as I said, till we get the stable data, we continue to use it. This is a case of mouth breathing. How did we treat? He had already gone through twice with braces, and he had swollen gums, and he never felt that the mouth was fresh. This is what was done. And then finally, some of the teeth you see, I have not included in the acrylic part, and finally everything was replaced with overlays. What happened to him? He used to have watery eyes, especially the right eye. He used to have sinusitis growing up, and even in his adulthood. All those problems reduced by at least 80%. Then TMJ jaw pain, as I said, we can treat it. Look at the lifeless eyes on the right side, on the left side, the picture number 1. This girl had jaw pain, and look at the dry lips. And after we treated her in a biomechanical dentistry way, you can see how her eyes have lit up. You can see the glitter in the eyes. Only grouse I have against her is that, after the pain went away, she started eating so much food that she put on weight. Otherwise, I feel that's a fantastic result. Then backache, shoulder pain, sleep apnea, all those can be addressed. And as you can see in the top picture, there is no canine guidance. The teeth are knocking, masseter has become hyperactive, tongue space has been invaded. So after correction, you can see that we brought her on canine guidance. And this is another case. He's a case of cleft lip and palate. So wherever he was going, he was being given bridges and stuff like that. The lower central incisors were mobile, that even me and Sonal could pass through it. It was that bad. So I put all the biomechanical principles in place, and I treated only the upper jaw and partly the lower jaw. He had a bridge. I removed that lower bridge, and because the premolar was failing, and the upper jaw put the implants, and you can see on the left side, the broken teeth were removed and the implants were put. This is how the radiograph looked, and this is how his face looks. The picture now on my right. So most people think that I did rhinoplasty, but it is when your muscles align, how beautiful, how proportionate, and how good we look. This is the testimony to that. And look at his leg. As I said, occlusion affects from head to toe. He has bow legs, and after the treatment, you can see that his legs straightened up at the age of 82. Isn't that so beautiful? Acidity. I conduct a lot of workshops for the doctors, dentists, and I always tell that the most of the problems which we cause to the patient is actually we cause and the patient comes to us with. That's the irony of life. Now, this patient, the dentist pulled out all his teeth from the lower jaw. Patient says that he has some of the teeth were very firm, but when something goes wrong, then the patient becomes very negative, and even if something good the doctor has done, they don't acknowledge that. But I view that with suspicion. But whatever it is, the teeth were removed, and this patient became apneic and he became highly acidic. He visited the dentist again. Dentist said, it has nothing to do with your mouth. It is possibly because of you already had some problem. So he goes to a pulmonologist, and pulmonologist gives him a CPAP machine. Now he uses the CPAP machine and he's not comfortable. He goes back to the pulmonologist. Pulmonologist puts his hands up and he says, now you have to go to NIMHANS because he felt that he's psychologically something has gone terribly wrong. So whilst he was leaving, he said, you said that it's because of teeth, right? Go and see Sanghamitra. Now, this patient comes to me and I saw him and I said that it happened because of your teeth. Because now the tongue space has been invaded and tongue is falling onto your windpipe and food pipe. And that's why it's causing the problem what you have. And I treated him. Look at the picture number on my left side. His hair are colored, but you see the distress in his eyes. And look at the picture on the left. His eyes are lit up. He has a glow on his face, and everything that problem which was created by my colleague was sorted out like this. Snoring. Whenever we hear somebody snoring, we laugh and joke about it. But ladies, let me tell you, it's no laughing matter. We mustn't laugh at this person. You do not know. This person is crying out for help. We really need to help this person. Snoring is a precursor of sleep apnea, and sleep apnea is a deadly disease. What is sleep apnea? We have a sleep cycle of 7 hours. And in this sleep cycle of 7 hours, if a person does not breathe for a couple of seconds, and if episodes of not breathing become more than 5, then it is branded as sleep apnea. It has a grading, mild, moderate, or severe. Does this have a genetic predisposition? The answer is yes, but the good news is we can fix it. So these are the problems associated with sleep apnea: hypertension, obesity, drowsiness, fatigue, diabetes, motor vehicular accident, acidity, impotence, job impairment, because you've not slept well and you can't focus on your work, arrhythmias, heart attack, headache, stroke, lung hypertension, dementia, memory loss, and weight gain. It becomes a catch-22 situation. You're trying to lose weight because doctor has told you you're sleep apnea, but you have sleep apnea, you can't lose weight. So these are the situations. That's why sleep apnea is considered as a deadly disease. Now, this child came to me. The mother said, Doc, I need a counselor. I've got 2 sons, but this son of mine is driving me up the wall. He is so hyperactive. He breaks everything. Can you get me a counselor? And I told her, I said, okay. And then she asked me, do you see children? I said, I love treating children. And when I put him on the chair and I said, you know what, your son is sleep apneic, she connected because child's grandmother is sleep apneic. So I treated this child. You can see on the right side picture. This is done with composites, and you can see the picture on my left. This is before the procedure, and here he looks older. You can see the oxygen is not flowing properly, and you see how the head is falling back, and the now head is more upright on the right side picture, and you see he looks even younger. If you see the radiograph OPG, you look at the windpipe has opened. How much the windpipe opened? Before the procedure, it was 9 millimeter, and post it is 14 millimeter. The normal is 15 to 20 millimeter. Am I concerned? The answer is no, because the child is growing up. Lower pharyngeal was 11. I took it to 12, and that is a normal range. Then came the grandmother from Sydney. She came carrying an oxygen cylinder, and I was scared to treat her. It was a very tricky situation. This is how her teeth were. I treated her. This is before and this is after, and this is how her face looked. You can see the blood flowing. You can see the cheek have become pink. This is deep bite. Twice he's gone through braces, and you can see the bossing of bone, indicative of hyperactive muscles. And this is how we treated him before and after. And you can look at the radiograph, look at the lateral ceph. The yellow arrow shows that the fold in the neck is gone. On the right side picture, you can see the windpipe has opened up. You can see the lower third height has increased. And if you see before, it was 12 millimeter. After the procedure, it became 17 millimeter. Normal is 17 to 20. Lower pharyngeal width was 9. I took it to 13. The normal is 10 to 12. This is how his smile looks. Even the gummy smile went away. Eyes open up. Look at the eyes. Okay. Then this is not just we are aligning the nerves and muscles. We do a lot of things to look good, right? We go for fillers. We go for what do I say? Botox. We do these fancy surgeries. The fallout of surgery is if it goes bad, you you require repeated surgery to correct it. Sometimes things even just go southward. It never improves. So is there something that we can do without doing all these things or use them to further enhance your looks? The answer is biomechanical dentistry. Look at the bad result. Such a pretty girl before and what happened after the procedure. Look at with the fillers, how she looks. But had she gone through biomechanical dentistry, probably it would have taken her looks to another level altogether. So this is what we can do. She's in a very high position, and this is how her mouth was, and she never smiled. It's also a confidence builder, right? So after the procedure, and it was a very tricky case. It was purely a surgical case, and me being a surgeon offering her a non-surgical protocol, and I myself did not know what the outcome is going to be, but she showed that faith in me, and I'm forever thankful to her. And this is the after result, and I feel that, and I'm sure you'll agree with me, she looks fabulous. Look at here, eyes have opened up. Look at the lower third. When the lower third aligns, how the entire face aligns, and the smile is looking so much better. Sleep apnea got better. Look at this is a class 2 situation. In we call it bird face, right? So this patient is a model. He didn't want to go through the surgery. And he came to me all the way from Mumbai, and she said, Doc, can you do something? I don't want to go through the procedure. I said, okay, let me try my biomechanical ways. And this is what is I think the neck looks so much better. The bird face is gone, and it looks so much nicer. Look at this picture. This is again a sleep apnea case, and the look is the added advantage. Here, look at her lips and look at her eyes. It looks like as if 10 years have dropped from her age. The only grouse she has against me is she says she has to spend more money on her lipstick, which I think we all enjoy. See, look at the before and after picture. She had only one problem. She had broken her front tooth. And when I saw that, when she came for a consult and I found out that she has all the problems, I treated, because whether it's a single tooth or multiple, my approach is holistic. This we did with braces, orthodontics. Look at the double chin is gone, neck has become longer. You can see how nice it looks. When he went back to the college, his professor thought probably he went through plastic surgery. Sure, this is the difference you and I as a dentist can make. And this is me. Way back in 2019, I was diagnosed with polymyositis. I couldn't even get up from the chair. All the muscles were badly inflamed. Anything I had in my hand would just roll off. The situation was bad. 8 months I was on steroids. And after that, my doctor said, whole life I have to be on immunosuppressive medicine. I've always been not so fat, reasonably on a leaner side, but I had put on 11 kilos. I went through this treatment, and also I washed my diet. I shed all that flab, and the person who couldn't even get up from the chair today, I can sit on this lotus pose for almost 30 minutes easily. Okay. Even the pros cannot touch their knees to the floor, but look at me, I can touch mine. This happens because all the nerves and muscles got aligned, and now I'm in alignment, and all my chakras are also in alignment, and that is what is making the difference. So I wanted to share my story to tell you that biomechanical dentistry is the future, and all of us should get into it. With this, I close my presentation, and thank you very much, Sanal, for having me.
Thank you, ma'am. And it was really wonderful seeing this aspect of dentistry, which is often overlooked.
Yes.
Or maybe I would say people are ignorant about it. And we have seen the results of this biomechanical dentistry being in place and understanding the importance of it. Know now that we can actually help our patient, not just by giving them a beautiful smile, but a healthy lifestyle also. Ma'am, can you just switch off your just come out from the share screen mode so that we can take a picture with you?
How does one do that?
There would be a section saying stop share screen.
And show, right?
Yes.
Have I come out?
Yeah, and then, yeah.
Okay. Is this good?
Stop share screen. Stop share screen.
Stop share. Okay. Yeah.
Okay. Yeah. Just smile for the camera.
Oh, look at let me do my hair.
Yeah.
Okay.
Okay, ma'am. And
Thank
one
you.
question I've been asking all the speakers is that what is that one thing you would like to tell your younger self? Like if you had
Health and health. Take care of your health. You may work hard for your career. You may go anywhere. Your jewelry, your clothes, your whatever. You make a lot of money. You go after fame, name, and this thing. But if you don't have good health, nothing is. So the first thing I always say that, I've gone through it and I know it. And you
Yes.
must have work-life balance. That's something,
Yes.
if you are not able to, then the things are going to go south.
Thank you so much, ma'am. And it was a pleasure having you on board. Thank you so much. Hope you have enjoyed because this is your first presentation with us in International
Yes,
Pink Dental Congress. We hope to have you soon for other programs also. Thank you so
sure.
much. Thank you.
You're most
And on that
welcome.
note, we would like to invite our next speaker, Dr. Ashwini. Dr. Ashwini, are you there? Can you switch on your camera? Yeah,
Yes,
you are
ma'am.
there. Please excuse Dr. Ashwini. Her camera is not working, but she will be sharing her presentation. Dr. Ashwini, can you just answer? Just say hello to
Yes.
everybody.
Very good morning to one and all present over here. Am I audible?
Yeah. Yes, dear. I'll just introduce you in a bit.
Yes,
So
ma'am.
Dr. Ashwini Vadane, she is an oral and maxillofacial surgeon, and she has a clinic by name of Arunika Oral Surgery and Dental Clinic in Pune, and she's attached with in teach. She's into academics also. Today, she's going to be talking about management of complications after transalveolar extractions. So a very important topic, which we all dentists, even though you're not into surgery, but you need to know when to refer. And thank you so much for being a part of this Congress, Dr. Ashwini. You may start your presentation now. Your screen is visible.
Yes. Thank you, ma'am, for giving me this opportunity. My topic for today's presentation is management of complications after transalveolar extractions. So, contents for today's presentations are, as we can see, there will be introduction, then what are the types of extractions, and then post-transalveolar extraction complications and their management. So as we all know, dental extractions are routine dental treatments, which we very commonly all dentists perform in their clinics. And according to Jeffrey O, exodontia or tooth extraction is defined as the painless removal of whole tooth or tooth root with minimal trauma to the investing tissues so that bone heals uneventfully and there will be no post-operative prosthetic problem is created. That is what the tooth extraction is. As we all know, there are two types of extractions. Intraalveolar extractions, also known as closed extractions or conventional extractions or forceps extractions. In this, after administering the local anesthesia, we do the extractions with the help of the forceps. While in open extractions or also known as surgical extractions or transalveolar extractions, we have to perform the surgeries, like we have to take an incision, then followed by the raising the mucoperiosteal flap and then bone guttering. So this is the surgical procedure. So today we are going to see the our topic is that management of the complications which occur after the transalveolar extractions, like after the surgical extractions. So let's have overview of all these. As seen in this slide, these are the hemorrhage, swelling, hematoma, and ecchymosis, as seen in this third picture. Then trauma. Sometimes after traumatic extractions, the patient suffer from the alveolar trauma. Then trismus, that is limited mouth opening. Then dislocation of the temporomandibular joint, sharp bony irregularities, and delayed wound healing. Also, there can be oroantral fistula, then acute osteomyelitis, aphthous ulcer, osteoradionecrosis, surgical emphysema. So all these are the possible complications which can occur after the transalveolar extractions.
Now we will see these complications one by one and their management. So the first one is the hemorrhage. Hemorrhage is the most common complication encountered by the dental surgeon after transalveolar extractions. For this, to avoid this, the thorough medical history is important. We have to record whether patient is having any blood disorders or whether he is having a history of any blood disorders. Then recording family history, past dental history, medical history, whether there are any platelet disorders, liver diseases, all these things are important, as well as whether that. Hello. Hello. Yes, ma'am. Hello.
Your slides are not visible. Is your second device still? Dr. Nural,
No.
can you see your slides? Dr. Nural, can anybody get back to me? Can you all see her slides? Dr. Ashwini, can you share the presentation again? Because
Okay. Yes, ma'am. I will share it again. Now is it visible?
1 second. Let me just see. Are you logged in from two?
No. I have logged out from another one. Just only one laptop I have logged in.
Okay, I think the people are able to see. Maybe there's a technical error on our side. No problems. Continue, ma'am.
Okay. As I told, we have to rule out whether patient is on oral anticoagulants because that plays an important role in the hemorrhage cases, as well as perioperative measures like careful handling of tissues is also important to avoid the unnecessary trauma which can happen during the surgery. The generalized oozing from the soft tissues, usually it can be arrested by the digital pressure as well as gauze pack. You can also use the tannic acid powder to control the bleeding, as well as sutures, as we all know, can be placed over the socket. Then if we can also use the whitehead's varnish or ribbon gauze, like absorbable hemostatic agents, gelatin sponge, bone wax. If if we notice that the bleeding is from the originated from the bone, at that time we have to go for all these options. And suppose if large vessel is involved, then vessel ligation is also required. So all these are the measures that we have to take to stop the hemorrhage. Then the second complication is the swelling. Swelling is also one of the common complication that can occur after the transalveolar extraction. That swelling it is caused by the poor surgical technique or surgical trauma. This inflammatory edema, it can be minimized by following the aseptic principles. Like we have to handle the tissues gently, as well as whenever performing the surgical procedure, there should be judicious bone cutting. There should not be over bone cutting or over guttering. As well as we should use saline as a proper coolant, and the irrigation should be properly done, as well as the all necrotic debris we have to remove after the surgery. So all these procedures, all these norms we have to follow to avoid the swelling. And instead of that, if suppose the patient comes to you with the swelling, and in that if the fluctuation is present, then pus should be drained prior to the institution of the antibiotic. That is known as the draining of the pus. And along with that, we have to start the antibiotic and analgesics. So in this way, we are going to manage the swelling patient. Then third one is the trauma. Post-operative pain, it may be caused by the avoidable trauma during the oral surgical procedures, and there can be bruising by aggressive instrumentation or the damage by the overheated burrs during the bone removal. Avoidance of trauma to the soft tissues while performing oral surgery procedures, combined with the meticulous attention to the smoothing of sharp bony edges and socket toilet, it may eliminate the cause of the post-operative pain. As well as oral antibiotics and analgesics, these are prescribed to control the acute phase of this condition. Then next complication is the trismus. Trismus is the limited mouth opening or inability to open the mouth. Trismus may be caused by the post-operative edema, hematoma, or inflammation of the soft tissues. and it can also be caused due to the needle injury to the sphenomandibular ligament during the nerve block. So in these cases, to manage the trismus cases, there can be intraoral application of heat by the use of short-wave diathermy or the use of hot saline mouth baths, analgesics, antibiotics, muscle relaxants. So usually 6 weeks are required to complete this treatment. And in this way, we can manage the trismus patients. Next possible complication is the dislocation of the temporomandibular joint. Dislocation of temporomandibular joint mostly happens when the operator applies the excessive force while doing the elevation of the tooth. So to reduce this dislocation, the operator have to stand in front of the patient and he have to place his thumbs intraorally on the external oblique ridge lateral to the any mandibular molars which are present, and his fingers extraorally under the lower border of the mandible to support the mandible. The downward pressure with the thumbs and upward pressure with the fingers will reduce the dislocation. This can be easily done in your clinic on your dental chair. Then sharp bony irregularities. This complication usually happen when after doing the bone guttering, if the operator skips the step of the bone filing, at that time the bony irregularities can be seen after the healing of that socket, as seen in this picture. This complication is treated by the conservative approach. If the cortical plate is not loose but it causes the pain, its removal is advised. The fragment may be trimmed using the existing perforation of the mucosa, or the mucoperiosteal flap is raised and the bony irregularity is removed using the surgical burr or bone file. Asymptomatic bony irregularity should be left alone until the spontaneous resolution occurs. This is how we will manage this complication. There can be delayed healing of wound in many cases, especially in the diabetic patients as well as the patient who are having the blood disorders. In that, delayed healing of wound is seen. To avoiding this, we have to take extra care in this type of patients. Suturing can reduce the healing time of the extraction wound, as well as while performing the surgical procedure, we have to take the utmost care. Then oroantral fistula, abbreviated as OAF. This is the very commonly this can happen. The most common methods which are used for the closure of the oroantral fistula are the buccal flap and the palatal pedicle flap techniques. The successful closure of the oroantral fistula should be preceded by the complete elimination of any sinus pathology, the fistulous tract, sinus infection, degenerated mucosa and diseased bone. And the other methods that can be used to treat this oroantral fistula are the bone autografts, auricular cartilage, maxillary sinus lift surgery, third molar transplantation technique. All these are the various techniques, guided tissue regeneration, which is happening very commonly nowadays. So this is one of my case report which was published in 2016. In this we had encountered oroantral fistula with the upper third molar, which had happened after the extraction of this upper third molar root piece. In this we had gone for the Caldwell-Luck approach as seen in this picture. So this was published in 2016. This case was managed very well by the Caldwell-Luck approach. This is one more case report. In this oroantral fistula, we had managed with the von Rehrmann flap, and this was published in 2020. And this case was very interesting. In this, we had given the palatal plate for the supporting the this oroantral fistula. This is one more interesting case of the transalveolar extraction. In this, the surgical extraction of the impacted mandibular canine was performed, which was deeply impacted, and that tooth was located below the incisors. This case was published in the International Journal of Current Research. Then acute osteomyelitis of the mandible. This is also the possible complication. Osteomyelitis, it is an inflammation of the bone cortex and marrow that develops in the jaw, usually after the chronic infection. Extractions done in presence of the acute infections like pericoronitis or any type of gingivitis, it predisposes to the acute osteomyelitis of the mandible. To avoid this, the cause is to be eliminated, and treatment methods can be incision and drainage, sequestrectomy, saucerization. All the treatments of the osteomyelitis are the options for treating this. Then the osteoradionecrosis. Osteoradionecrosis, it happens when the patient is under the uh, radiation for the cancer treatment. In these patients, extraction has to be avoided, and thorough aseptic care during the extraction, it prevents the osteoradionecrosis. The condition is treated by the conservative treatment methods like improvement of the oral hygiene, then prescribing antibiotics, analgesics, HBO therapy. All these are the treatment options for the osteoradionecrosis. Then, as we all know, ulcer, it is the bridge in the continuity in the epithelium, and many times while performing the transalveolar extractions due to the excessive instrumentation or using excessive force, then due to the hand pace, there can be injury to the lips that can lead to the aphthous ulcer, and it takes time to heal after the surgery. So in such cases, these cases are treated by the topical anesthetics, then corticosteroid preparation that we have to prescribe the patient for the aphthous ulcer. So this is also commonly seen after the transalveolar extraction. Surgical emphysema, it is a collection of the air which has been forced into the tissue spaces through the extraction wound, and it forms a swelling which crackles on the palpation, and it gives rise to the discomfort to the patients. It results from the increased air pressure in the oral cavity using an air spray, especially the aerator. And such type of complication, it subsides by itself. The operator has to we have to explain the patient that it will subside by itself. No special treatment is required for the surgical emphysema. Then paresthesia. Paresthesia is as the word implies, it is the persistent anesthesia. Means patient will feel numbness for the certain period of time. In such cases, we have to explain the patient that while doing the surgery, there was the pressure on that nerve. That is, mostly it happens with the while doing the surgical extraction with the third molars. There is the pressure on the inferior alveolar nerve. So that we have to explain the patient. Due to that, he is feeling the numbness in that particular area. In such cases, we can prescribe the multivitamins to the patient. In most cases, the nerve regenerates in 6 weeks to 6 months. So to avoid all these complications, along with taking the utmost care, we have to give the patients proper post-operative instruction. That is very important. All of us know all these post-operative instructions. Just this is the brief overview of that. So I would like to thank MaidSkill to giving me this opportunity to present on the International Women's Day, and I wish a very happy International Women's Day to all beautiful ladies present over here. And thank you, Sonal ma'am, for giving me this opportunity. Thank you so much.
Thank you, Dr. Ashwini. It was really lovely looking at the complete aspect of management and avoiding or how to manage these post-operative complications. Ashwini, can you just stop sharing the screen, dear? And if you would like to answer the question, I'm asking
Yes.
all the speakers, what is it that one thing you would like to tell your younger self?
Yes, ma'am. Ma'am, looking at my younger self, I will just, as right now, one of the speaker has said that health is very important. We have
Yeah.
to take care of our health. If we want to achieve anything, everything is fine. Hard work is fine. Then achieving goals, everything is fine. But if we are healthy, we can achieve anything. So first of all, we have to take care of our health, and then other things are important.
Okay, thank you, dear. Thank you so much for joining and becoming a part of International Pink Dental Congress. Looking forward to further ventures also. On
Thank you
that
so
note,
much.
I would like to welcome our next speaker, Dr. Sanyogita Shah. Can you unmute yourself, dear?
Hi,
Hello, Dr. Sanyogita. How are you?
I'm great.
Great. And congratulations on becoming the board member for IACD, if I'm not mistaken.
Yes.
Okay, I wanted to click a picture. Okay, no problems. I'll take it.
Okay. I'll just stop share.
Okay. Dr. Sayogita Shah is Director of SGK Dental Care and Dr. Shah's Advanced Dental Care in Mumbai. And the topic she's going to be presenting is 10 Commandments of Stable TMJ Practical Tips and Tricks. So what she's chosen to speak is a vast topic, but she's trying to condense it into 10 commandments. And congratulations on being able to make a presentation on that. I would like to take the tips from there. So thank you so much for being a presenter here today, and we welcome you to International Pink Dental Congress. The slides are visible, all set to go, Doctor.
Yes, thank you. Thank you for the lovely introduction, Sonal. Here, my topic for the day is 10 commandments for a stable TMJ for every dental practitioner. Mind, every dental practitioner, it is practical tips and tricks. Now, why for every dental practitioner? Every now and then, I come to hear from people like in my practice, there are no TMJ patients. TMJ is a very vast topic. We cannot do that. So after 15 years of practice, maybe I will have TMJ patients. No, they are sitting in your waiting room. Out of 10, 8 people have TMJ problems that go undiagnosed, unmatched, and after doing your treatments, patient might come with pain in your joint, muscle tenderness, and what do we say? हाँ ये शायद पहले से था, and that is considered as an excuse. If you diagnose patients having problem for TMJ, that is, and if the patient don't want to get it treated, that is their problem. But diagnosing them will always put you in the front foot. Now it is just practical tips and tricks for the general dentist or the specialized dentist who doesn't have any idea for TMJ practice. So why it is very important? Why it is very important? It is the base of all your dental treatment. It gives you peaceful musculature. It gives you a beautiful smile. Now why beautiful smile? Now if you do an anterior restoration, front teeth restoration, you don't give an anterior guidance. You deliberately unknowingly give interferences in your smile. What will happen? Patient might suffer from jaw pain later on. They stop smiling. Then even if you give good teeth, do good whitening, you do good veneers, but if the patient is not smiling, it is of no use. The oral musculature also needs to be synergized with what you have worked. So we are dentists are not only doctors for teeth and gums, but we are the physicians of the masticatory system. We need to know about TMJ occlusion, and it is that triad of teeth, muscle, and the joint. This is the place where I practice. It is an exclusive center for TMJ, smile designing, FMR, and implants. This is the place where I practice. Then this is a old clinic where we have 3 dental chairs. This is for general dentistry. I have been the recipient of the Aesthetic Practice of the Year 2022, 2023, and 24 as well, the runner-up position, then Outstanding Dentist of the Year in 2025, and as Sonal said, now as a member and board of directors for Indian Academy of Aesthetic and Cosmetic Dentistry, a huge honor in itself. And this is a publication again on aesthetics. Now, why would we say why she is so much into aesthetic and now talking about TMJ? It is because of this man, Dr. Avinash Shah. Since last 20 years, I have been just seeing TMJ patients in, out, seen evolution in our treatment, evolution in and how we could treat and make a patient's life better. But this is like a different end of practice. I will be talking about general dentistry and how we can incorporate TMJ practice, or you could say take ahead your diagnosis in that. So first of all, whenever a patient comes to you for a pain in the tooth, do we examine TMJ? Do we examine TMJ? No, nobody does. Almost 80-90% people don't even touch or go beyond this teeth to the joint. You can take permission from the patient. Okay, you are come with to me for a tooth pain, but can I check your joint as well? If you just check, you will also have an idea, and he will also have an idea ki what is going around there. So what is to be taken? Just take your hand in front of your ears here. Ask the patient to open and close, open and close. Now what will you get? Some click, some pain, or some problem there. Or just if you cannot feel anything, put one finger in your ear and one outside and ask to open and close. You will get to know there is a click, there is a problem there. So you can just energize the patient कि यहाँ कुछ तो है, we might require to address it later in life. Then take a pencil and just mark your midline for your upper and lower teeth. Ask the patient to open the mouth. If while opening and closing the midlines don't match, like after opening the midline the lower midline is going on the left or the right, then there is a major problem. If the midline matches but the path is deviated, then it is called as a deviation. This is good enough to be known. Second, encourage for rest position and avoid daytime parafunction. This we can do immediately. Once you see a patient is tense, sitting on the chair, just grinding, or the muscles are getting tense, ask them to do this simple exercise. Your lips should be at rest completely, and sorry, lips closed, teeth apart. Lips closed, teeth apart. That should be the thing the patient should be knowing, and the tongue should be resting on the palate, on the back side of the palate. Okay, this you should encourage. So once the patient goes back to his own office or place, he would just remember that my lips should be closed and teeth should be apart, and tongue should be resting there. And what is parafunction? Daytime parafunction is when they are sitting, they are working on their computers, they clench. So you're making them aware, okay, you're clenching, now you need to stop this, you need to stop the clenching. It is just going somewhere. You'll train your mind to stop that, and they will remember you for this because you have energized them to stop daytime parafunction, which is normally front and back and side to side. Mostly people say ki when my mother-in-law starts talking, I try and I clench my teeth or I grind my teeth. So it gives them a reminder at the back that you have to stop daytime parafunction. How do you then? Third commandment is minimize TMJ load. That we can do as a dentist, right? We can do as a dentist. When you're doing procedure beyond 1.5 hours, use a bite block. It is a simple procedure as that. If you think there is a TMJ problem, which you know or you don't know, before doing any big procedures, just take a closed mouth OPG. You can see here, the front teeth and the back teeth are closed. What you can see in this? Here you can see the joint space, right? The joint space here, you can see the condyle is thoda sa piche, the space is little less. So you can just ask them, right side mein thoda pain hai kya? Left mein kuch aur ho raha hai kya? Okay, so after treatment or in between treatment you have problems, so we might have to address your TMJ issues. But if you minimize the load, take care, give him exercises and beforehand, so we can prevent the further problems. Then what we do is maintain a stable occlusion. This we can give, right? We give a proper canine guidance. What is a canine guidance? When the canine's teeth, the rest of the teeth, the back on the left and the right side should not be touching. Simple. It is simple as that. We don't go into any more complication. What is anterior guidance? Once the front teeth touch, the back teeth are out of occlusion. Bas. That is the only thing we need to know. Then we do a Fremitus test. Now, what is a Fremitus test? You can see here, we don't need any fancy appliances like other appliances to test the load like T-scan, EMG or any other thing. Just place your finger on your restored tooth. Maybe it is a simple filling, a veneer, a crown, and just ask the patient to do tap, tap, tap. If you feel there is a little more movement than the other teeth, then you know you have to go in with your articulating paper and adjust the occlusion, not only in centric but also in eccentric, which is very important. Start doing it, you will have less crown debondings, less veneer debonding in your practices. Then maintain a stable occlusion. Once you're doing an FMR, give a temporary, like this what you have given, temporary for around maybe 15 days to a month. Now why? So the muscles of mastications are getting adapted to your new occlusion, so to your new bite as well. So why to go for a final thing when you can go for a temporary in between? Temporary restorations, they will grind off your one of your tooth might get debonded. So we come to know where we have to adjust the occlusion, and then you can replicate it by doing a scan or asking the technician to replicate the bite at the same time, and patient also gets aware of the new bite. Then addressing the cervical and postural problem. Now this is a very common thing even with us, we say it with teenagers, but forward neck position. Forward neck position increases the load on your neck by almost 100 times. So just encourage teenagers from the age of around 12 to 20 to change their habit, to use your phone from front rather than just bending down. Another exercise with this is chin tuck. Chin tuck is just 2 fingers, put it on your chin and ask them to take it back. Even you start doing these practices in your daily practices, the patient will be very thankful to you. They do or they don't do, that is their outlook, but at least you have energized them to have a healthier lifestyle. Why? Because one second, yeah. So sorry. There is an app where there are many apps which have posture thing where you can see the posture of the patient, and they can diagnose themselves how they are standing and things. Now if this patient here on the left we have treated, and that was before treatment, and the right is after treatment. Here you can see the here there is 2-degree tilt. Now after treatment it is 1 degree. The major difference you can see is the feet, like Sangamitra ma'am had shown. They stand with 1 foot forward, right? So this is 14 degree, it is changed to 2 degree. Now if you can see the significant swelling on her face on the right side, sorry, yeah, on the screen right side, and here on the right side, there is a major change. It has just happened with a simple occlusal splint or a simple occlusal permissive splint. No other treatment. Just it takes time. It takes time and compliance. Same happens with aligners. If you wear aligners, you will get results. If you wear your splint, it will give you results. Yeah. So this is like a thing where you can have a posture analysis. You can see the name there. There are other apps on the Android as well, which are good enough. Now, why this happens is, this was beautifully explained by ma'am. I don't need to go ahead with this also, because you have a problem in your jaw joint here. This plane, your shoulder plane also tilts, your girdle also tilts, your knee also has a problem. All the 5 planes of the body go for a toss. 6 is exercise, physiotherapy, physical therapy. Now, what is moist heat fermentation? It is moist heat fermentation, isometric exercises, and massage. What is moist heat fermentation? Just boil water, put Turkish towel, squeeze it out, then you have steam towel in your hand. You just need to apply on areas where the patient has pain. Like this might happen after, like आपने injection दिया and patient is saying कि my mouth is not opening now, or extreme pain after a treatment. So ask them to do this when they are at home and they're just calling you on a phone. So ask them to do this moist heat fermentation. Isometric exercises is when your TMJ is stable from the pain. So what is it? Is strengthening exercise. Like you place your hand on one side and ask the patient to apply force on the same side, or with your two thumb ask the patient to open against resistance. So these are muscle strengthening exercises. Then massage. Now the fascia, it is said everywhere, it is said that fascia of your body, muscles might get relaxed, but the fascia doesn't get relaxed. You have to physically massage it. So ask them to massage areas like SCM, sternocleidomastoid, temporalis, they have problems. So wherever there is a trigger point or the pain which is excess, you just ask them to apply oil and massage that area. So it might release some of the pressure there. Pharmacology and adjuvant therapy. Muscle relaxant is the safest thing you can give. There are other treatment modalities or drug modalities which are there, but you need to learn about them before prescribing, rather than just saying कि चलो amitriptyline ले लो, need alprazolam le lo, but when to give, how to give, you need to learn that thing. Muscle relaxants you can give. Physiotherapy is also safe. You just send them to a neurist physiotherapist. They can give them safely TENS. TENS is like just small pads of TENS which are applied on the muscles and the pain goes off. Manage stress. No, it cannot be managed. We all know that, but at least we can encourage them कि ठीक है अभी जो temporary stress in your whatever there is in your life, emotional, physical, mental, you just have to try and be aware of it and manage it well as possible. Like with meditation, yoga, therapy, counseling, lot of counselors everywhere, offline, online, whoever you feel you can they can put their heart out, they should have counseling. When we sit to counsel patients, they might open or they might not open, but sending them to a therapy session always helps. Now in this appliance therapy, my god, this is on which I have been living on throughout my life, almost 20 years of life. We have evolved through this. So this, what you can see here on screen, is a permissive occlusal splint. Now permissive occlusal splint has a bump like this thing here. It is just for the mandible to glide on it. Sorry, the jaw to glide on it, the anteriors to glide on it, and the posteriors it is flat, so the mandible can glide left and right. This is the front side. Okay, then how it goes, like if it is in the mouth, you can see the front teeth, once the mandible glides, the front teeth are touching, the posteriors are disoccluding, and once this is here, so you can see every tooth is touching here. The buccal cusp is not touching for the lower. Once you're giving a lower splint, the upper buccal is not touching, only the functional palatal cusp is touching, and it has to be equal intensity contact on both the sides. This is the crux of this. Now why this? Now you're fooling the brain that the occlusion has become ideal, the patient is not grinding, and now they can concentrate on relaxing the muscle. What the muscle was doing was nocturnal bruxism, trying to adjust with the interferences in the teeth. Now the brain is fooled. Now it is everything is okay. Now the muscles can relax, regrow, or you can say rebuild themselves. See, muscle is more powerful than the bone. So you have to deprogram muscles, and it is an ideal form of deprogrammer. I would just like to share this case with you. Here you can see the patient is unable to open the mouth. He was diagnosed at facial palsy, facial thing. Neurologist has given him many medicines. He was supposed to go for a brain surgery, like electrodes on both sides, and then then he went for Botox. He was in immense lot of pain also. Then our old patient whom we had treated, he sent him to us. We said, okay, don't worry, stop all treatments, whatever you have been doing, just wear the splint. And he said, okay, I have tried everything, now let me try this also. This is from involuntary mouth opening to voluntary mouth opening. It was a big thing for me. This happened last week. So whenever he used to come, we used to need a bite block for him to just to thrust him in mouth, then we used to put the splint and then again check the points on it. And he said, and I was searching for the bite block. I kept the bite block for, besides him, and he said, doctor, I don't need a bite block now. Tears rolled out from my eyes. It was just the humble splint which worked in the direction. No appliance, no EMG, nothing, no fancy appliances worked for helped. It was just the splint which worked for him. Now after we have now an in-house manufacturing thing for that also. This is the 3-axis milling machine for that. Then we have a 3D printer and this, so we deliver splints in a day or two as well. We have a teaching center where Avinash teaches TMJ and occlusal splint, take 3-day courses, 1-day lectures, and so on. However the students want to study. This is how the milling machine works. It is the middle one here, you can see it is a 3D printed one, and this one here, it is an orthotic appliance, like a tooth colored one. So we manufacture that as well. It depends on case to case and person to person, whatever is required. We do it for doctors as well. Here you can see on the top here, it's an orthotic appliance. Here it is given for the daytime wear as well, where the patient can eat and sleep with that. it is made in transparent as well as tooth colored. Again, the same principle, tooth colored one, the palatal cuspa touch, it has to be in function, and it needs regular reprogramming as well. This is an anterior repositioning appliance. Now, what happens with anterior repositioning appliance? You can see the airway analysis. Now, I would suggest every other dentist who is doing a full mouth rehab to get an airway analysis done before the treatment and maybe in a temporary stage as well. So to see how the airway goes. Now you can see the patient's airway before the treatment. You can see black spots, red and stuff. Just repositioning the mandible to the front. See how much the airway has increased. Here it was 78, here it is 179, almost like by 100 mm of thing. A simple humble appliance can do such a thing. Once he's better with the treatment, we can go ahead with full mouth rehabs, ortho. So like after your splint therapy, after your appliance therapy, you will have future FMR patients, future ortho patient, future DTR patient, future veneer patients. That is also a win-win situation for all of us. Now, like FMR, what I said, see, this was the patient before an FMR. This is the when he was in temporary. So you get to know how much the airway is increasing. We are giving a better life to the patient as well. Then 10th commandment, this is catch them young and know when to refer. Catch them young is a phrase I have taken from Sangamitra ma'am. She had spoken around 2023 in IEECD conference, and I was so inspired by this. So every TMJ patient, I call the younger ones. I call the younger patients bachus. So mostly they are class 2 div 2, they have class 3, and you know they will also get TMD problems in future. So at least you can energize them. Ask them if they are snoring. Ask them if they have tongue ties. If they are sleeping on their stomach, or if they have unusual sleeping position. So after hearing ma'am, I called 2-3 patients, and after doing an myofunctional therapy, jaw expansion, the palatal expander and all, so they were better, and they thanked me later also. So catch them young. Catch them young. It's like energize your patient to have a better teeth, to have a better airway, and avoid future TMJ problems. Like then energize patients to release their tongue ties and limited mouth opening and when do you need to refer a patient? When you have tried your treatment, and still there is limited mouth opening, the patient is in immense pain, you need to refer them to a TMJ specialist who is around you. Yeah. And thank you MedSkill, thank you Sonal. First of all, thank my family, Dr. Avinash, my son, my my all my father and mother, my sas susur, they have been through with me through this journey. Like madly, we are working 10-12 hours a day, and they are very cool about with me. Miss family functions, they're very cool about it. And my staff, all of these are with me around 10-12 years, and they have been a very immense big support system for me as well. Because for every successful man there is a woman, but for every successful woman we need a big team of people around us to achieve whatever we want in life. And thank you Sonal.
Thank you, Dr. Sayukta. And your last line that says that, okay, we need a team to be successful. That says it all. And with that, I would like to, yeah, please smile for the camera. I should not forget this picture. Just a second. Okay. 1 second. Yeah. Okay. One thing that you would like to tell your younger self.
Okay, so as ma'am said, it is about health, but I would say it is not a crime to look after yourself. Whatever we used to think when we used to get married or we used to younger, so we have to help our elderly, we have to do this, we have to do that. But taking time for yourself is not a crime. It is mandatory. It is an essential thing to do.
Yes.
You have to look after your physical, mental, and emotional health as well.
Thank you so much, dear. Thanks for being a part of International Pink Dental Congress. I think this is our second year together, right?
Yes, Sonal. Yeah,
Yes.
thank you.
Thank you so much. And with that, I would like to call in our next speaker, Dr. Urvashi. Dr. Urvashi, are you there?
Yes, Dr. Sonal, how are you doing?
I'm good, good, good. You're in India or abroad? Where are you right now? Because you keep
USA.
places, USA. Oh, you're in the middle of the night and you're still awake for us. Thank you so much, dear. Thank you so much. Overwhelming. Okay, Dr. Urvashi, she's completed her MDS in conservative and dentistry and endodontics, and she proudly calls herself American dental student. And she calls herself a student for life, actually. She's going to be talking about vertical root fracture detection and treatment plan that is simplified for us all. So, Dr. Urvashi, smile for the camera first. Okay. Can you start sharing your screen, dear? This is the younger self. We wanted this attention because what Urvashi is at that age, if we would have had the guidance and wisdom, things would have been different. We would all agree to that. Yeah, your screen is visible, doctor, and
Better?
please go ahead.
Okay, all right. So, good afternoon, everyone. First of all, happy Women's Day. I'll be presenting, as Dr. Sonal said, on vertical root fractures, diagnosis and management simplified. So to introduce the topic, first of all, the dental trauma, as in general, is a significant public health problem because of its frequency and impact on overall youngster and school children, because they are the most common ones which are being affected by dental trauma. But are we talking about different type of dental trauma first, and then focusing on vertical root fractures? When I say different type of dental trauma, meaning that there are two type of fractures in dentistry: longitudinal and transverse. Longitudinal includes crease lines, fractured cusp, cracked tooth, split tooth, and vertical root fractures, whereas transverse fractures include enamel dentin, L is 1 to 9, we can say that. And then, so when we talk about longitudinal root tooth fractures, so usually they first occurs in our teeth, and then they tend to grow and change over time. What are the key factors that we need to know when we want to save these teeth? Number one is how to identify and classify cracks. Number two is what are the characteristic signs and symptoms that will help us to identify them, and how to detect crack as early in its development as possible. So when we look at the classification of longitudinal fracture, these are the 5 common types. Number one is graze line that are mostly visible in anterior teeth and sometimes posterior as well. It is just like a minor cracks on enamel portion, and that only stays in enamel, most likely doesn't extend towards the dentin. Number two is fractured cusp. Number three is cracked teeth. And when cracked teeth goes down, it results in split tooth. And number 5 is vertical root fracture. So generally what happens is people always get confused between cracked teeth and vertical root fracture. They don't know that they're confused because they don't know when to use the correct term. So I would first like to focus on cracked teeth. So where is the crack or fracture located in terms of cracked tooth? So that is present in mesiodistal, in enamel and dentin of crown only, or crown and root. And it depends. If they are separable, it calls complete fracture. If they are non-separable, it calls incomplete fracture. And if they are separable, it's called split tooth. And if they are initial stage, it calls cracked teeth. And how do we treat it? If it's initial stage, if it's cracked tooth, it depends. If the pulp is involved, then we will go for RCT and prosthesis. And if pulp is not involved, we can go for cuspally reinforced restoration, such as onlays or full crown prosthesis. And sometimes if it is non-restorable, if it goes below the gums, and if it goes below the alveolar bone, then we would go for extraction. And if it's split tooth, definitely we would go for extraction, followed by either FPD or an implant. So here is the just one second. Sorry. Yes. So here's the crack tooth that is an initial stage. So as we see here, it always runs in mesial and distal direction. It starts from the cuspal area. It doesn't start from the root area. And it runs in mesial-distal direction. So as it progresses, it will involve the root structure. And if it ends on the other end, on the down part of the root, it is called as split tooth, right? Whereas for vertical root fracture, the fracture always runs in facial-lingual direction. If it is separable, it's called complete fracture. It involves both root surfaces, meaning facial and lingual. If it's non-separable, it only involves one root surface, either facial or lingual. And how to treat, we will go about it in detail. So this is what I was talking about. If it's incomplete, it only involves one tooth surface, either facial or lingual. And if it's complete, it involves both the tooth surfaces, facial and lingual. But here's the main differentiating point, that it starts from the root apex, or it starts in the root area, number one. And number two is it always runs in facial lingual direction, whereas cracked tooth runs in mesodistal direction. So this is the third most common cause of the tooth loss, and the prevalence of vertical root fracture is 2 to 20%. The prevalence is increasing these days. It is mainly because of the increasing amount of knowledge among the dentists, number one, and number two is advancement in the diagnostic techniques. And incidence is higher for men. There is no reason behind it. So before we begin about how to diagnose and how to treat vertical root fracture, let's go over the risk factors that are involved for vertical root fractures. It is broadly divided into two parts, related to dentist and related to tooth. Related to dentist, it mainly occurs because of the root canal treatment. When we go for a root canal treatment, type of endodontic treatment number one is, for example, if we are retreating the tooth, there are higher chances that it may end up in vertical root fracture than if the tooth is immature and we are doing the root canal treatment. We have to be very, very gentle. We have to be very, very careful, so that we don't end up in fracturing the immature root surfaces. Endodontic excess cavity preparation, then root canal preparation, while BMP, we may end up sometimes in, especially the mesial roots of the mandibular molars, they are not that thick, but sometimes people prepare the canals so much wide that it doesn't have enough space on the on the distal area of the mesial root. So that's where vertical root fracture commonly happens for mandibular molars. And root canal obturation, post-space preparation, coronal restoration, and when we use the tooth as an abutment. And related to tooth structure, so when we have reduced mechanical properties of the tooth structure, the tooth form, anatomical location, especially mandibular second molars are the ones who get the highest load in the mouth. So those are the ones that are mainly affected. And then changes in the dental microstructure, that is because of the butterfly effect. Now, how will we diagnose? The main thing, how will we diagnose the vertical root fracture? So let's start with the patient's symptoms. Unfortunately, there are no typical hallmark signs for the vertical root fracture. However, it says that some patients may present with mild pain or dull discomfort, and which can be accompanied by tenderness on mastication. And on the other hand, it has also been reported that 1/3 of the patients present with no obvious symptoms or pain history. Then second is sinus tract. This is a very important feature that is associated with vertical root fracture, and it's most frequently located at mid-root level or close to the gingival margin. So as opposed to more apically when you have periapical lesions, right? So sometimes it has presence of two sinus tract at both buccal and lingual aspect that highly indicates the vertical root fracture involving both the surfaces, facial and lingual. Then next is periodontal probing. We should always use non-metallic periodontal probe to detect the vertical root fracture. Why? Because it is easier for the probe to identify the defect on the bone, on the alveolar bone margin. And it is important for us to distinguish between the pocket probing depth in vertical root fracture and periodontal disease. In vertical root fracture, the pocket is usually isolated and limited to the site of fracture. It doesn't like go all over the tooth surface. initially you have the normal probing depth, and suddenly you have almost around 8 to 9 mm back pocket, and then again you have the normal probing depth back. So that is the main thing that we need to remember about the periodontal probing. And the radiographs, I'll go over the multiple different characteristic and the different representation of vertical root fracture in terms of radiographic presentations. But however, the main thing is J-shaped radiolucency. We all of us know about that. And the last but not the least is surgical exploration. So earlier, when we didn't have enough data on diagnosis of vertical root fracture, that was the one thing that was recommended to identify the vertical root fracture, meaning that you expose the root surface and you look for it. So these are the things that I was talking about on radiographic appearance. You may see a halo-shaped radiolucency is a combined periapical and perilateral radiolucency on one side or both side, and it may extend to mid-coronal, mid portion and coronal level also. Here you can see in the second X-ray. Now the middle one is either you can see also as an isolated perilateral radiolucency on the proximal side of the root. And the third one you can see here is vertical bone loss or angular radiolucency extending from the crest of the bone and terminating into the root surface apically. Now, the next is periapical radiolucency confined to apical region, not extend coronally. And this can be confused with the the periapical disease. And then next is bifurcation radiolucency, that is also commonly found in mandibular molars. And the root displacement, that is very obvious when it fractures so badly that it is normally visible in periapical x-rays. And sometimes what happens is the after completion of the root canal therapy, initially abscess was present and then it was healed, and then again abscess comes in. So you think that, okay, this is because I maybe have missed one canal or maybe something else is going on. So you end up doing re-RCT again. So abscess goes away and then again it comes back. So those are the main things that we notice routinely in our practice. So we need to always keep this in mind that even with periapical radiolucency also and correlation with abscess, there are possibilities that it can be a vertical root fracture. As I said, that it may appear as a periodontal abscess because it is not present in the apical portion of the attached gingiva. It is present nearly at the margin of the gingiva. And this you can see the same case after 6 years where the radiolucency extends coronally and towards the bifurcation area. So now coming to the management part. So management includes extraction, hemisection, sealing the gap of vertical root fracture through the root canal, and reimplantation after binding the fracture fragment using adhesive resin. So number one, before we start with management, let's focus something on prevention. How do we avoid vertical root fracture? So the practitioner should avoid the use of excessive force with possible torque during lateral or vertical condensation of gutta percha while you are doing root canal therapy. All intracoronal compound case selection amalgam, we don't use pins as much now these days, but initially it was suggested that pins should be avoided. And with age, tooth becomes more brittle, so we should always choose the conservative option rather than going more prophylactically. So let's begin with the management portion. So this is a case of hemisection. A 40-year-old female present with a chief complaint of lower left back tooth since 2 months after the root canal therapy. And root canal therapy was anyway done 2 years back. So both mobility and percussion test was done, and they both were negative. And periodontal probing revealed that there was a 7 millimeter pocket. So this is a preoperative view of periodontal pocket in the distal root area. And this is a pre-op radiograph. And so after the diagnosis of the vertical root fracture, it was decided that let's remove the distal root of this mandibular molar and then followed by prosthesis. So exploratory surgery was done, and it was confirmed that there was a vertical root fracture, and vertical cut was made towards the bifurcation area for hemisection. This you can see here, the hemisected distal root. This is a picture of the socket after hemisection of the distal root, and following extraction of the root, they put some bone grafting material as well. And after that, the sutures were taken, and this is the follow-up X-ray. And you can see here in the prosthesis, they chose they chose the metal crowns for the distal portion of for the prosthesis part of the distal portion. And this is a 2 years follow-up. However, like, this is also an option when patient really wants to save a tooth, and when you want to save a space for implant, when you want to save bone structure for the implant. However, it doesn't last longer, but this is always a good resort to begin with. Now, the second portion is the sealing the gap of vertical root fracture through the root canal. So this is very interesting. So this was the radiograph taken at the initial visit. Here you can see the bone defect, the J-shaped radiolucency, and the diagnosis of vertical root fracture was made. And after that, the root obturating material was removed. And through the canal, these pictures were taken through microscope. So here you can see that in the canal, there is a fracture line present here. So the ultrasonic tip was used to prepare the cavity around that line, and that cavity was sealed with super bond. And after that, the prefabricated fiber post was used, and then you can see the results after 1 year. So here they use super bond. So what is super bond? Super bond is mainly used for the bonding the fracture gap. The resin was chosen because of the report stating that inflammation of peroneal ligament did not occur histopathologically after using the super bond, and it is used to treat vertical root fractures, and it mainly encompasses a tri and butyl boron as a polymerization initiator. And when it comes in contact with moisture, that is the most magical part, that the radicals are generated and polymerization progresses. So because it is difficult to maintain moisture in the beneath the CJ, so it is a very good material when it is moisture friendly, and when it comes in contact with water, it polymerizes. And then next is reimplantation after binding the fracture fragment using adhesive resin. You extract the tooth with as minimal trauma as possible, and then you seal that part with the adhesive resin, and then you put it back. So what are the things that can be used to seal that part? You can use dual cure adhesive cement. You can use GIC. You can use cyanoacrylate or adhesive resin. However, GIC has lower bond strength than other two, of course, but these are the things that has been used and that can be seen in the published articles. So to conclude, it is difficult to identify vertical root fracture, but however, with the advancement of the diagnostic aspects such as CBCT, and with advancement in the knowledge also in among the dentists, it is very common to identify these days, and people are doing attempts also to treat this condition rather than extracting the tooth. So that is a very good point here. These are my references, and thank you so much. Thank you, Dr. Sonal, for giving me this opportunity one more time.
Thank you, Dr. Urvashi. It was very concise, precise, and very, very informative lecture. See, I would not be asking about your younger self, but definitely I would like to know who has been your inspiration. I know about
Yes.
family a little bit, but is there a person who has inspired you to the core?
I would say that person would be my father, because he is the one who guided me during my dental school also. When I was kid, I was very angry kid. If I don't get something, I was very that kind of person that if I don't get something, I want it right away. Otherwise, I would get mad at my parents. So he was the one who changed my behavior towards everything, and he was the one who taught me how to handle patience, and patience by keeping your brain patient. And he was the one who guided me throughout my career. So I would say my father is my idol.
Yes, in fact, I feel every woman,
Daughters, yes.
all daughters will agree that the fathers are the real heroes. And having said that, thanks for coming here and being a part and staying awake so late. Now, please catch up on your sleep. Thank you so much,
Thank you.
dear. And it was a pleasure having you again on this platform.
Thank you so much.
With that note, I would like to invite our next speaker, Dr. Sneha Divekar. We are sorry to say this, that we are not having any lunch break. We will continue throughout the lunch. Dr. Nurul, I hope it's all okay with you, because I don't want to, I would like to catch up on the time here, and lunch break will be utilized for the speaker's presentation as well. So very sorry, guys. It will be a working lunch for everybody. So Dr. Sneha Divekar, can you switch on your camera, ma'am?
Yes, I have switched on.
Yes, yes, yes. Now I can see you. Yeah. Smile for the camera. One second. Yes. Okay, Dr. Sneha Divekar, I mean, when we talk about sports dentistry, she is the one who is pioneering in this field, this very important field. And I would congratulate you for all your efforts that you have been putting in all throughout the years that I have known you. For the past 3-4 years, she's been really striving hard to make everybody aware about the importance of sports dentistry. And congratulations on the same. Dr. Sneha is the course conductor. Of course director for master's program in sports dentistry. She's founder and director of National Sports Dentistry Committee, and I'm sure they're building up a community also of their own. And nice to know that so many efforts have been put into this field. She's going to be talking about sports dentistry, a journey of struggle and triumphs. And the name sports itself signifies with the journey of struggles and triumphs. So welcome on board, Dr. Sneha, and it's a pleasure to have you. Start sharing your screen, dear.
Yeah. Thank you so much for inviting me. So I'll just first, before I start, just let me quickly share the screen. So are you able to see it?
Yes, just go on the presenters mode or slide share mode.
Yeah, just a minute. Yeah. Okay, and just a minute.
No, it is not. It's not yet on the slide share mode. Yeah, now go ahead. It's all set.
So do you see it moving to the next slide also?
Yes, 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 yes. All well.
Yeah, okay. So yes, good afternoon everyone, and can't help but you join us, attend the lecture with a working lunch, all of you. So Sonal, just tell me if the internet connection of this, there is some issue. Okay.
Yes, please go ahead. I'll inform you.
Okay. So good afternoon, everyone. I am Dr. Sneha Divekar. I have my clinic in Pune in the name of Dental Fitness, which is a cosmetic dentistry and a sports dentistry center. And as Dr. Sonal introduced, yes, I am the course director of Master's Program in Sports Dentistry and founder and director of National Sports Dentistry Committee and consultant sports dentist at VMAX High Performance Center. So yes, I am definitely, because I know a lot of people are going to be eager to know about sports dentistry. So my presentation I have blended with how my journey was and what sports dentistry is. So this presentation is a blend of both the things. So let me start. So this is not since last 3-4 years. Actually, it's been now 7 years that I'm into this. So I started the course on sports dentistry as early as July 2018. So there is an institute here in Pune called Institute of Sports Science and Technology, through whom I conduct this course. Started a 3-month course, which through all the ups and downs of COVID. So see, as you can see here, we took a lot many one-day workshop as part of our 3 months distance learning program. Then COVID came. We had to compulsory take workshops online during COVID, and our course completely survived and not only thrived but it succeeded. So we had amazing feedbacks of dentist participants during the workshop, because it was a unique thing for them. So they found everything pretty interesting. Then eventually, as post-COVID, as all the sports clubs started reopening again, we started conducting dental care and dental injury programs for athletes. Yes, some places I took it online, sometimes I took it offline. Then in 2022, there was the Azadi Ka Amrit Mahotsav, where I was the assistant clinical director, one of the assistant clinical directors, you can say, for Special Olympics, Special Smiles here in Pune, where a lot of us dentists were trained for this special event. And it was a very humbling and very interesting experience of doing dental screenings of these athletes. And I have been a local dental speaker on sports dentistry. So yes, the struggle was that, at that time when I started, absolutely means none of the dentists had even heard about sports dentistry. Okay, so then I figured out that the only way to make people understand is to take programs, associate with different people. So I started approaching various dental organizations, dental colleges, dental branches like IDA Pune. So slowly things started building up. I approached bigger organizations, and then I became a regional and a national dental speaker on sports dentistry in many places eventually. So the journey was that, initially I had to keep convincing people that you keep lecture on this topic is important, and this and that. And eventually, as it started spreading, as the awareness started spreading, as people started getting to know about this, people started calling me to to become a speaker in their conferences. So then I have now actually lost count as to how many places I have given the lectures for. So these are all regional, national. With dental reach also, we have given Dr. Sonal, we all know, we have attended dental reach programs also. So yes, continuous post COVID especially, lots and lots of webinars. Then with dental reach, we conducted the first international level dental conference in India in sports dentistry, where I was the not only the scientific chairperson but also a keynote speaker. And we had a very different and an interesting symposium, which has never been taken in, which was never been taken in India before. It was a multidisciplinary symposium with other sports healthcare professionals like sports physiotherapist, sports nutritionist, sports physician, and sports psychologist. So it was like a discussion, it was like a panel discussion amongst oral health and general health of the athlete, and I was the symposium moderator for that. Then for national and international events, I have been a chairperson. Like for ISTT, it was my dream come true when I met online, but at least I met Dr. Steve Mills, who is from Academy of Sports Dentistry, USA, and I got the chance to be the chairperson for his session. Then there was a huge Asian conference happened in Delhi, so we chaired the sports dentistry panel discussion on sports dentistry there. So thankfully, for leading in such places. So this is how the success came after 6 to 7 years, where I was started getting awarded by many organizations for leadership in sports dentistry and taking huge efforts for introducing sports dentistry to Indian dentists. Yes, and FAMDent, so this is an earlier slide. I received the nominations for Innovative Dentist last year, and this year as Educator of the Year. And one more award, which is very close to my heart, is Dental Icon, which is the pioneer of sports dentistry. So I think, it's been a very long journey. And one of my favorite things is to get my article published in a textbook of pediatric dentistry, wherein and I have authored an entire chapter on sports dentistry for children and adolescents, and many such articles I have actually published. But this is like the main thing, because of course, and it's a textbook of pediatric dentistry which all the final year students are using, and PGs and UGs are using. So the work doesn't end at just meeting up dental conferences and spreading the message. You have to be, as a sports dentist, you have to be a part of various sports organizations and leave a mark there. So for example, in Women in Sport India, I have attended so many networking meetings. I have given a lecture to them, like a master class with VZ. I have attended VZ mentoring program to develop a proper full understanding, overall understanding of sports. I was the first dentist to give a webinar on sports dental care for them exclusively for VZ members. Then there is another organization called Association of Sports Nutrition and Fitness Science. So I am the first sports. So you will notice that there are going to be a lot of firsts here. I have been the first sports dentist to be on the panel of ASNFS. My article has been published on sports dental care and nutrition on ASNFS website, and I have been the lucky one to complete a course on sports nutrition approved by ASNFS. There is another organization called Sports Entrepreneurs Foundation. Again, the main purpose is to create a lot of awareness programs amongst the sports science and sports management professionals on dental care of athletes. Because see, they are the ones who are in actual contact with the athletes. And of course, last but not the least, very important is Indian Society of Sports and Exercise Medicine. I am very glad that I became a part of that. First time I have given webinars on their platform almost 2 to 3 times now, and I have been the only one to give dentist to give webinar on offline also and online also. And also ISSCM was our academic partner for our sports dentistry online international level conference. And a true partnership about ISSCM I will be talking about in the end of this presentation. Yes, so I gave a lecture on sports dentistry at the International Sports Medicine Conference recently, which happened at Varanasi. So why and how this happened, I will be talking in the end. So after 4 years of a lot of struggle and reaching out to so many dentists and everything and working hard, so we felt that it is high time to upgrade the course, to which we upgraded it to a 6 months diploma in sports dentistry in 2022. And believe me, it has not been easy to teach dentists who are similarly qualified like you. I have been studying since last 8 years. I have been continuously studying. I have done master's program in sports science. I've done master's program in sports nutrition. I did a fellowship in aesthetic dentistry, fellowship in endodontics, fellowship in psychology counseling, and the list is endless, because whatever we are offering in this course is a conglomeration of it's a structure of all the things learned. And this became a 6 months course again. So again, there are a lot of upgrades in this, but now I'm not going to go into the detail of this, because now this course we have closed down. So again, we conducted for 2 years. Again, it went very successfully, because we started having hands-on for dentists, which were we were not taking in the earlier courses, because we were receiving these kind of feedbacks from dentists that they wanted that everything is there in the course except for the hands-on. So we started having hands-on programs, and it was very interesting and upcoming. And I'm very proud to say that last year, in 2024, we have finally launched the 12 months hybrid program, which is a master's program in sports dentistry. All earlier programs we have closed, and I will talk about this a little in detail later. But right now, what I want everyone to first understand is how what is sports dentistry in context, where does it fall in the context of sports medicine. So I gave you a little idea about my journey, and I will be talking in the end about few other things also, like the National Sports Dentistry Committee and the master's program. But right now, let me focus on sports medicine and dentistry. So sports medicine is contributing today to healthier athletes, optimum fitness levels, and good performance. But now the thing is that winning is now becoming more important than just participating. Best or high performance is the keyword today. There can be millisecond difference between winning and losing. That is why there is more stress on talent detection, research on all aspects to improve athlete performance, and all professionals have to be included in the athlete healthcare team. That is why sports medicine has now become a multidisciplinary field. And of course, dentistry has become a very important part of the sports medicine team today. So it is we as dentists, we should realize our importance in the athlete's healthcare. So there is a Dr. Bob Bryce, of head of medicine and performance at Leeds United. What he is saying is there is nothing more annoying than a player missing a game for a problem that was preventable and could have been treated earlier. That is why sports dentistry is so important, because sports dental care is nothing but preventable dental treatments most of the time. So what is sports dentistry? It is the branch of dentistry dealing with prevention and treatments of the pathologies and injuries of the oral cavity and the stomatognathic system related to sports activities. A little bit into the history. Now, this is going, just see how old this is. This is going back as early as 1958. In 1958, the dentist Mario Trigo traveled with the Brazilian soccer team to the FIFA World Cup. The World Cup lasted for most of the month of June. And during that time, Dr. Trigo pulled 118 teeth from 33 different players. So that's a huge number. Then again in Barcelona, 1992, in the Olympics, the psychological situation, muscle performance of the athletes was improved because of dental treatments. Then in Athens Olympics, 2004, which happened in 2004, dental care was the second most searched service behind only physiotherapy. So these are all the staggering statistics that which you are seeing in the Olympics. Now, why is this happening is because at the grassroots level, a lot of dental treatments are not being taken care of. And that is why athletes are needing treatments at such an elite level stage. Yeah, so there have been surveys on oral health and performance. Dental literature contains information from surveys taken at various championships, which clearly demonstrate the need for basic dental care in athletes, which improves their quality of life. So as you can see here, this survey was made by the dentists in the London 2012 Olympics. Here, you can see the staggering percentage. 40% of athletes were bothered by their dental health. 20% of athletes felt it impacted their training and performance. 30% of athletes reported a loss of quality of life. So if you think of yourself as the dentist, and if you feel truly, if you are a true Indian and if you are a true dentist, don't you feel that it is our duty to prevent any such anything? If I want my athlete to go to the Olympics and win, I don't want anything hindering the training and performance, least of all that which is preventable. So how is oral health affecting the athlete performance? Of course, the first most important point is dental pain. So we all know that it is of mucosal origin, dental origin. I'll not go into that. But how is it affecting the athlete performance? Acute pain is leading to sudden abrupt stop to the training or competition. Chronic pain is causing depression, anxiety, and long-term effects. It is affecting the psychology of the athlete. Yeah, so how is this interfering in the athlete's life? Diet alteration. Food is everything. Food is so important for the athlete. And how is the athlete going to chew properly if the teeth are not in a good condition? So this will lead to improper nutrition, sleep disturbances because of pain, self-medication, very, very dangerous, and inability to train hard and loss of confidence. And we as dentists know that the dental pain doesn't go away on its own. The tooth has to be treated. Again, I would like to highlight one part about the self-medication is there are certain drugs that are being banned by the World Anti-Doping Agency, like for example, tramadol. So we all know that which drug, which is the go-to drug for severe dental pain, drugs like tramadol. But if it is banned, and if the dentist is prescribing that kind of a drug to the athlete, the dentist and the patient, athlete patient, all of them are going to land up in trouble if that athlete, undergoes a anti-doping test, right? Dry mouth and other oral infections. So these athletes, they have a lot of hyposalivation and common dry mouth syndrome. So what are the common dry mouth complaints in these athletes? Thick stringy saliva, halitosis, cervical caries, periodontal disease. And because of these dry mouth complaints, what can happen? It can lead to opportunistic infections like oral candidiasis, mucosal aphthy, fissured tongue, stomach. The list is endless in terms of bacterial and viral infections. Of course, chronic infections now are already, so much studies have been conducted, which have already proven that periodontal disease is definitely associated with heart disease, cerebrovascular disease, respiratory disease, and also preterm births. Now, also interesting findings are that in athletes where there is an injured Achilles tendon, the inflammation worsens, it increases the healing time, and it affects the training and performance. If this problem is there, if the problem of recurring Achilles tendinosis is there, consider that some chronic gum infection is there. So it is the duty of the sports dentist to ask these kind of questions to the athlete. And one, of course, very, very important as to how the oral health is affecting is the dental occlusion. See, now these are examples of how malocclusion can result in impaired athletic performance. First and most important is podal pressure. So this is a computerized image where you will see that 80% of the cases reveal that bad bite will lead to unequal post distribution. So I'm sure if Dr. Sanyogita Akshar, she's seeing this, so they will definitely agree when they are taking the T scans of the patients. If there are unequal bite, or the bite is heavy on one side, also bite related problems are there, it is definitely going going to muscle spasms, TMJ problems, and all these things are going to affect the athlete's back, neck. And because of all this, somewhere the injuries are going to happen to the athlete. So correcting, how to correct this, wearing corrective dental trays or customized mouth guards are going to improve the symmetry in the patient. It will help to improve the running pattern in the patient, reduce the chances of injury. Then respiration. So orthodontists sitting or pediatric dentists, they know that, studies reveal that flat long facial types, incompetent lips, what they cause: fatigue, insomnia, cold, allergies. All this is going to affect the performance of the athlete. Of course, biggest part is dental injuries. 5 million teeth are lost in sports in each year. 33% athlete has a 33% of chance of sustaining a dental injury in sports. But as dentists, do we realize that there is not just physical impact, there is a lot of psychosocial impact, especially if facial injuries are involved. So it can lead to depression, anxiety, loss of self-confidence and image, reduced self-esteem. So there can be poor intervention and poor rehabilitation of these kind of athletes. So it is our duty. See, whenever the athlete patient gets injured, you are not, as a sports dentist, you're not just supposed to look at the dental and the facial injuries and treat them. PTSD is real, guys. PTSD is real, and it is very important for you to work, help the athlete along with the team of the sports physician, the athlete coaches, parents, for helping the athlete come out of this kind of psychosocial impact. See, these are the situations. These are very small injuries that you see. I have put excuse me. I have put examples of very simple patients here. But even if this injury is that small, even if it is at least class 1, class 2, the kids are refusing to go into school. That is the level of consciousness that they have. This kind of scaling. So actually, I will tell you, the appointment of scaling is extremely important, because that is the appointment where you motivate the athlete for proper oral hygiene. You can see this is like an oral care kit. Like how, if the athletes are going for tournaments, you have to explain them that baki so jo tumhara medical kit, this kit, that kit that they are carrying, they have to carry an oral care kit and a first aid kit. Now in the right side image, there are 3 types of mouth guards. You have to have samples of mouth guards. You have to explain them all these things. Yes, so one very actual live example of how oral health is affecting the performance. Few years back, I met a female national hockey player. She shared her story. Some days before a national event, she had a tooth problem which she ignored. One day before the final match, the tooth developed severe pain and swelling. She took medicines, but it did not completely stop. And we know how it pains, and that is why her concentration, her performance got affected that day. And to the day she repents, and I really wish I would have taken an audio or a visual of her at that time, but it did not strike me at that time. So the point to conclude here, the only solution now is preventive dental screening and timely dental treatments of all these athletes. So basically, the carry home message here is, the mouth is the mirror of the body. An athlete with a healthy mouth can eat a wide variety of food without discomfort, communicate well with their peers, concentrate well on the field, and can practice the sport of his or her choice without disruption. Sports in India are on a rapid rise in the 21st century. Our athletes need dental care and trauma prevention to give them a competitive edge. So what should we do as dentists? Dental groups and associations in India, along with sports bodies at various levels, they must include sports dental care or sports dentistry, not just to improve the oral health, but for the overall health of the athlete. So what is sports dentistry? It's not just about oral care and mouth guards, diet modification, substance abuse, customized boil and bite mouth guard programs, injury prevention programs, and of course, emergency and long-term management. See, these are all the various topics, sports related topics, dental related topics that the dentist must know if you want to practice sports dentistry. See, these are the main roles. I'll just talk about each one in detail. Oral care, mouth guards, modification in diet, and dentofacial injury management. Additional roles: referral to the proper medical personnel, recognition of doping, recognition of tobacco, substance abuse, health assessment of athletes, special need athletes. The list is endless. I can just go on talking the whole day, but we have some time restriction. Yeah, so dental checkups, why they are important? Because you have to identify which patients are at increased risk of dental trauma. The dental and sports history helps decide risk factors for dental injury. And when has to the pre-season dental examination, whenever the pre-season physical examination is there, that is the correct time for us to get a pre-season dental examination done. Type of mouth guards. Now the mouth guards are mainly of three types: over the counter, which we are completely the dentist will not recommend; boil and bite guard, yes, to some extent they are good, and custom made mouth guards are the ideal. Now it is our duty to explain to the athletes and the coaches the type of mouth guards, why it is important for them to wear, recommend a mouth guard according to the athlete's age, dental issue, and fabricate the mouth guard and give instructions for care. Now, this is a small comparison. Stock mouth guards, they have no individual fitting, not recommended. Boil and bite mouth guards, individual fitting is attempted, but they don't fit properly. So the best ones are custom made mouth guards. They are fabricated under the proper guidance of a dentist. They are either made in the dental clinic or sent by the dentist to the lab with proper guidelines. Now, the biggest catch here is the advantage. The athlete will come to tell you, barabar baith nahi raha hai, main baat nahi kar sakta, I cannot breathe. So this is where you have to tell them that custom fabricated mein you can talk properly, it will fit properly, you will not have any interference in breathing. So who can become a sports dentist? Dentist of all specialties can become a sports dentist, including the general dentist, as all types of dental treatments are needed for the athlete. So whether it is a pedodontist or an orthodontist, oral surgeon or a prosthodontist, endodontist, periodontist, community dentist, and general dentist, anyone can become a sports dentist. Irrespective of whichever specialty, what benefits does the dentist have? So just like you are going for dental camps for regular patients, this is a very customized client that you are going to get. Go and visit various sports clubs. But what you have to tell them, for that you need to understand sports dentistry. So what will happen because of that? Additional athlete clients and related people to the dental clinic. Revenue generation through mouthguard fabrications and general dental treatments. Opportunity to associate with various schools, colleges, and sports club as a sports dentist, and a very good marketing of yourself and your clinic. Thus, any dentist interested in becoming a sports dentist must know the ways by which the dentist can intervene to improve the oral and general health, and indirectly thereby helping in improve the athlete performance. So we as dentists, we have to believe that the presence of dentist in the athlete support healthcare staff is of paramount importance. Only then we will be able to convince other people. So for this, the topic of sports dental care needs large scale awareness, so that not just the dentists but the athletes and the sports healthcare professionals, everyone realizes the importance of neglected, and believe me, it is a neglected oral health of the athlete. And this is, I would further even strongly say, the missing link for their better health and performance. So I'll just quickly, Sonal, I have, I think, 5 minutes left. I'll just quickly go. Yeah.
3 minutes, 3 minutes.
Okay. So I'll just quickly go through the master's program and the National Sports Dentistry Committee. Few slides are there. So master's program, it's a 12 months hybrid program, and I will talk about details of faculty. I am the head faculty. Then there are subject faculty, subject specific for sports science modules, and we have guest faculty for various sports dentistry and sports science lectures. So we are following international guidelines, national and international standardized guidelines, and there are 50 hours of online training. So you can just imagine all those ladies who are taking courses here. You can just understand what amount of efforts and a lot of mehnat has gone into this, because to curate this kind of courses, it become really tough, what all to include, what all to not. So 25 hours of sports dentistry, 25 hours of sports sciences. Then online sessions, extensive sessions are available on all sports aspects. Few online workshops are there. Then exhaustive offline programs is there. Hands-on is there. On-field training is there for dental screenings, basic first aid, face-to-face meeting with the experts. So many things are there. So total, it's a 600 marks. Okay, so it's not, you have to be really serious about sports dentistry. So we are not just taking any course. It's a 400 marks MCQ exams and 200 marks of practical exams. So that's about the course. So anyone interested, you can just let me know. And now that was the course part. Now the another important part, course to ho gaya, pad liya, but what next? Okay, so what next? इसके लिए हमने ये launch किया है National Sports Dentistry Committee. So of course we are taking members who are already done the course and not done the course. It's a mix of everyone, because we want people, we want dentists to understand what is sports dentistry. So this is our core team, myself, Dr. Aditya Sontakit, who is the secretary, and Dr. Riti, who is the treasurer. So this is our mission and vision, mainly to, because our parent body is Indian Society of Sports and Exercise Medicine, which is a registered national body, to conduct activities in sync with their objectives. Basically, to main aim is integrate sports dentistry and into sports medicine, to create awareness at local level, at national level, and to have team dentists at all the levels, and make sports dentistry a nationally recognized branch. So there are various membership benefits. We are going to have a lot of various programs, conferences, symposiums, discounted rates for all educational events, and we want NSDC to have state-wise chapters, regional committees. We want you to become our members and conduct NSDC programs in your states, and we will give you visibility on our social media platforms, on our newsletter, and we will guide you for sports dentistry as a career. So these are just few glimpses. We had an online inauguration on 3rd December 2023, where again my dream came true, where Dr. Steve Mills, who is one of the most senior sports dentists in USA, he spoke on sports dentistry and overview of 30 years. Dr. Shobha Tandon, everyone knows she was a chief guest, and Dr. Kiran Kulkarni was a very senior sports medicine physician who was also our guest. So last 2 years, we have been conducting quite a few programs, local level programs, I would say. So we have curated these NSDC ambassador t-shirts that you will see here, and we conduct activities for athletes. And I'm very proud to say that now we have started conducting state level events across Pune and outside also. So we would love all of you to connect with us and join in this movement of doing sports dentistry and helping the athletes reach their level best. So we also conducted a unique event called Sports Dentistry and Sports Science Conclave, where we actually had panel discussion, and there was an NSDC brochure inauguration done by the special guest. So it was a wonderful event where, all the sports dentistry and sports science people, all of them discussed and collaborated on various things. So I think I have just spoken what are the benefits of becoming. So a lot of people ask me the question, job ka kya? So job isme nahi hai. It's not for job that we are doing. This is an additional to what already you are practicing in your clinic. Till the meantime, जब government करेगा job तब का तब देख लेंगे. Right now, you work as a consultant sports dentist in various sports clubs, academy, schools. See, you have to understand that team dentist is needed in our country very, very badly. Local city level, district level, state level, national level, international level, at all levels. So there is so much work. There is so many athletes are there. There are so many sports organizations are there. Various events are happening throughout the world. Keep a track of these events. Of course, a lot of depends on funding decision by our authorities. Keep in contact with the sports medicine team of these organizations. Be ready to volunteer. This field is very dynamic and interesting. आपको clinic में बैठे-बैठे patient नहीं मिलेंगे. So if you are interested in doing some experimenting, then this field is for you. Become part of dental care at the Olympics. So these are so many statistics. So I'll start telling about the statistics as to क्या क्या हो रहा है Olympic events में, it will take me and 1 hour. But in just one slide, I have put that day by day dental treatments are increasing, and you can imagine 2016 8-chair dental clinic was there at the Olympic Village. So dentist scope is increasing, and it is our duty to understand this and become a part of it. So we in NSDC, we conduct programs like NSDC ambassador program every 2 to 3 months. We do athlete dental screening programs. So ambassador program is eligible for dentists. Volunteer program, we conduct these programs for athletes, coaches, parents, sports medicine professionals. We have a quarterly or maybe a 6 monthly newsletter. We conduct research and publish articles. There are webinars, symposiums, conferences, so many other things happening. So in the end, I would like to conclude with the last slide by saying that let's work together for the betterment of the athlete oral health and performance. Let's be a part of the sports medicine team and uplift the subject of sports dentistry in India. Now, next, our upcoming, there is a free webinar about the master's program on 10th March at 8 p.m. And the next online NSDC ambassador program is happening on 23rd March, which is a Sunday. So anyone, if you're interested, you can just get down my number, and it's a request that, please, all of you, please join our bandwagon, and it's a very interesting and dynamic subject. And thank you, Dr. Sonal, for inviting me for this program.
Thank you, Dr. Sneha. And it's a very different topic that you have brushed across with, because ultimately, at the end of the day, even you, if you are not an athlete and your child is into any kind of sports, they need to have the awareness that they need to be taking care of their dentition and as well as their surrounding structure, because TMJ injuries are most common at
Very,
that
very
age.
common. Yeah.
So thank you so much for enlightening us. Can you just switch off the share screen mode, ma'am?
Yes, 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 yes. Yeah. Stop share.
Yeah. And what is it that you would like to tell your younger self? That question I'm asking everybody. So what is it that you would like to say in one sentence if you have to sum up what it?
Yeah, the most important that go for it and don't wait for people to do things for you. You just do it yourself.
Yeah, lovely. Thank you so much, Doctor. Thanks for being a part of this Congress. Thank you so much.
Yes,
And with
yes,
that, I
thanks.
would like to welcome our next speaker, Dr. Akruti Choksi. Dr. Akruti, you're there? Can you
Yes,
switch on your
hi.
camera, mic, please? Yeah, you're there. So smile for the camera first, Akruti. Okay. And Dr. Akruti, this whole session, what I have kept, it's a different topic altogether, but because she being a dental student, practicing dentist, but then she changed her gears and now she is providing dental care for the horses. Something really different. This was the first time I heard that veterinary sciences have a specialist dentist, and that too such a beautiful specialist dentist among them. So thank you so much for enlightening us, and I'm sure the lecture would definitely bring about a different perspective and a career option for dental dentist at par. So please start with your screen share, and Dr. Akruti, I will let her only talk about herself. She's going to be talking about from the horse's mouth. That's her topic. So let's understand and dwell what she and understand and what she does and how her life has set. So
Thank you so much, Dr. Sonal. Can you see my PPT?
yes, please go
Okay,
ahead.
great. Okay, great. Okay, so thank you so much, everyone, for being here. I would really like to thank Dr. Sonal for this opportunity. I am Dr. Akruti Choksi Kapadia. I am, a dentist by profession, technically, but I also am an equine dental technician. And I'm really, really grateful to be able to share my story alongside these amazing women that I've heard in the last few hours. Thank you so much to the International Pink Dental Congress of 2025. Here I have provided my, Instagram ID in case anyone wants to get in touch with me, and I'll just move forward with my presentation. I'm sorry, I'm a little nervous. I'm just, it's the first time presenting with dentists, and it's a lot of stuff that I really miss, and I have kind
Akruti,
of,
in fact, we want to learn from you, so don't be nervous. Okay,
yeah,
we are
thank
the
you so
one
much.
who are looking up to this thing presentation. Take care, dear. Yeah, don't
Thank you
worry.
so much. Thank you so much. Okay, so I am technically India's first equine dental technician. Nobody in this country has done this or learned this before I did. I started dentistry about 18 years ago, and a couple of years after that, I went and learned equine dentistry from New Zealand. So I've been working for now 16 years. Right now, I am consulting at all major racecourses in India. I work with all the top trainers of racing. I'm working with all the top polo teams right now, all the national and international level eventing horses. I also I consult with the police and the Indian Army at times, because this sort of education is not very common in India. So I'm called from time to time even to help our military services. My practice has now spread all over South Asia. Through equine dentistry, I thought it was a little hatke, but I did something called telepathic animal communication. So, it's this thing of how you can telepathically communicate with animals, because my patients can't tell me what they want or what they're feeling. So, it's my job to figure out what they need. I also do a little bit of energy work with humans and animals. So, enough about me. But about my career, but maybe I can start with where this all started. So, as you can see here, these are some of my core memories. I think, I remember the first thing that I can remember if people ask me why do you work with animals is
I think my dad put me on a horse for the first time when I was a year old. Her name was Shena, and she was a tiny little horse. And I was very scared of the big horses, so he put me on this really cute gray pony that I used to love her. So that's my first experience with horses and horse riding and whatever. Through my dad, I think I have really, kind of understood and learned the love for animals. I remember when, bachpan mein, when we were small, I remember my father saw an elephant on the road, and usually you see some begging elephants that ask for alms on the road. So instead of paying the mahout, my father actually stopped the elephant mahout and said that, I need to feed your elephant. So we found a fruit seller close by, and he literally said, whatever the elephant picks up from the fruit seller, we will pay for. And soon, fair enough, the entire road got crowded because everybody loved feeding the elephant, and everybody passing by stopped and started feeding bananas and apples and watermelons to the elephant. So this is how exciting my life was. Once my parents decided that they had found these, they had read about these rescued leopard cubs, orphan leopard cubs by a forest officer. So I remember my dad driving me in the early hours of, a Saturday or something towards Chembur, and he said, let's go see some leopard cubs. And it was like the biggest surprise for us. And we were just so interested, in wildlife and animals and all that. It was just ingrained in us. um, you know Also, I mean, I've had great opportunities, as you can see here, to kind of interact with wildlife, whether it be in Chitwan jungle, which is in Nepal. Like here you can see the rhinos on top of the elephants we're all sitting. We've seen tons of things all over the world, and I think that has made us really understand the importance of animals, nature, and what we human beings need to do to give back to animals and nature in general. So it's safe to say that I loved animals from day one of my life, I think. Well, talking about following stereotypes, I think my parents and I did kind of follow the stereotype where, all Indian families like the fact that bachcho ko doctor, lawyer, engineer banana hai. And that's, at least back then when I was getting into dental school, that was the concept of my parents. They said, this is an apt career for a girl, and, you will be able to handle your family life as well as your career. So, I mean, quite stereotypically, today I am a dentist and my brother is an engineer. But I think even that has kind of helped me, and even that worked in my favor rather than against me. So, as when I was a dental student, I think I was pretty average. I was not great or anything, but I really liked working with my hands. So I really liked carvings. I really liked fillings, cavities. All of that really interests me. All the practical work really, really interested me. The theory work not so much, but it kind of I compensated with the practical. But also I remember that during my time as a dental student, I was very clear that I had to do what I'm doing because that's important. Education is important, but I also had to live my life happily, and I had to also give back or do things that were good for my soul. So I remember doing complete crazy rescue ops when I was in second, third year of dental school, rescuing ponies from those tangawalas and all that, and rescuing rabbits from the road and all of that. There's a lot of stuff. I'm not going to go into detail, but I did all of this while I was doing dental school. And I also did dedicate a lot of my time, free time, in spending it with underprivileged children or children with who are differently abled. So it always gave me like a balance in life. So I was studying, but I was also doing things I really, really like to do. So I mean, life went forward like that, and I did start my career, and I did start working in dental clinics, and I got really good at what I did in my dental clinics, and I enjoyed it. But there was this feeling of something is missing in my life. Something is not complete. Like my heart is looking for something else. Uh, so I would say that that's when I think I was very lucky that also in dental school I met my mentor, and I met my faith through a friend, faith in Nichiren Daishonin's Buddhism. This quote that you see here: "Dig beneath your feet, there you will find spring," by Dr. Daisaku Keida. I think for me, it really meant that, I am here for a reason, but I need to continue one step forward to be able to understand what is my true unique mission in life. What is it that I really want to do? Um, So I must say that my parents were very, very, although stereotypical, were very, very also encouraging. And, I remember my family took a very bold step at that time of taking a big loan to send me to New Zealand, because it was the time of the economic recession that year. And I luckily was the only student that ended up going to New Zealand from all over the world, because a lot of students from different parts of the world cancelled that time, because it was such a difficult time for everybody. So I will always be grateful for that. And they supported this crazy decision, not knowing job milega ki nahi, is there anything in the future or not. And a lot of people telling me before doing this that it's not really going to work. I mean, people in India don't care about their own teeth. How are they going to care about horse teeth? That's not going to work at all. So fair enough. I said, chalo, at least try to karenge. If nothing else, I do have my BDS degree to back up on. So when I reached New Zealand, I thought, how hard can this be? It's going to be easy breezy. It's going to be like, okay, I mean, dentistry and horses. I mean, what's there not to love? Well, I was in for a very rude shock. I entered New Zealand and I realized that it's really very, very, very cold. And it was actually the coldest winter in 10 years that they had faced. So it was not working in a comfortable, cozy clinic environment. It was out working in the rain and the cold, in the sun, whatever it may be. We had to go out and work. So it's a really funny story. So I keep telling people that, I mean, I went thinking this is a cakewalk. I'm sure it's going to be a lot of fun and horses, yay. But in India, we're used to seeing horses with, a ghodawala, a groom that stands with the horse. And, it's kind of a safe environment because you feel like he's in control of the horse, so you're kind of safe. But in New Zealand, it's a whole nother deal. If I had to do dental work for horses, I had to catch them from two paddocks, which is like 1 kilometer far away, in the cold, in the rain, and bring them to that place, get their dental work done, and then go drop them back. So it was a lot of hard work. And especially this first time, I remember my teacher said, okay, actually, why don't you get inside and palpate the TMJ of the horse and check the teeth and fill out the dental chart. I literally wanted to cry and run back home because I said, boss, this horse is way bigger than I am. I'm a pretty tall person. I'm 5'8" almost. I couldn't even reach the TMJ of that horse. This is not that horse, but it was almost as similar as this height. So I remember Warwick, my teacher, telling me, Akshuri, get in there and just get it done. Like, I don't want any excuses. So I think that was a big lesson that he taught me. There are many times in my life that I don't want to do things and things are very, very tough. And those words always come back to me. And, I just tell myself, get in there and just get it done. Like, no excuses. So that's how I started. When I came back to India, obviously, I think people were perplexed. And the single most annoying question I was asked was, why equine dentistry? You're a girl. Why do you want to work with horses? This is a man's industry. You're not meant to be here. Why don't you open a small animal dental clinic and, do cats and dogs? Because, that will be easier for you. It used to annoy me to hell when people used to talk like that. But so today I will give a technical reason as to first why I chose equine dentistry and why it's different from everything else. So here you can see on the right side a brachydont teeth, which is our teeth, human teeth, the crown and the root, the way it is placed, enamel, dentine pulp, cementum at the bottom, simple as that. A hypsodont tooth is very different. They have a very large, reserve crown. This is what you see above the gum. So this is the occlusal bit right here, and this is what you see above the gum. Uh, the root is way down here. So meaning that is what the difference between horse teeth and our teeth is that horses' teeth erupt their whole life. So my job is to shape and manage them so that they can eat better, they can, feel better. We just heard Dr. Sneha's amazing lecture on athletes and how it's so important for their dental work. And I really feel her because what she said was so apt. This is what I do on a day-to-day basis because my patients are also athletes mostly. Here you can see the difference in, on the left, you can see this is a milk teeth, first cheek tooth milk teeth of a horse, of a 2.5, almost 3-year-old horse. You can see the dark colors here, that is the secondary dentine. And around that, you can see layers where you can see dentine, you can see like ribbons of enamel, and also then all this yellowish stuff that is called cementum. So this is how morphologically their teeth are different than ours. Also, because horses are athletes, they riders are riding these horses, or jockeys are riding these horses, or polo players are riding these horses. So what happens is, this is a bit in their mouth, right? They have a bit in their mouth which is connected to the reins, which is there in the jockeys or the riders' hands, right? So my job is to, I'll show you the next slide here so you can see clearly. So you can see here how, this is how, the apparatus is on the face, and this is how you can see on the skeletal, how, how the bit is right there. So my job is to actually shape teeth and create a comfortable mouth so that the horse can actually understand what the rider is trying to ask of him or get from him. So this is something that people have often missed in India, where they have not invested enough money in knowing what is actually the dental problems of India and of horses, but they have actually invested in really harsh gear and stuff that is also very cruel to horses. So my job is to make their mouth comfortable and make it easy for the horse and the rider to function, and for them to focus on the performance rather than focus on the pain. um, well, this is all the technical bit. So why I did dentistry, why I did equine dentistry is very simple. They told me that I couldn't do it. That's why I did it. So I would like to share one small story here without boring everybody. But I didn't know anybody in India when I started with equine dentistry. I just came back thinking, "Abhi kuch to karna padega. Kaise karungi?" I had no clue. I had heard of one particular person who had horses, so I called Just Dial and said, "Oh, so and so has race horses. Would you be able to give me his stud farm number or something, or email ID?" So that lady on the phone said, "There are also other stud farms. Would you like some numbers?" And I got some 20 odd plus numbers from her and email IDs, and that's where I literally started from scratch, sending people my CVs, and figuring out how will someone call me to just maybe showcase, so I can showcase my work and tell them what I do. So the one very famous person that most people know of, that is the person whose racing manager called me, and actually he said that we don't need you, but he put me on to India's top racing trainer. He's the best trainer in the whole country. And so I said, great, okay, this is fantastic. And that the person that I spoke to, the trainer, he said, why don't you come to Pune and show me what you can do? So it was like a little test of, he's going to check what I can do and what I'm talking about, and if I even have some actual experience in horse dentistry. So I went to Pune. I think I remember still, it was 4 a.m. in the morning. I'd driven by myself. Like, I think every step was just hard. Like everything was things I had never done in my life. um, Long story short, I reached Pune in this foreign environment, working only with people, men. Obviously, there were no women inside. There was a place where they took me to the horse, and I could see the horse is completely cuckoo. He's under a lot of stress. He was very agitated. There were 5-6 men holding him, holding his ears, holding his bit really hard, and holding his skin and all of that. And this is not how I was taught to work in New Zealand. Warwick taught me how to work in a very, very calm and compassionate manner. The way he would talk about equine dentistry is very similar to what I feel about pediatric dentistry. So you have to be able to win the trust of that little child that walks into your clinic. You can't make him scream and cry on the first time that he's there on your dental chair. So this is the logic that I applied from dentistry into equine dentistry. And obviously the men didn't like it when I told them to politely step out of the stables. They were like, who the hell does she think she is? And she doesn't know what she's talking about. This horse is crazy and blah blah whatever. And I did what Warwick taught me to do. I calmly sort of did my work and figured out what was the problem, and I told the trainer that this is the issue. And obviously everybody was amazed at what I could do without manhandling a horse. So I think what this taught me was the only way to, like, we win the trust of that child that walks into a pediatric clinic. The only way that I could win trust of a horse is through calm, sincere effort, for him to think I'm a friend, I'm not here to hurt him. Also, actually, this is the only way that has helped me to work in my industry with all grades of men, in terms of like the guy who's holding the horse at the bottom of the thing, to right to the top, where the top trainers or the owners of the horses, they were really amazed at how working quietly, softly, gently, was actually the way to go. So although in India people think that horses is like a man-oriented industry, all over the world it's actually a woman-oriented industry. And our superpower is that we're women and we're gentler and calmer and softer, and it works great with horses. So I mean, I had it inbuilt in me. But I also feel that as a woman, I had to really show my mettle to not only the guy that's holding the horse, but right to the top, to the trainer, to the owner, because it was a test at every point. It all worked out great, and now I am treated like an equal, so it's all good. Um, I'll go on to the next slide. So, a very important aspect of my faith, that is Buddhism, is happiness for oneself and happiness for others. So, I also feel that yes, it's absolutely important for me to advance my career and do my best as an equine dentist, and be really successful. But I also feel it's very, very important for me to give back. So right from the get go, along with working on my clientele and working on my career, I have worked side by side on things like working with the working equines of India that have literally um, you know uh, no source of health benefits, or any sort of veterinary care, any sort of hoof care or dental care at all. So this is me and Warwick right here working with Brook India. Brook India is actually associated with Brook all over the world, which is a massive organization working for benefit of working equines in different countries. This is a part of that team where it was 17 of us gallivanting all over remote parts of India, teaching the local veterinarians as well as veterinary students what we do, so that somewhere people can imbibe and learn different things. Here we're at Mahabaleshwar. We are all, this is a bunch of equine, this is the dean of the veterinary college. These are a whole bunch of students and obviously professors and also other local vets. We'd conducted camps for horses here where we had done the dental, the farriery, and the entire veterinary check for these horses. About 800 horses were treated here. So I think that need for awareness is very, very, very crucial. I think somewhere that is missing in this country. Even after 16 years, I feel that I'm still not even at the tip of the iceberg. Like there's a lot more to go. um, I feel that education and collaborating with veterinary colleges is the way for the future. It's very important that we really understand that equine dentistry is not taught in India at all. It's basically one chapter and two paragraph in a book that says, okay, you should do equine dentistry, but how and what is completely foreign to people. So here, you can see me. I'm with some army vets who are learning how to do things, the way internationally it's done. I'm here with a whole bunch of rural vets from India, from Maharashtra, talking about dental work and what its impact has been. This is me in the south. We are together with WVS, which is a very famous organization for training for veterinarians. I've taken a couple of lectures for them and shown them dental work, and I think it's really amazing because the newer generation that's coming in is very, very keen on knowing different things and learning newer things. So that's really encouraging and promising for the future. So I truly believe that let the beauty of what you love be the what you do. This is a quote by Rumi. And in my case, it's been very simple. I wake up in the morning thinking, yay, Monday morning, even after if I have to catch a flight at 6 a.m. and go to some really remote place in India, wake up at 3 o'clock in the morning. What keeps me going is that I'm so grateful that I'm working with these unicorns on a daily basis, and I wouldn't have had it any other way in my life if I had an option. So obviously, I do get to have a lot of fun. I mean, I drive tractors around Punjab. I gallivant on polo ponies in Thailand. I'm driving a buggy here that a client had in the middle of Maharashtra somewhere. Like horses have given me everything in life. Along the way, they also gave me my Prince Charming right here. We're in Iceland riding horses, Icelandic horses. He literally came to me galloping on a white horse. We have a white horse, and she really likes to gallop a lot. She's taken him and flown off thousands of times, and he's been in the hospital so many times for it. So yeah, like I mean, I think wishes really come true, and you never know. Like there's always magic around. So another thing. Okay, so I would like to share a little bit of the impact, not from my words, because I've spoken a lot, maybe from some of my clients and well-wishers. I'm going to just play this video now.
In my experience, I believe that dentistry plays a very important role in this.
Kruti, could you
She's
just
done a
say
wonderful
what
job. She's in
saying?
fact, sorted out some horses which I was facing a lot of
Can you hear it?
difficulties while I was playing, especially on turning on either side.
This one is
And then we understood about what the issues was, and she made me understand. And after that, she did some special work on those horses' teeth. And today they are one of my best horses, and I'm really enjoying them and playing them. And they're really, really special horses now for me. So I'm really grateful to Dr. Akriti for getting into this and making me understand. And I think as a horse lover, the dentistry is a very, very important part which we don't pay attention, which we should.
I have known Dr. Akriti for 15 years. She has done a brilliant job as far as the dental work is concerned in all the breeds in India. And plus, she's gone abroad also to do some work about dentistry. She had brought a Kiwi team also back-to-back 2 years to spread the awareness of equine health, hoof care, and other managemental aspects. And in that, there are a lot of students also who got to learn a lot of things from her.
For over 30 years, as a trainer of sport horses competing at a high international level, I've seen firsthand how vital proper equine dentistry is. And not just routine maintenance, but specialized care that addresses imbalances in the jaw and the TMJ. I've seen many issues that once were thought to be training issues, but they've completely resolved themselves after proper dental equilibrations. When I moved back to India about 10 years ago, I was incredibly fortunate to find Dr. Akriti, who provides this level of specialized care for my clients' horses.
So moving on, sorry. So I think moving on, I would really like to say that, like everyone here is sharing, all the women that I've heard so far, it's so important to mention that all the people that support you in your journey, yes, it's tough being a woman in a man's world, but it's also a lot of good men that have, professionally really helped me out and, really understood what my, skill is and what my talent is. I was supported by like amazing parents who have always been my cheerleaders. Sometimes they would double up as translators in my NGO work. Sometimes they would double up as my drivers from here to there all over the country. My brother, who's an engineer, is now my technical team because it's very, very expensive for me to get my equipment sorted at times because everything is only available abroad. Nothing is available in India. So I'm very lucky to have him. My husband now, who is my logistics team, who is always tagging along with me in these remotest parts of the world to check horses, and it's just fun when he's around, and he's like my biggest cheerleader. And I would like to say that my learnings in life have been very simple. There are no shortcuts to success, but there is always a little bit of magic that happens when you put in that hard work. Gratitude and ethics go a long way in life. You have to have some fun along the way, otherwise there's just no point. So thank you so much.
Thank you so much, Dr. Akruti. And you must visit the chat box because I am amazed by the comments also. Because when I heard about you, I was equally awed by the whole concept. And congratulations on doing such a wonderful job. And before you say what the questions, before you answer, I would say that you are already an inspiration to everybody who would want to have a different profession altogether along with dentistry. So, is there any person who inspired you other than your parents and the family that you mentioned?
I think it's my mentor. I think because in Buddhism, I was very early on. By 18, I knew in life that this is what I mean. My mentor was very clear that there's no boundaries. There's no impossible. Everything is possible. You just have to put your mind and heart to it, and it's possible. That's all. Yeah.
A petite looking female who is handling pounds and pounds of, I mean, kgs, I think a ton, the way of
500
the,
horses,
yeah, yeah. So you're handling that kind of a beast. Congratulations, dear. And it is a privilege to know you, know of you, and what you do. So keep doing the good work. And I'm sure you have inspired many of us to look into a different aspect of life, because yes, as you said, animals cannot speak. So when you can have a telepathic connection with them, I'm sure you will develop much more telepathic connection with humans also than in that situation. Thank you so much for gracing us with your presence, doctor. And on that note, please visit the chat box, Akruti, because you will be amazed by the comments that have come for you. Yeah, and I would like to welcome Dr. Vaishali Das, ma'am. Dr. Vaishali, ma'am, unmute yourself.
Good afternoon, everyone.
Good afternoon. Ma'am, smile for the camera. We missed the photo yesterday, so I will take the photo today. Ma'am, okay, you've started sharing the screen. No problem. Later I'll take the photo.
Okay, no problem.
So, Dr. Vaishali Das, ma'am, needs no introduction because she's been the jury for the past 2 years for the paper presentation. We all know her as the art lady, like the one who brought grace and beauty and elegance to dentistry with her orthodontics, and she's the founder and CEO of Orthodontics. Today, she's going to be talking about her second. She always has a set of priorities in her life. That's what I have known. And clinic priority, she treats it like a child. So she's going to be talking about her child now, that is navigating complexities in minor oral surgeries. But before that, madam, thank you for being a part of International Pink Dental Congress second year around, and welcome to the forum. And the stage is all yours. Please go ahead, ma'am. Your slides are visible.
Thank you so much, Dr. Sonal. And at the onset, let me thank International Pink Dental Congress for considering me second time in a row for being speaker and jury both. And Dr. Sonal, again, for interesting me. She's like my child. She's my student from DYP. And we have lots in common also. So it has been really amazing, the talk by Dr. Akruti. It was too good, too good. I wish I had known about it earlier. I love animals and I would have really gone to that. So if there are any complexities, I'll come to navigate them, Dr. Akruti. Learn it and then navigate. So we are navigating complexities in minor oral surgery. It's a very, very vast topic. I'll just try to pick up a few things that we can do in day-to-day basis at maybe undergraduate level or at times on the postgraduate level also. You can call in and ask people. So what happens, let us just talk about something very basic. When you talk about hi-fi things, the essence just goes away. So let us talk only about the basic. What happens when you fall into some unexpected challenges? In very simple cases, you think you take up a case and I'm going to finish off this case in 5 minutes. That might take around 5 months for you to navigate a particular case. First thing that you are supposed to do is do not panic. Okay? Do not panic. One of the most simple things that comes on a day-to-day, I wouldn't say day-to-day basis because now there's so many antibiotics have come up and things are really better now comparatively. But then what happens? Dry socket. It could be on your end if your sterilization assessment is not good. I'm not going to go into the theoretical aspect of dry socket or any of the complexity. I'm just going to talk about how to handle those things. First of all, let your sterilization be excellent. Okay? Acceptance is very important. Chalta hai, hota hai, attitude does not work in oral surgery. So now what happens? How do you all know, but this is for young kids that I would like to tell that you see bare bone over there, foul smelling, third, fourth day of the extraction, and the patient is in excruciating pain. Don't tell the patient, yeah, everything will be all right, everything is fine. The patient will lose trust. What do? You irrigate the socket. You know the socket is not forming. The tissue is not granulating over there. So please inject the patient and cure it out. Try to instigate fresh bleeding. Is what we used to do once upon a time. I still do at times, but not always. You get this dry socket paste, ready-made dry socket paste from Siraj Merchants in Bombay. I am sure you must be getting this in other cities as well. And our age-old thing of zinc oxide and eugenol packed with some sterile cotton fibrils in it, along with some dry socket paste. Pack it into the socket, okay, and leave it there for 4-5 days. Now, don't make that pack very big also. Don't make it very small that it will swim. It should just snugly hold over there. I don't want too much of mechanical obstruction over there, okay? So you put that pack, change it after 4-5 days. Maybe 2 set of packs should be more than enough. I'm going a bit fast with the complication because we are already 3 minutes into it and I have finished only one complication, okay? So this is the hematoma which occurs in a very simple case, just a lateral incisor, maybe anything, maybe a molar, and you land up with a hematoma like this. What do? You first remove the hematoma, okay? Curate, again you have to inject, curate out the socket. Why does this hematoma form at all? There must be some ooze over there and it has to be a very, very slow ooze. So what happens? Our clotting time is around 2 to 4 minutes, right? So the ooze is happening and then by the time it is coming down, it is clotting. And then that kind of makes a liver clot. It is called as a liver clot. It looks like liver. So what do? You inject, remove this clot, curate out the socket again. Don't be scared that it will start bleeding more. You curate out the socket and then suture up the wound by placing Abgel, which is a hemostatic agent. If you don't have Abgel, you can put Botroclot, just hold it there for 5 minutes. And then you have to suture the wound. That is very important so that any small capillaries which have been ruptured, because here you can appreciate the redness, the erythema, okay? That will also close with the help of suturing. Another problem is the massive bleed that can happen. This is quite less. I have seen much more bleeds like this. Now, let me tell you one more thing. All these pictures I have picked up from the internet. Okay, because when the patient is in any complex situation, I can't tell the patient, hold, let me shoot a picture for you. I find it very cruel to do such a thing. So all these pictures are from the internet, but day-to-day basis, or maybe once in a while, you definitely come across these complications in simple minor oral surgery. So this kind of bleeding, again, just inject the patient. Now this bleeding can happen due to maybe just a soft tissue or some capillary which has been ruptured over there. So again, you have to irrigate with plain saline. Please don't put betadine right at the beginning. Betadine is not Gangajal, or maybe of recent, I would say it is not Mahakumbh ka jal which will wash away your pap. Okay, so it is, you have to clear saline, just saline. You irrigate over there, okay, and then this particular irrigation will kind of show you where is the exact spot, and then you can maybe clamp that if you're not able, if you're not equipped enough knowledge wise where you can't find that thing. So either you call help, that is you call an oral surgeon to help you out, or you, by the time the oral surgeon walks in, please irrigate the socket very thoroughly over there, suck out everything. Now do not continuously put the suction on the bleeding point because that will kind of attract more bleed. Okay, so suck gently over there. Again, curate. There going to be a very small capillary bleed over there. Again, place an Abgel over there and suture the socket very well. Now, sometimes what happens? You feel hemodynamically, you feel, okay, now the bleeding has stopped. Let me just give very watertight sutures, okay, so that it won't bleed. But if your bleeding is happening somewhere inside the socket, you will land up in this kind of situation whereby it is still bleeding inside. So what happened? The bleeding is not able to come out because we have given watertight sutures, right? So the bleeding will go into the interstitial tissues. When it goes into the interstitial tissues, it's not able to come out. The hemoglobin breaks down over there and a bruising sort of a thing happens out there. Don't do anything. 24 hours of ice application is good enough over there. It takes around 10-15 days. Assure the patient that it is okay to have this kind of bruising. And especially when it is an elderly patient, even if you do not expect any complication, expect any issues, please tell the patient that you could have this kind of a bleed because the tissues are very soft. They are very laxed, especially with a surgical tricellular extraction. Please see to it that you inform the patient about the bruise. Nothing to worry about it. Do not get scared yourself, and see, whatever you feel in your mind is percolated to the patient. Okay? One of our nightmares, nightmare after nightmare, we are going to see a lot of nightmares. So, a fractured palatal root inside the socket, which normally happens with the first molar. What happens is you try to hold it with the bayonet, and the bayonet slips. Already there could be a periapical infection. There is something, and the root just slips into the sinus. Again, this particular thing, what do you do in this kind of a situation? Just open. Again, you can call an oral surgeon if you are not equipped enough to do this kind of surgery. A Cardwell leg surgery. This is with the semilunar incision. Many a times I take a entire flap from the gingival tissue. Okay? From the clavicular incision, what we normally would call it as. And then you look into it, this particular root piece, where I have also removed quite a few times for other people and myself also. So, very gently, you can tease it out from there. But sometimes, because the sinus is an empty cavity, it keeps swimming inside. That time it becomes a bit more difficult. You need to have a good fiber optic light to locate it. Once you look, don't scavenge into the area without having a good vision. First, just calm your mind. Look into the socket, irrigate with saline, let the patient be upright. Don't have the patient lying down. If the patient is upright, the root piece is down below only. Much easier to just hold and remove it. Okay? Then, with that kind of a situation, you lined up into oroankle communication. These pictures are not matching. This is an edentulous case. This is a dentulous case. Okay, you can see a clear-cut oroankle fistula. You give the routine instructions to the patient. Now, what do you do? What are the ways and means of solving this problem? Right? First, you take a buccal flap. For all the reasons, you have to first inject, okay, curate out. Now, what happens is immediately if you realize that you have created a communication, there and then you take the buccal flap, which I have shown over here, the buccal flap, and close it. But sometimes you do not realize at that time. It only comes to your notice later on when the patient tells you the patient is having a regurgitation. Okay, so by then, what happens is you have formed the fistula. The fistula is already formed over there. So you inject. You have to curate out the fistula nicely. Otherwise, the epithelium it does not heal up well then. Okay, so you curate it out. Irrigate again because there could be some food debris gone inside. This time irrigate with saline betadine. We want little exception. Sepsis also over there, and the food debris out. Otherwise, once you close, what will happen is the food which is the debris which is there can cause a recurrent infection into the sinus. That would be a bigger problem for you. Okay, so you take 2 vertical incisions and the flap, and then you give a slit, a periosteal slit, and then take the flap, pull the flap across very gently, and then close it over the defect. Another way of doing it is taking a palatal pedicle flap, whereby you take the flap with the greater palatine artery, because flaps, these are pedicled flaps, whereby there is always an artery over there, so that the wound heals very well with that feed. Okay, You take an incision, make a U-shaped incision like this, take it right until the premolar, otherwise it will bleed a lot, and plus it has to rotate. So it has to come up till that. If you take a small flap, it will not rotate. Then you rotate and suture it over the wound. The basic remains the same, that you inject, curate out the fistula, irrigate well, and then you do it. And here you put some sutures across. It will not close, okay? But eventually with secondary healing, it will close up. You are just encouraging the palisading over there, okay? Then the third way of closing it, if the flap, if you have done both these things, but every time each time it can open up. This is the third way and a better way of doing when it is a very large defect. Okay, so you open the flap with the clavicular incision. We have a lot of buccal bags of fat. Right now, we have no time to go through the anatomy, but here in the buccal area, we have this buccal pad of fat. So you again nick the periosteum and tease out the buccal pad of fat. Don't hold and remove it. You gently tease it out. Place it over the socket. Okay, and then you suture the buccal pad of fat to the palatal mucosa. And then this is the second layer closure you do. Put the flap over it, so it is a double layered closure. And it works really well. Believe me, it never fails. Up till now, I've never had a failure with this kind of flap. Okay. Another major issue, many times we face this issue, is the tuberosity fracture. Now, why does the tuberosity fracture happen? Okay, sometimes you feel, oh, I've just put the elevator and very gently elevated it, yet it just fractured. Okay, many times it can happen. The tuberosity could be very small. The tooth is palatally placed, so there is a huge chunk of tuberosity on the buccal side. So there are many issues whereby it can happen. Now, what happens is, here the most important thing is that you have to know that the tuberosity fracture has happened, right? So what happens is basically you still hold the tooth and you try to remove it and you give a jerk. When you give a jerk, you get this kind of palatal defect. The entire mucosa rips off from there. Okay, and this is how it looks on a CBCT. That there is a fracture over here, a fracture over here, and that entire segment is mobile. So if, first of all, if you realize that you have caused a tuberosity fracture, be very gentle. You separate with the periosteal elevator, first separate of the palatal mucosa. That way, you will get a little less traumatic injury over there. This palatal mucosa, which I showed you in the previous slide, the tone palatal mucosa, it will not rip over there. It will not tear over there. That laceration can be avoided if you cleanly separate the periosteum, okay, and then kind of tease out the tooth. Don't be harsh with it. Just gently tease it out. Now, what happens is, when if there is an upper second molar, especially with the tuberosity fracture, the entire tuberosity comes out with the lateral pterygoid plate, with the hamulus, with the pterygoid muscle. So later on, patient is in for very, very severe trismus. So you have to work upon the trismus, give patient muscle relaxant, a lot of assurance, and just be patient so that the patient can be patient. Now, there are many times you leave behind some root pieces because it is a pro and con situation, risk versus benefit. So like that root piece, if it is a big root piece into the sinus that left behind, you can't, not sinus, a palatal root or any of the roots. If it is a one whole root, you definitely can't leave it behind. So very tiny root, you can leave it behind. You tell the patient, please be very, very honest with the patient. Tell the patient that you have left behind the root piece because the why has to be given to the patient. Don't be scared of the patient. Okay, the why has to be told. If you tell the patient why you have left it behind, patient will understand. Okay, so this was some root piece left behind by someone considering the risk factor that it was very close to the nerve. And then after 8 years, we had landed up in this situation. This is our case. The patient was referred to me and there was a cyst formation. So we did a window technique for that. Okay. We opened the window because you know the exact situation where it is. And then because otherwise it could have been too much of bone loss for the patient. And then just put it back with the bone plate. But it is safe to leave some root picking if you know definitely you're going to injure the nerve. Okay, I forgot to include the coronectomy thing in this, but whereby you just remove the crown when the tooth is very, very close to the nerve. I am not a great advocate of that particular thing. Well, now fracture mandible during the third molar surgery. Sometimes, especially I've seen the fractures much more with the distoangular. So I've shown only the distoangular because there honestly we don't have so much time to talk about each and every complication. Okay, so whichever are the most common ones, I've taken them into consideration. So now while removing this kind of third molar by one junior, so unfortunately, see, no one wants to do anything. No one wants to land up into a complication. It happens. Just when you fall in love, you don't do it deliberately. Okay, so this is the situation, and the fracture. There was fracture mandible. Then he was. I mean, we did this and the GA finally because it was a very complicated surgery. The entire buccal bone, the entire buccal ramus ascending ramus had fractured. And then we secured it with the intraoral plates on the champagne lines and the patient was fine. Okay, later on, maybe after we put him on these are the IMF screws, so we had not put the patient, but later on I had given elastics to the patient. But what happens in another situation is like osteomyelitis. Osteomyelitis normally we see in patients who are medically compromised, high sugars. Now sometimes what happens if the tooth is mobile, there is periapical infection. And patient says, my blood sugar is always normal. My blood sugar does not shoot up. Or maybe the patient tell you, I just tested it yesterday at home and my blood sugar was all fine. It was within normal limits, within 200. Here I would definitely like to tell you all, please do not trust what the patient. He could be right. Okay, I'm not saying he is lying to you, but you must take into consideration that tomorrow, if a complication like this happens, the patient will only tell you, I am not a doctor. You are the doctor. You should have insisted that I should get the investigations done. So please do not compromise onto any investigations. Okay, we feel that the patient might not like if we tell him to go ahead and do some investigations for a small tooth. Just a mobile first molar, you just hold and remove it. Patient could be, or it's a 20-year-old patient and there is some problem in upper eight, you just remove it without checking the sugars. Patient might land up into osteomyelitis. Maybe the patient himself also does not know that he is a diabetic. He could be a juvenile diabetic patient. Okay, so please see to it that your investigations are up to the mark. And the patient with a third molar, maybe a small bone left behind, and patient can land up with this kind of situation. The osteomyelitis with a sequestrum. So what do? You have to take such patients under general anesthesia, curate out the sequestrum. You have to do fossilization of that region, put the patient on long-term antibiotics and hyperbaric oxygen. Okay, and these are a few navigations that you have to do. Sometimes in the upper teeth, the situation can really be terrible. This was a simple extraction. Okay, a very simple extraction done by a general dentist, but patient landed up with a very bad event. This took almost over 5 months to recover completely. So please, and when don't allow, please call the patient for follow-up after even a simple extraction. Please, these are very, very important points that you cannot miss out on. To. A written consent is extremely important. Okay. Now, I'll just brush through this. These are the like root canal instruments. Now, what do you do in this kind of situation? If there is absolutely nothing, no periapical lesion, nothing, no pain to the patient or any irritation, leave it behind. Just leave it behind. But in a situation like this, when the burr tip fractures, you have no option but to go ahead, open it up and remove the burr again. You have no choice in this kind of situation. And I would suggest that when you realize that you have left behind a burr or the burr has fractured, see, this situation normally happens when you do not realize that the problem has happened. If you realize the problem there and then, probably you will not have an issue. In situations like peri-implantitis, you see the blue over here, a big shock, a big tension. What do? Just open it up. You get the silicone cleaning up brushes. Please clean. Please do not wait and watch. Okay, giving antibiotics. What will the patient say? One more procedure. I know these are very stressful things, but open it up. As soon as possible, open it up. Okay, so that there will be lesser problems later. Please open it up and all this, brush this off, place a bone graft, place a membrane, and keep it under observation. Fractured implants, now this is again peri-implantitis basically. Fractured implants, nightmare after nightmare. This is a good implant. Why did it fracture? Occlusal load. Prosthetic is very terrifying. And the prosthodontist too at times. So again, we go refine it, remove the burr. Implant pushed into the sinus, again do cardwell luck. Please call people who are more efficient in doing things rather than you doing it yourself, because you're already in a panic mode at that situation. So do not handle these things yourself. Call someone or have someone along when you face this kind of situation. Okay, so in this situation, I would say, please do not panic. When a complication happens, breathe. Assure yourself in your mind first, and then you assure the patient. As I told you, that thing percolates to the patient. Patient can perceive your movements, okay? So you show the patient, boss, everything's all right. Please do not worry. I'll handle it, okay? And then you navigate your situation. Do not take stuff very hard to your heart, okay? So with that, thank you so much. And probably I can talk hours on each complication, but the time does not help us at this time. Thank you so much, team, for giving me this opportunity.
Thank you, ma'am, and thanks for the lecture, because this complication part. What you said is, yes, first of all, don't panic. That is most important thing, and more often than not, that heartbeat raising and all that. It in itself, it's a complication for us also. So thanks for bringing up a topic which is very, very important for all, even a general practitioner, to know that a small little negligence, or you can say you have just neglected checking the systemic parameters of the patient, and even a 14-year-old child is right now having heart attack kind situation. So you need to be, the time has come that we have to be more vigilant and take care of all these factors. And yes, mistakes do happen. We are all humans here. So just take it with a pinch of salt, that if you have done 50 cases and not one complication, then there is something definitely wrong with you.
No, in oral surgery, we say if you have done 50 cases and nothing has gone wrong, then probably you are an outstanding surgeon. That means you're standing out of the OT, never actually touched a case.
Absolutely, ma'am.
Because
Absolutely.
complication is a part and parcel of any surgery or any work.
Yes, ma'am. And for that, just smile for the camera again. One more picture. Okay, ma'am. And one thing that you would love to tell your younger self. I've been asking this question to all the speakers.
Yeah. So I would like to tell my younger self the same thing that I've told you all. Do not panic when complications happen. Because when you are younger, see, now I know how to navigate, but when you're really, really young, just out of practice, just out of college, that is the time when you panic because till the time you are an intern or you're still in college or you're still doing your PG, there is someone behind your back. When you are thrown out into community, it is not because you have done something wrong. It is because you feel that nothing should go wrong in my hands. Because that is one thing I said, do not panic. And one thing I would tell my younger self also, and also assure, I would have preferred I would assure myself more than assuring the patient. The patient gets assured automatically if I assure myself. And taking informed consent for each and every procedure. I would tell my younger self the same thing. Any procedure, even if it is scaling, you should take an informed consent.
Yes, ma'am. Thank you so much, ma'am. And it's always a pleasure listening to you. And as you said, you can go on and we can also keep listening to you. And most of us are your students somewhere or the other, Dr. Das, and you have been our mentors in many, not even in, not only dentistry, otherwise also. So thank you for being you. And thank you for gracing this event with your presence. And on that note, I would like to welcome our next speaker, Dr. Nilashri Kene. Nilashri, can you just switch on your camera, dear? Unmute yourself, dear.
Yes. Thank you so much, Dr. Sona, for welcoming me.
Yeah, just smile for the camera.
Should I share my screen?
Yeah, just smile again, one more. Yeah. Yeah, Dr. Nilashri is a principal dentist at Smile Dental Clinic, Bhiwandi, and today her topic is going to be mastering soft skills for confident life. The topic, this topic actually we after a lot of deliberation have chosen this topic because Nilashri is someone who has not only been a seasoned clinician, but also she has carved herself in a industry which is very well known to us, that is the beauty industry. She's been into acting, she's been into beauty pageants and won at many places, and also she can be a good mentor for how to present yourself. The world nowadays requires you to be presentable and have certain soft skills. So as a dentist, she's going to be enlightening on a very, very important topic. Welcome, Nilashri, to International Pink Dental Congress, and the stage is all set for you. Your slides are visible, and please go ahead.
Thank you so much, Dr. Sona. First, I will dedicate this to our three Devis, Lakshmi, Ma Lakshmi, Ma Saraswati, and Ma Durga, who give us the power to conquer the world. This is my guru, Dr. Davis Thomas. Under his mentorship, I have done my fellowship in orofacial pain and TMD and sleep medicine. So now we will start with our presentation. What is soft skills? Soft skills are actually a power, common, essential, or core skills, as psychological skills generally applicable to each and every personality, and we need this in our day-to-day life. This term is actually coined by US Army in 1960, and they work hard on soft skills. So soft skills are personal attributes. The importance of soft skills lies in the fact that they are not restricted to a specific field. This thinking deposition consists of a group of abilities that can be used in every aspect of people's lives without any need to readapt them based on the situation. Their utility helps people to adapt and behave positively so that they can deal effectively with the challenges of their professional and everyday life. Soft skills make people flexible in changing world. And that's what we need because dentistry is a changing world. Then comes confidence. What is confidence? It's a feeling that comes from within you. Are you confident enough? So it comes with your own ability. You know yourself, your opinions, feeling and consciousness of one's power, faith or belief that one will act in a right, proper, and effective way. The quality or a state of being certain. So for these things to achieve the soft skills to be a confident, what is important? Be positive. Be positive about yourself. That don't criticize yourself. That no, you will not be able to do this and you are not enough, good enough to do all these things. You are enough. So how to develop this positive mindset? Practice gratitude. Always be a thankful to everyone which is contributing in your life in a positive way. Practice mindfulness. So where you are, the present, live in present. That will give you a mindfulness. That for that meditation is very important. Practice positive self-talk. That yes, I can do this. This is in my touch, and I will do. Definitely will do it. So that will help you a lot. Uh, there is a verb which says that in my younger age, my mom used to say, don't say any negative things about anything, anyone, or yourself also, because Ma Saraswati comes on the tip of your tongue, and any day, at any time, if you say a wrong thing, might it come true. So don't say negative things about yourself also. Identify negative thoughts. Whatever negative thoughts you are coming in your mind, please restrict it. Why this is happening with you? Why these negative thoughts are coming to your minds? Work on it. And then refrain them. Work on that. Spend time with positive people. They will definitely give you that positive mindset to develop yourself. Your wife attracts your tribe. So choose your energy wisely. Incorporate healthy habits. That is very important, like getting up early, sleeping early, reading books. All these healthy habits always comes in your life very it will constructive will be for your life, because if you get up very late and lazy and all that, then you're like, okay, I wasted half a day, now what can I do, then I will sleep again. So no, that will not help you. So please incorporate healthy habits. Start your day one on a positive note. So here is a video I will like to show you. This is my positive mantra. Can you hear this? So this will help you early in the morning. And benefits of the positive mindsets are you are able to handle the ups and downs of life. You trust that you will be okay and good things will happen. You are more productive at work. You can come out of bad experiences focusing on what you have learned and gained. So how you will be positive over yourself? Self-grooming. The practice of actively maintaining your personal appearance. Key points about self-grooming are hygiene is a key. Regular bathing, brushing teeth, washing hands, and maintaining good body odor are fundamental aspects of self-grooming. Why it is needed? So if your body odor is not pleasant, you dentist or any work, you are working with a very close premise with other people, that person will be very like, why this person is near me, just go away, I don't want to smell this bad smell and all this. So please Body odor is very important in dentistry. Then comes hair care, facial care, nail care, clothing selection. Obviously, you are going into your cleaning and you are using some funky clothes. It will not give a good impression to your patient. So please, clothing selection is very important. It gives a proper that you are mature enough, you are wise enough, that vibe to your patients also and to your assistants also. Positive body language is always very important. People always tend to come into the like to come into the contact with the positive body language people rather than a negative body language because they hate the company of these people. So always maintain a positive body language. Surrounding hygiene, like where you're working, if it is dirty, your clinic is dirty, the instruments are not properly autoclaved, and everywhere you can see it is not tidily kept, so that person or the patient comes into your reception, they see all these things and they will go back and they will say, oh, that clinic is not hygienic, so I'm not going back. So surrounding hygiene is also important. Then comes the environmental hygiene. Why environmental hygiene is important? Where you are living, where your surrounding is. It gives a calming effect to your body, your mind. And if it is not proper, you will find very bad about yourself. You're getting early in the morning and you're seeing all this kachra and this is not proper, bad smell, and other your mood will get spoiled, and that you will definitely not like. So the environmental hygiene is also very important. So why self grooming is important? It boosts self esteem, positive impacts your self confidence and self worth. Professional impression. A well groomed appearance is a sign of professionalism and reliability in the workplace. Social perception. How you present yourself can influence how others perceive you. So both of these is very important. So you will may think that, oh, this is very superficial. Why we should do this? We are doctors. We should seek knowledge and all that. Yeah, you should seek knowledge. But self grooming isn't about appearance and hence not superficial. It is about carrying yourself in an elegant manner. It promotes self-love. It says person is disciplined. It shows person is hygienic and healthy. It shows a person is ambitious. It shows a person is mature and evolving. Now comes the communication skills. If you're not able to communicate properly, then you will not present yourself very confidently. So, what are the types of communication skills? There are speaking ability for an individual to accurately convey a message to another person or a group of people. So, verbal communications, non-verbal communications, and other communication skills. So, speaking clearly is very important. Using words to convey information in a way that's concise and easy to understand is very important. Like you are talking rubbish and people will get bored and oh, what is this talking? What is going on? I don't want to listen, and they will zoom out. So please use concise and easy to words understand. Writing. Using words to convey information, write properly is also a verbal communication. Then what comes under non-verbal communication? It comes body language. Using gestures, facial expressions, posture to convey meanings. Like tone of voice. If using your voice to convey the message, like voice modality is very important. Are you angry? Are you happy? Are you confident? If your tone of voice is not proper, then it will tell people without saying anything that, okay, this person is not confident in telling something. When you are conveying your patients for the treatment and you are having doubts in your own mind or your tone is not proper, like very under confident, then patient will directly come to know that this doctor is not good in his work. So not to come. So tone of voice is very important. Then eye contact. Maintain eye contact. Using eye contact is in to convey the meaning is very important. Like the person is talking to you and you are using your phone or mobile. So it will not give a good impression to the person sitting next to you that this person is not understanding what I am trying to convey. So why should I talk? That person will stop talking. It comes in your day-to-day life, in your clinical life, everywhere you need to keep your eye contact, because then and then only that person will feel that you are interested whatever the person next to you is saying. So maintain eye contact. Other communication is like active listening. You have to listen very actively, giving your full attention what someone is saying rather than just hearing the words. Feedbacks, like giving and receiving feedbacks to improve your communication is very important. Like the person in front of you is saying something and you are not giving any kind of a feedback, not saying okay I understood, okay sure, then person is like, is he like listening to me? No. Should I stop to talk? Or if you're talking and talking and not like giving attention, that person in front of you is listening to you or not, then it will also give a very bad impression about your communication skills. Show empathy. That is very important in our dentistry and in our medical knowledge, because in my orofacial pain journey when I started, my teacher always told me, please listen to your patient empathetically. It is very important. Understanding and sharing the feelings of others are very important. Then and then only you can work on their pain. So, empathy is a major factor in communications and also understanding the pain of our patients. Empathy and emotional intelligence is like being able to understand and manage your own emotions and the emotions of others. Then while communicating, you cannot be rude. You have to be friendly, confident. You should give respect and should be responsive to the person who is you're talking or in a group when you are communicating. That will definitely develop your communication skills. So next now comes the problem solving. Then this also gives you a lot confidence in your day-to-day life. uh, for that you have to be creative, like coming up with new ideas, solutions, and thinking outside of the box. Communication, I already talked about it. Then decision making, choose the best solution by evaluating options, considering, analyzing, break down the problems, what is happening, why this is happening, and understand the parts which is actually a troublemaking. Then prioritize what is actually a problem and which problem you should solve first, and then give importance to other problems. So that will also help you in problem solving. So steps for solving problems is like define problems, analyze, develop possible solution, evaluate, choose the best option, implement the solution, measure the results. So this will definitely help you in problem solving also, and your confidence also. So I gave a full page to empathy, because empathy is very important in confidence and also in our dental curriculum. So empathy is like a types of empathy. They have types like the cognitive empathy, the ability to understand another person's thoughts, feelings, and experience. Emotional empathy is the ability to share another person's feelings, which can also be called affective empathy. And compassionate empathy, having sympathy or compassion for another person and their circumstances. So, how to develop empathy? Listen carefully to what others are saying. Be aware of your own opinions and how they might color your understanding of others. Offer your support, whether it's helping hand or a listening ear. Ask for constructive criticism, not the criticism which will demean you, but a constructive criticism. Practice self-awareness. Practice emotional intelligence. So, how it will benefit you? It will help build trust between your team, patient, like your associates, your assistants. Then it will help develop honesty and openness. It will also help ensure that we understand and relate to one another, help you lead effective discussion with colleagues. There is a small I took this video from the cartoon Dandy, and actually it shows that if you can't say something nice, don't say nothing at all. So you shouldn't say mean or hurtful things to the person if you are not understanding their problems. Maybe their problems are very, very genuine and their place. Or you should not comment and show your empathy like that also. Like goal setting, it can help you in your life to attain a confidence. Like a benefit of goal settings, it's like a focus. Goal setting helps you to focus on what's important. Then motivation. Motivate you to take action and achieve your goals. Accountability. So you track your progress and stay accountable to your goals and then plan. Goal setting helps you to plan the steps you need to take and achieve your goals. So steps for goal settings are like identify your goals. What you want in your life. First thing first. List the benefits, list the obstacles, list your goals, list the skills and knowledge you will need to attain that goal. List the people or groups you can work with. Create an action plan. What should you take actions to attain that goal? Set a deadline. Like, okay, this is the time limit, and I will complete this task within these 6 months or 3 months. Otherwise, you're doing and doing, okay, this is my goal. But when are you going to achieve? If you don't know that, then it will be only dream. It will not be goal. So, and monitor your progress. So, goal setting tips how you can do that. There are tips like get smart, specific, measurable, attainable, relevant, and time bound goals. Don't be like, okay, I will be rich like Ambani. No, that will not be a realistic thing to do. You have to be set realistic goals. Prepare for potential obstacle. Like, okay, you're doing, and there is an obstacle. And okay, no, I don't want to do that. No, that will not help you in your life. You have to prepare for the potential obstacles and how to get over it also. Cross off each step you completed, and that will definitely help you to attain your goal. Don't accept failures. So if you accept the failures, that means okay, you are accepting that you are nothing. Why you are accepting your failures? So get rid of negative thoughts. Never give up. Never accept failures. There is a solution to everything. So why would you want to throw in a towel? Make this your new mantra. Succeeding through great adversity is a huge confidence booster. Be prepared. Learn everything there is to learn about your field, job, presentations, because in dentistry, day to day, it is evolving. It is going into the new era. Every 5 years, we are seeing, okay, this new thing is coming. Okay, this knowledge, I never knew this. So you have to work on it. Then create a great list. Sit down right now, make a list of all the things you are thankful for, list of your accomplishments. Once your lists are complete, post it where you can easily reminded of what an amazing life you have and what an amazing person you really are. If you feel very self-confidence is dwindling and take a look at those lists and let yourself feel and be inspired all over again by you. So this will help you in not to accept your failures. It will remind you what you are, what you can do, and what you have done. So there is a Roy Bennett who has said that the one who falls and gets up is a stronger than the one who never tried. Do not fear failure, but rather fear not trying at all. Then comes the self-awareness. Self-awareness skills come like mindfulness. I already talked about the mindfulness, being present in the moment and paying attention to your surroundings is very important for the mindfulness. In doing meditation, like focusing your attention on one thing, such as your breath, mantra, or feeling, that will give you self-awareness. Then self-compassion, being aware of yourself without passing judgment on yourself. Like you can human is a person who can learn from the mistakes, and mistakes are the part of your life. So why criticize yourself for that mistakes? Get over it, learn from the mistakes, and start again your that life. So don't judge yourself. Then reflection, considering your past experiences and what tasks come naturally to you. That will definitely help you in self-awareness. Then feedbacks, like asking trusted colleagues, friends, or mentors for constructive feedbacks. Again, constructive feedback is very important, not the feedback which will demean you or make your life like, oh, why I'm doing that, and making you depressed. So constructive feedback. Then benefits of self-awareness. It's better relating to colleagues. It will help you more self-confident. Then making sounder decisions. Then it will help you building stronger relationships, communicating more effectively, and being less likely to lie, cheat, or steal. You know that you can do this, then you will not like, okay, I'm this great person and that. No, you know what you are, and you will not say like, okay, oh, I'm this person, I'm not that person. So you can value yourself, you can evaluate your behaviors, then feelings, emotions, and thoughts. Then your what action and reaction you will take in this situation, that will comes into your mind when you are self-aware, and you will act according to that, and you will not misjudge the situation or fall into the very like deep valley where you cannot get through from that. So that for that also we have to know the strengths and weaknesses of yourself. That will definitely help you for the confident life. So decision making. So all these decision making things always comes, whatever I talked first about all these things, like creativity, think outside, problem solving, like what is the solution, what analyze, use other skills to develop a unique solution, critical thinking, like challenge assumptions, evaluate alternatives, consider potential consequences. Everything will help you in your decision making. um, I will not go in detail because this is very theoretical, but what will help decision making process in that, at the recognize problem, gather information about feasible solution, and finalizing the best alternatives. Like if you're done, there is a dry socket, and Dr. Vaishali already told you not panic, be patient, and it will come only when you have a very rightful decision making power, what to do in that situation. So what will come next? It will give you the leadership. Why we will need the leadership? We have to run our clinic. We are growing. We have a team, and we are the leader of that team. So the leadership skills are very important in this, and it will come with your communication, your empathy, your how you are mentoring your staff, like what to do when the patient is like very aggressive or very rude to your staff, and how you will go out of that situation, or that situation turn positively. You have to mentor your assistants for this, and they should feel that you are dependable. That if something happens, that you will give a solution to them, that you can come out of that situation. Then you should be problem solver. Empathy is very important, that I have already told. Then integrity. Okay, if you are promised that this thing is going to happen and this will happen to you, then you have to be integrately stick to that situation and your thoughts, and visionary. Visionary is like you should have a plan of what after you're going to do 5 years. Like what are your goals? Like after 5 years, the dentistry, where dentistry is going, and taking action according to that. Now that will show your visionary thing, and then your practice will develop very potential. So teamwork. Then what is teamwork? I already talked. If you are a leader, then you have to work on your teamwork skills also. Because talent wins games, but teamwork and intelligence win championships. And our clinic is on teamwork skills. And for that, you have to listen properly to your staff also. Like you cannot dictate them. Okay, you wanna like you want some chutti, and no, I'm not going to do. I listen to their problems, why they are saying something or why they want to go or something like that. If you are listening and empathetically, um, empathetically you're listening to their problems, then you will take a proper decision. And for that, open-mindedness, reliability, also very important. And then only you will be very good in your teamwork. Because even if you agree or not, you are going to stick with your team for whole life in one clinic. So for that, you have to be together and work on your teamwork, and that will definitely boost your confidence after working on your team. If you can properly manage your clinic, you can manage your life, you can manage your social life also. So for that also, for confident life, you have to be organized. Uh, so being organized means having a system in a place to manage your time, space, priorities. It can help you more productive, creative, and in control of your life. Benefits of organized is improve your quality of life. Being organized can help you feel more balanced and in control. Increase productivity. You can be more effective and efficient when you are organized. Reduces your stress. Having routine can help you feel more comfortable and in more control. So tips for being organized: make lists, create to-do list for a day, for a week, or a month. Prioritize, like focus on what's most important and set daily goals. Manage your time. Schedule time for tasks that require concentration. Use calendars and planners. Write down commitments. Use reminders to stay on schedule. Declutter. Get rid of things you don't need and keep only what's essential, like in your mobile, in your cupboard, in your clinic, everywhere. Delegate. If you're not good in some part, like some expertise, so seek help. Assign the task to others when you don't have the expertise. That will definitely help you. Then manage your mails and phones. Sort mail of priority and use voice message screen calls. You might have missed some important mails, and because it is decluttered, it's cluttered. So declutter that and it will definitely help you. Synonyms for organized is like systematic, structured, methodical, regular, orderly, and that's your personality you are going to develop. So to sustain longevity, you have to evolve. Evolving is very important. Look around you. Everything is changes. Everything on this earth is in continuous state of evolving. Refining, improving, adapting, enhancing, changing. You were not put on this earth to remain stagnant because stagnant stinks. Because now digital dentistry is going, we never heard of like a scanner or like planning before doing any patient. Now it's the same thing, we have to do that. Implants, 20 years back or 25 years back, hardly anyone was doing implants. Now you have to evolve and you have to learn all these skills, otherwise you will not get to know. Like orofacial pain, you never know this branch is there, and right now it's going, it's booming. You have to know all these things. Why this is that? Like even biomechanical dentistry, Dr. Sangamitra talked about. This is very like interesting dentistry going on in dental science. So you have to know all these things. Then and then only you will sustain in your life. So interpersonal skills are also important. How you are making better relationships is important. Like you have to for in your practice also. Join some NGOs, join some medical associations. It will help you to maintain your relationship with other uh, medical branches also, where you can seek help if you need them, or they can refer the patients to your clinic also. That will be beneficial for you. And for that, interpersonal skills are very important. How you're talking, how you're behaving in your social circle is it's very important, and it will come in hand when you are talking. So more a better relationship, then identify well with individuals leads to more relationship at times and friendship, better communication, relating with people and being able to work in large groups. It will give you greater efficiency. Then it will advance your career prospects. So obviously, if you go out, people will know you, and then definitely, if you are behaving properly, your posture is proper, your behavior is proper, they will think that okay, this person is very reliable. Definitely, I should go this person for my treatment plan or my problems. The doctors will definitely send patients to your clinic, and that will increase your day-to-day practice. Then definitely it will increase your overall happiness also.
Nilashri, any issue?
Oh yeah, my slide is not going up. Okay, so no. So again, the critical thinking. Why critical thinking is important not only in surgical procedures. The law, I think 2-3 months back, the incidents happened in my friend's clinic that my friend extracted his teeth and patient was very healthy. We have given him, injected him LA, and after injecting, he waited for 20 minutes and then patient came in his chair and he extracted. After that also 5 to 10 minutes he was there in his premise, and then he went out and suddenly he had a heart attack, and he was in his premises only when this happened, and he has to do the critical thinking what is happening, because he would have panicked and would have took a very went into the shell, and it would have backfired on him. So in this scenario you need to have the critical thinking, and also you need to know what you should do in this kind of situation. So for that, you need to have skills. Then you have to observe what is happening. You have to analyze. Then you have to interference, like what conclusion, what is happening, and what should I do in this thing. And communicate. You should tell other persons to call, like 911 or emergency contact. That because in dental we don't have this kind of things like emergency kits or like that. So you should have your contacts with other hospitals, and you should tell the person beside them to call the hospital. The ambulance should come in a time, and you can send that patient to that clinic. So in this time the critical thinking always comes in handy, and you can solve the problem. And for solving the problem, the process of gathering, analyzing, communication information to identify and troubleshoot solution is always important. So conclusion now, why? The conclusion, so how to have confidence in yourself, like visualize your confidence, that you are confident. Can you hear me?
Yes, yes, yes. Go ahead. Conclude it. Conclude.
Can you hear me?
Yes, yes, yes. Nilashri, go ahead.
Okay. I'm sorry because one of my so visualize your confidence, fill your life with motivation, what you want to do, and always the person who is motivating you, keep in contact with that person. Say yes more often, create and embody to alter ego. So you aren't nervous, you're excited to do this. That you should tell yourself, okay, I'm not nervous, I'm excited, I want to do this, I will do this. And create a power playlist and celebrate your wins. That will definitely give you a boost. Okay. Then focus on your strengths. What's your strengths? What you can achieve? What you can do, and develop that in more strength. And posture matters. How you're talking, how you're listening. It will definitely matters in your showing how confident you are. And smile more often. That will give a positive aura in your life. Then dress the part where you're going, where you're sitting. Are you going for a pub or are you going for a clinic? So you have to understand that and dress the part. That will definitely give a confidence. Think highly of yourself because you're worth it.
Thank you, Dr.
So
Nilashri. Yeah.
this is dedicated to my the women in my life. This is my nanny, my grandma, my mother, my baby, then my childhood friends, then of course Dr. Sonal, Dr. Amrita, she's my college friend, and all these are my assistants who are always there in my life, and they also give the positive, they have positive impact on my life. And last but not the least, myself. I'm a mother, I'm a dentist, I'm a daughter, I'm a wife, and I'm an achiever. That gives a boost to my confidence always. So thank you so much. Thank you, Sonal. Thank you, Metzger, for giving me this
Nilashri,
opportunity.
can you just come out of the share screen mode so that I can take a picture and ask a few questions?
Yeah,
And there are certain questions for you in the chat room also. So please visit the chat room. Yeah, just come out of the share screen mode. There would be a button to come out. Stop sharing.
Yeah, I got it.
Yes, yes.
Thank you
Smile
so
for the camera. Yeah, what is that one thing, Nilashri, you would like to tell your younger self? I know you're still young, but then compared to the self you are today. So maybe when you were in 20s. So what would you like to tell her?
I will tell
But
myself, don't be impatient. Be
ah,
wise and seek the knowledge.
lovely,
You're
lovely, lovely
doing
having you on board, Dr. Nilashri, and thank you for this lovely presentation. And I'm sure we have all gained a lot of personal tips also from you. So thank you so much. And with that note, I would like to call in our next speaker, Dr. Rakhi Kapoor.
Hi, how are you?
Hi, Dr. Rakhi. Dr. Rakhi, as she calls herself an entrepreneur first. When I asked her what should I write in bio, she was like, mention me as entrepreneur. She's completed her MDS, and today she's going to be bridging this gap between dentistry and entrepreneurship. So the stage is all yours, Dr. Rakhi. Welcome.
Yeah, thank you so much. Can everyone hear me? And Dr. Nilashi, can you mute yourself?
Dr. Nilashri, you just mute yourself, and yeah, we can hear you, Dr. Rakhi. Please go ahead.
Awesome, that's great. So, hi everyone. Today's topic is from dentist to entrepreneur, how entrepreneurship and partnerships can empower women dentists. Let me introduce you to myself. I'm Dr. Rakhi Kapoor. I'm a dentist by education and an entrepreneur by passion. Over the past 15 years, I have worked extensively in the dental industry, building a thriving network of 80,000 dentists and launching multiple ventures in healthcare, media, and startup consultations. Through my journey, I have seen firsthand challenges and opportunities women dentists face when transitioning into entrepreneurship. Today, we'll discuss how women dentists can leverage entrepreneurship and partnerships to build successful ventures. Whether you're thinking about starting your own practice, launching a dental product line, or creating an online business, the insights in the session will help you make an informed decision. Today, the topics that I will be covering in this lecture are going to be why dentists should consider entrepreneurship, challenges women dentists face and how to overcome them, the power of strategic partnerships in business growth, steps to transition from dentist to entrepreneur, key business models for women dentists, and how to build a sustainable and scalable business. First point, why women dentists should consider entrepreneurship. Let me go to the slide. I forgot. I'm presenting. Okay. Why women dentists should consider entrepreneurship. Many women dentists limit themselves to clinical practice without exploring the vast opportunities entrepreneurship offers. Here's why stepping into business is a great idea. The first being financial independence. Running your own business allows you to control your earnings and scale them beyond a salary-based model. Instead of depending on a fixed income from a clinic or a hospital, you can diversify revenue sources, such as offering specialized services, online consultations, or even dental product sales. Second is the flexibility and work-life balance. Unlike traditional clinics with fixed schedules, a business can be structured to suit your personal commitments. This is especially very important for women who may need to balance family and career responsibilities. Expanding impact. Entrepreneurship enables women dentists to go beyond one-on-one patient care and impact the healthcare industry at a larger scale. For example, starting a tele-industry business that can help reach patients in rural or underserved areas. Personal and professional growth. Running a business fosters leadership skills, decision-making abilities, and personal confidence. Learning financial management, branding, and business strategy can empower women to make independent decisions. Let's go to the challenges that women dentists face and how to overcome them. Many women dentists hesitate to start a business due to perceived barriers. Now let's address them. First is the lack of business knowledge. Most of the dentists are not trained in business strategy, finance, and marketing. So the solution is to take up online courses, join mentorship programs, and attend networking events. Engaging with experienced entrepreneurs can help bridge this gap. Second is funding and financial management. Many women struggle with securing initial capital or managing finances. The solution here is exploring self-funding, bootstrapping that is called, bank loans, and startup grants tailored for women entrepreneurs. Platforms like government women startup programs offer funding support. Work-life balance concerns. Balancing a business with family responsibilities can be very tough. So the solution, delegation, time management, and leveraging technology for automation, it can really help. Hiring skilled professionals or outsourcing tasks can reduce your workload. Limited network opportunities. As women, we often face challenges in accessing strong business networks. Now, the solution for this is engaging in industry groups, startup communities, and events that support women entrepreneurs. We have a women entrepreneur groups where we have 180 founders. You can collaborate with us and we can provide you networking opportunities as well. Additional insights could also be cultural and social barriers. Now, for some women, many face resistance from family or social society when stepping into a business. The solution here is educate your family members about your vision and gradually build credibility in the industry. Third, the power of strategic partnership in business growth. Now, one of the fastest ways to grow is a thorough partnership. And here's how you can do it. First is collaborate with other dentists. Joint ventures with other women dentists for group practices or specialty practices can increase patient referrals. Partner with dental suppliers, negotiate better rates or co-brand with suppliers. It can improve your profitability. Bulk purchasing through a network of women dentists can also lead to a cost saving. Team up with tech startups. Using AI, telemedicine, or digital marketing partnerships can create new revenue streams. Teledentistry, for example, allow consultations beyond physical locations. Women entrepreneur networks. Join forces with other women entrepreneurs to co-market your services, share your resources, and learn from each other. Let's get some examples for a successful partnership. A group of women dentists have partnered with a local lab and an AI-based diagnostic tool, creating an online consultation platform, which has grown exponentially. Let me help you with the steps to transition from a dentist to an entrepreneur in 5 minutes. First step is to identify your business. Do you want to start a clinic? Do you want to do an online consultation platform, a product-based business, or a dental education venture? Conduct market research to identify these gaps. Step 2, develop a business plan. Outline your vision, business model, revenue streams, and your growth plan. Use the lean canvas model to map out key aspects of your business. Step 3, build a network and find mentors. Engage with startup incubators, mentorship programs, and business forums. Seek mentorship from successful female founders in the healthcare sector. Step 4, learn business and marketing basics. Take short courses on finance, digital marketing, and branding. Leverage social media to build a brand presence. Step 5, start small and validate your idea. You can run a pilot project, gather feedback, and refine your business model before you scale it up. Now let's come to key business models for women dentists. Here are a few scalable business models that women dentists can explore. First is the dental franchising models. Owning and operating multiple chains of clinics with standardized service. Get a set SOP. Dental education and consulting. Run online and offline courses for young dentists. E-commerce and dental care. Sell oral hygiene products through a private label or an online store. Tech-driven dental services. Use AI-powered diagnostics or telemedicine for virtual consultations or for booking your appointments. Choose a model that aligns with your expertise and interests. How do you build a sustainable and a scalable business? For a long-term success, follow these principles. Leverage your digital tools. Automate processes like patient scheduling, marketing, and customer engagement using CRM tools. Focus on your branding. Establish a strong and personal and a business brand to stand out. You can use Instagram, LinkedIn, YouTube for content marketing. Diversify your revenue streams. Have multiple income sources, clinic services, online products, courses, or partnerships. Invest in a good team and leadership. A strong team and a good leadership will make the business sustaining. In the long term, growth strategy, expand regionally, and build passive incomes. Take courses, read ebooks, or a subscription-based model. Invest in all of these. So, in conclusion, I just want to say the transition from a dentist to an entrepreneur requires a mindset shift, learning new skills, and building the right partnerships. Women dentists have immense potential to create impact businesses that offer financial freedom, career satisfaction, and industry-wide influence. I encourage all of you to explore entrepreneurship, embrace partnership, and take the first step towards building something extraordinary. I also want to share some details about an incubator program that we are planning for women entrepreneurs. And let me just share the details with you of the same. So we have a 3-day startup bootcamp, which are for early stage founders or any founders who want to, start with, who have an idea and who wants to refine them. So basically, these are the pointers that we are going to be covering. Our speakers are Mr. Abhimanyu Rathi, and it's me. Mr. Abhimanyu Rathi is a young dynamic entrepreneur. He's actively involved in India's startup ecosystem with extensive experience in business development, technology solutions, and market strategy. I have a female founders community, and I help them in business strategy, fundraising, and startup growth. What we are going to be understanding is the startup ecosystem. How do we build a strong foundation? How can we do market research and validation? How our business model made and how a market strategy, that is a go-to-market strategy, is formed with limited resources. What are the legal basics and startup compliances that are required to start a business? It's a 3-day program. On the day 2, we are going to be talking on product growth and fundraising, where in session 1, we'll be talking about product development and MVP strategy. In the session 2, we'll be talking about growth hacking and customer acquisition. Then we'll be talking about how to raise money. That's preparing you for fundraising. In session 4, we'll discuss about financial planning and unit economics, understanding revenue models, burn rate, runway, unit economics, and how to make your numbers work, which is a very essential part of your business. On day 3, we'll be building for the future. So first session will be building a winning team and culture, because as you know, if you have the right team, you're on your way to success. Then we'll be talking about branding and storytelling for startups, how to have your own personal brand as founders. Session 3, we'll be talking about navigating challenges. As a founder, you're going to be having a lot of challenges in your day-to-day life. So how do you handle failures? How do you pivot? How do you manage stress? And you have maintained a long-term vision. In session 4, we'll be talking from early stage to scale, understanding 3 growth inflection points, strategic partnerships, and global expansion. So this is the outline for 3-day program, and there are additional benefits as well. When you think about doing a startup, we can help you with a startup toolkit, which has legal templates, pitch deck examples, go-to-market strategy. We have an exclusive founders community. We have one-on-one session with the mentors. So the early bird for the registration is 25,000 until March end. And after that, we'll be charging 30,000. You can get in touch with us anytime if you would like to start your own startup. I will take this opportunity to thank Dr. Sonal for giving us this platform to speak about entrepreneurship. Her vision is excellent. And thank you everyone for attending. I also would like to share one more thing that we are also coming up with a program for implants, and I would like to do a special pricing, a discount of 20%. So you can get in touch and also follow the dental experts on Instagram, LinkedIn, as well as Facebook. Thank you, Dr. Sonal,
Yeah. Thank you, Dr. Raki.
for giving us this opportunity.
Yeah, thank you, Dr. Raki, for being a part of this Congress.
Thank you.
And if you just come out of the share screen mode, then we can take a picture together. And meanwhile, that you're setting up the screen, one thing that has inspired you, yeah, just come out of the share screen mode. And if you can tell us one thing that just come out of the share screen mode first. So
I am trying. Ah, yeah, stop share. Got it. Yeah.
okay, smile for the camera, dear. Yes, so
Thank
it was
you.
an engaging lecture. Actually, this entrepreneurship is something which we all must engaged into, and somewhere or the other, at one point in time, we all must know about this different aspect of clinic management, because it is the
Right,
niche
right.
and very rightly put. And thanks for the discount you're giving to the participants also. So thank you so much on.
Thank you.
So I would like to know one thing that has inspired you. Like your journey has been a little off track and then back on track. So I mean, you are into dentistry, yet you have spread your wings, and it's really commendable. So can you just briefly tell what is the inspiration behind this?
So the inspiration has been my mother, honestly speaking. I mean, she came from, like she studied from Delhi and she had just finished her graduation and then she got married and she was not allowed to work. But, in spite that she was not allowed to work, she got into share market, she got into, investing, and she made more homes than my dad, even though he was working. So she was my inspiration, that staying at home and, she learned everything by herself. She got herself financially educated and she created a secured housing for us and, made us all secured just without even moving out of the house. So she has completely inspired me. And I also want to inspire a lot of women to take this journey of entrepreneurship, being financially stable, and, doing the best for themselves and providing themselves because they deserve it.
Yes, Raki, actually, you have struck a chord which every female can relate to, because, yes, somewhere or the other, we are a replica or a shadow of our mothers. So,
Yes.
being that says a lot. Like you do your bit, and the generations follow. So,
Yes.
thank you so much, Dr. Raki, for being a
Thank
part of
you.
this Congress and enlightening us. And
Thank
on
you so
that
much.
note, I would like to call in our next speaker, Dr. Shelly Mahajan. Are you there, Doctor?
Yes, Dr. Sonal.
Yeah, hello, doctor. And how are you doing?
I'm doing fine, good, and
Dr.
all
Shelly
ready.
Mahajan, let me introduce you. Dr. Shelly Mahajan is MDS orthodontist. She's completed her MDS in orthodontist and laser specialist, and she's certified into global tobacco control management from John Hopkins University, and she's a professor and head of Department of Dentistry, RMLIMS, Lucknow, India. Today, she's going to be talking about a very important aspect of healthcare. Forget about dental or anything. The healthcare that we as the privileged souls we call ourselves, where we are staying in urban society, but there are rural places and places where the healthcare has not yet ventured their wings into. So I would like welcome Dr. Shelly Mahajan to this forum, and thanks for taking up a topic which every healthcare professional should actually contribute to. So thank you for enlightening us, taking a part and enlightening us on this topic. So your screen is all set, ma'am. Please continue with your lecture.
And thank you. First of all, it's my privilege and honor to, extend my contribution to this, workshop or this world-class conference, what we are totally into it today. Dr. Sonal, you have been magnanimous, dynamite, if we say so, and we are privileged to have you amongst us, because I've been seeing you not working like only days, but even nights as well, because working out on those strategies of, making those timelines being met is quite a daunting task. And also Dr. Nooral, because I approached him for this when I got to know about it, because this was something, when I looked into the brochure, I found that something was missing, where we can contribute as dental surgeons in the society. So I'm really honored, and I would start my topic as the Smile Guardians, okay? Because Rural Women's Oral Care Mission. So these are the greetings from Dr. Ramanohar Lohia Institute, where I'm working at the present, and in the capacity of a professor and head Department of Dentistry. I have done my orthodontics as like mastership, but when I came to the department, I was handed over the charge of being, one of the dental professionals. So I had to really unwind myself and go back to those eras where it was more of a dental surgeon rather than just being, specialized to my specialty. So in the mission, we were also conducting a few dental camps, and amongst, getting in collaboration with the NGOs, our rural healthcare centers, and there were some of the poster competitions which have been displayed, and we would like regularly were doing all these, so you can see these are just the today ones, the International Women's Day, like we had it in the morning. So this was by our endocrine department, like we had held, with other departments as well. And these were some of the posters which are displayed in front of you. One poster where you can see this girl, I mean, she doesn't have hands. So she had presented one poster, and it was this, which really caught me. And it was on the Girl Child Day, that is 5th of October last year. So this really had the disparity, and it came as a slap, on me, whether this girl who didn't have hands, she was painting with her own feet. She had presented this, where you can see the disparity that, the girl is being like, this is the playful age of hers, and she's stung, she's committed a suicide. So this was something which really, intrigued me into something like where we are lagging. So with that, we've already had those missions of, having those oral days where we keep on promoting ourselves to the local people, like how we are talking about tobacco cessation, what the importance of oral hygiene is. We have important days like an endo day, which we just had, then ortho day we had, and what all we can make, we are all planning and doing it. I mean, in a very unstrategic manner, I would say so. So some of the contributions, what we had was, this is the importance, like what is the importance of oral health in rural women. So these are the women who are there, staying in a very like urban society. We and talking about, from my office, it will be very difficult when you go into the fields and meet the rural women. So if you see, they are not aware of it, because for them the priority is their family, their health is neglected. So if you see, they would come to you only when they have, such kind of conditions where their mouth is not opening, or maybe they have a fear, because now we are totally talking about what kind of, the percussions oral cancer has, or maybe they have a bad breath, or maybe some bleeding which is coming from their mouth, or some of the oral manifestations which they would have. They may have a systemic manifestation, or referred by an ENT surgeon where they have an ulcer which is non-healing, coming with the limited mouth opening, that is oral submucous fibrosis, or maybe a wisdom tooth, or maybe a non-healing ulcer, coming with some voice changes. There are tongue changes which are there. They do not have, sensitization to what they are eating. They are not able to eat or feel anything. They have a fungal growth, or they have some TMJ problems. They have some vitamin deficiency, nutritional deficiency, and whatnot. So with gingivitis and all that, they are not bothered about it. So many times, even in our dental clinics also, we would have seen there would be pregnant women in the second trimester, and you cannot do anything. And in the first and the third trimester also, they come to us, and then we are in a very grave situation that we do want to, conduct, and we are competent of conducting some dental treatment, but just because their systemic health or their, physiological health is not allowing us to do so. They are not aware even in the urban areas. And think about those situations when we are working in the rural areas. So common health problem in the rural areas would consist of malnutrition and anemia. You would know that so many times they are not, given the privilege of eating first. There is a movie which is She, which just came, your Mrs. Sorry. Mrs. Movie had come, and we all must would have seen, and if not, then please go and see. This is not just the section of like urban or rural, it is the story of every woman. I think malnutrition and anemia is also seen in the urban areas where lot more, things are given. Like if milk is there, they should be given to the men in particular, and even the boys or the small children in particular. But as women, we prioritize our family first and then ourselves. Infectious disease, so many times it's because cervical cancer is more into these words now, breast cancer, many other maternal and child issues, oral health problems, gingivitis, periodontitis. I think 80% of the population is having all that. Non-communicable diseases, there are many of them which are tobacco oriented, especially when I'm sitting in Uttar Pradesh, and now it's just like, the South Asian countries which are there, and all over the world. Now your tobacco is like all over. Alcohol is the one. They would have respiratory problems. They have now cardiac arrest cases are also coming. They have the the pulmonary cases are coming. So all these are the ones, and reproductive health issues. There is rise in infertility, and if there has been a coincidence of evidence based that your oral health, which is compromised, would also lead to preterm birth and low birth rates. So common health challenges with us when we're working in the rural areas is, first of all, they have a limited access to the dental care. They have lack of awareness and education. There is so many myths which are encountering them, and high prevalence of tobacco use, which is also considered one of the cultural things which are actually, when they say like "Baratiyon ka swagat pan parag se kijiye," and all those things which are very prevalent in these kind of areas. Poor hygiene practices, lot many patients when we see, or lot many areas when we visit, they are not aware of what a toothbrush is. Imagine the plight of, the division in the sections. There is fear and misconceptions, fear of like even getting the tooth extracted. If you are getting the tooth extracted, they may have the fear of losing their eyesight. This is a very common myth, and not to go to a dentist or not to go to any doctor for that matter if they have got any problem. Not many patients, they are, unfortunately, we are not able to save them just because of the thing that they do not want to go to a gynae, because they have a fear that every time a C-section will be done and whether the child can be delivered. So financial constraints are also one of the compensating things which are incorporated in these kind of bills. So what is the role of a dental professional? The role of a dental professional is, first of all, oral health educator. You can talk to them about, what are the various oral health means, like, for example, a toothbrushing. For us, it may be a very simple one. But believe me, when we went into those areas, we could see they were not at all aware. And even the medical professionals are not aware of how a proper amount of toothbrushing needs to be done. Preventive care providers, you need to tell them about what is the prevention, how they can prevent certain diseases, how they can have like tobacco cessation programs. Primary caregiver, if they have a small, a gingivitis or maybe a bad breath, how it can be taken care of. If they have a cavity, then it can be restored. All these things too. Even if a tooth needs to be extracted, it can be, re-implanted, or even for that matter, the slightest amount of what kind or what purpose the tooth is, serving in your mouth. That also they are not aware of. Just because the tooth has got some problem, they would come and say like, please, nikal do isko, extract it. And we tell them that if you have, like I tell them, if you have 10 fingers and if you have 2 eyes, doesn't mean that if it doesn't, work, you would tell us to, remove that. Just because there are 32 in your mouth or maybe 28, doesn't mean that we have to remove. So, I mean, we are provided with the capacity of saving. So it is always a conservative dentistry rather than, going for a surgical one. And the priority should be given to, save someone rather than that. And for us, be it a heart or be it a tooth, they are more or less having the same kind of value. Community outreach advocates should be there. Tobacco cessation and oral health care promotion. April is 1 month where we just talk about oral cancer awareness. 4th February was one where we had spoken about cancer. We have AIDS Day and all these other days where we can utilize. And there should be some policies as dentists. We can always, promote and have, collaboration with our government and our health officials, where we can talk to them about the policy influences and how we can help in research. So community outreach activities, what we had performed and in whatever I could have in my capacity to improve oral health in rural areas, I thought I would just share with you. So first of all, what we can do is just free oral health screening camps. I'm sure most of us are doing, with IDA and with other areas where we are doing philanthropy. We are also doing as one of the promotional events of our, way of talking about our clinics, that you can come to our clinics, and it is good in a way because it is a mutual. Whatsoever they are being advocated and they are being made aware of what importance the oral health has. So this is some of the workstations what we have. You can always have a basic health checkup. No need to give anything, just go there and have a small section where they have rural sectors where you can have a village school, temple, or a community hall. You can just set up a small table with just gloves to mouth mirror. You don't need to have mouth mirrors as well. Before we were having mouth mirrors, but then there were a lot of problems because the people were so many, and then we had limited amount of the sterilization was one of the issues. So what we tried promoting was the ice cream sticks. So these were there, gloves are there, mouth mask, and that's it, a table and a chair, and you can evaluate, you can just assess what kind of problems they have. Then screening women for oral diseases, gum infections, and early signs of oral cancer. There are many times when we talk to them about the basic oral health hygiene, how they are supposed to, switch their mouth, brush 2 times a day and 2 minutes. And every time we have had one or the other questions, which were really, just an eye opener to us, that these are small basic things and they don't know. How can this be possible? And it used to be like, initially I used to find it very funny that they're asking me that, is it important to swizz your mouth every day? And I'm like, is it important to brush your mouth every day? And I was like, what? There were so many of them who had not even brushed their mouth. Can you believe it? I cannot. But when you are having all these strategies, when you go into the interiors, you would find women or children who have not even brushed even once. There are some NGOs, you can take help from them. Dr. Raki had just spoken about it, being the dental entrepreneurship. And there were some NGOs, there are still NGOs which are ready to help, throughout. There is Help You Foundation, Inner Wheel, Rotary, Lions, and whatnot. There are non-government supported, the government supported also, which are there to help you for these. So what you can do is you can take help from them. You can go and interact with the people out there. They do give you a place where you can provide dental health checkups, so you can make aware, and their parents can share their problems, what they have and what their children have. And once, because they are very monitored once you conduct a dental camp somewhere, and then you go and you cannot assess them again and again. But if you catch hold of a school or a community as such, you can always go one and other time, and you can assess whether whatever you have spoken is being inculcated or not. So this was the health status what we had. You could see fluorosis cases, dental caries, and some of them have even got those skin diseases, fungal infections, and you can assess the amount of, like, whether it is water which is the problem or whether it is the overall environment which is the problem, and you can get connected and try and help them. There are fluoridation programs which are there. Assess the amount of fluoride what is there in the water, so that can help you. And when you are inculcating in young minds, I think they would give you more of the result rather than talking to the elder people. There are group activities. When we speak about them, we make them into a small groups, and we tell them, first we advocate them what is the toothbrushing and how we have to, go to the surfaces. We talk to them about small things, that the tooth has got 4 surfaces, the outer surface, which is near your cheek, and the inner surface, which is near your tongue, and the chewing surface, what is there, and in between surfaces as well. So one activity what I had done was the simple chart paper and some chalk which were there. They were cut into small pieces and they were mimicking as teeth. And one thread where we were telling them about the importance of how flossing activities to be done, and a brush which they would, brush. So these are the activities what they can take. Have some parent activity in your school, in your children school, so that you can go and advocate them. They're very simple and they need not have to make you invest so much. We also talk to the government, NGOs, and other people. We try and inculcate these small group activities in between them also, making them aware of what all they can do under their things. You can take, teachers as one of them. This was the activity we had conducted with the teachers of the school, so that they also know, because once they would know, they would also be able to, inculcate in the young minds. There will be poster competition when we have these special days. What we do is we inculcate in them that they have to have poster competitions, and when they get prize for that, or maybe a simple thought of how a poster needs to be made, or how important their health would be, they would just go and talk, or maybe Google them, and they can get lot of information which we might not be able to foster them, or maybe they would forget, but what they Google, they may get a number of things what they can have. Then free distribution of oral hygiene. Everyone likes to be, having a gift, and children, or maybe I at this age also would like even a small flower if someone gives me. I think that would be more than appreciated. So there are small gifts. I think these are the practices which everyone does in particular, but these are some of them. This is our ex-director, Dr. Sonia Nityanan. She is now VC of KGMU. So we had asked her also. So these are the directors, your dean, your principals. If they come forward and they help, this will be more than appreciated. You can see this woman, how, I mean, she's adoring, that these are the, and once, because I'm in a medical institute, even I would foster that kind of, that oral hygiene is important in my director's mind as well. And even in the institute with other faculties, we are working with. Celebrate days. This is a teacher's day, and we had done a difference. This was the specially abled kids. So we had like celebrated with them. We sang some songs with them. We tried to inculcate what oral hygiene importance is in their own way, be it a song, up, down, round and round, like that. We used to make rhymes of how easy it can be for them to inculcate. And also we had told them to get their own tiffins, so that we can monitor what kind of nutrition they are having. So in case if they are having a lot of sticky starchy food, so then we can always talk to their parents that okay, this is not the diet because it is high in karyogenic. So you have to have either some of the other nutritional benefits what you can add into your tiffin, be it like pulses, or maybe soya, or maybe other things, how we can have like a fruit day or a cheat day, something like that we can incorporate in them. Then we also felicitated the teachers. So this was No Tobacco Day we had done in our PHC centers. We have two of them which were adopted. One is the urban center and the rural center. So you can also adopt one of the villages. There we had inculcated. And you know what is the benefit? Because every time when we go there, we have the same faces which have been seen. So one of the females, she stood up and she told, I am really inspired by this and I really want my husband to quit this habit. So every time we go and meet her, and she's always telling us ki abhi, like he had the capacity of 5 packs of cigarette, now he has reduced to 4, 3, 2. So these are all the motivating factors for us as well. So also you need to empower them. So when we had gone to this school of specially abled children, we had so this is one of the child, he makes herbal colors. So this has been made by they put itra in that, and also this is by haldi and other as well, like palak they would have, and other beetroot, like for that they would have, and we buy them so that it is a power, and it is hardly costing 10 rupees, these many, and this would give them such a thing. The parents need not have to sell that, but it is just for this child, and in the rural areas we have provided them with this. So these are some of the incense sticks what they have. So this is a Google, like you can light up, so it really spreads fragrance. So these are small tips what we can give them, and this will really help in being in touch with them. So this is one of the example. He's Master Muhammad. So what he used to do is he would be there in one of the shops where they would sell tobacco. So I told him that this is wrong and we have to do. So what we did, we gave him this. It hardly costed 500 now. So he's doing that, and he's a very camera shy. He's like, "My photo nahi khichwaunga. I would not get my photo clicked." So I'm like, okay, just see, let me be with there. So these are small steps of empowerment. Now he goes and preaches everyone not to have that. He has made his father stop. He makes it everyone stop about it. And he is one of our, entrepreneur for this. Coming to various NGOs where they would empower women, we have these self-help groups where this is one of the event we conducted in Akanksha, which is by the officer's wife. So they empower the women of the underprivileged section. So they make all these papdi chaat and matri and everything where they can have, So there we had inculcated. So he is my son. So you can see him. I carry both my kids wherever possible so that they can also have this drive of, promoting the awareness. So he is also one of the very camera shy people. I don't know, when they are young, they are more active into, promoting the health factors and all. When they become a little elder, they are more of shy. So there we can promote them what is the flossing and role play method. So if he is doing one thing and he would give it to the other female also, that she also has to try out the same. So it will be a playful thing for them. My daughter, she had a project in her school, and I was very happy that she could, take that. I did not tell her for that. And because kids, when they are of 16, 17 years, they do not talk to their parents about what is to be taken or not. But I was really very happy when she took this as forte and tried teaching in their mela, Hunar Mela they have. So she taught about how, oral hygiene is there, and this is the model of whether root canal is there and how do they do it and what are the layers and all that. So these are small things like which really took us. Then visit those self-help groups. There are Asha workers, Anganwadi workers. If you go into those details, you can go and talk to them. So this is one, like Brahma Kumari, we had conducted this camp and we had adopted this village also. So initially, we made her one of the, ambassadors for our oral health program. And she talks to the women about the importance of what oral hygiene is, and also what overall sanitation, like, because now there is more of awareness of breast cancer, cervical cancer, and oral cancer. So we have also spoken about the oral cancer. I go there regularly and speak to them. Then maternal and child care awareness, because that is very much important. I told you about how women in particular, they are not, taking care. So we talk to them about that the child's health is more important, but the most important thing is your own health. Like, how do you take care of your health is very important before getting pregnant and in between pregnancy and after that. What is the importance of, breastfeeding, how it impacts your child. So all these things would encourage, and early visits as infants and toddlers, not just taking care that, okay, these are milk teeth and they would go anytime. So not that, and even the nutritional factor, what they need to inculcate in their own, hygiene and things. Then topics like pregnancy, oral health, we do visit them in, these neonatal wards, and we give them small things like, a tub or a thing, so that these are some, mosquito net and cereals like dalia and dal, something like that we give them, and oral hygiene things like a mouthwash, toothpaste. So this is happy. And we also talk to them, because otherwise if we just talk to them saying that, okay, oral hygiene is very important, you have to brush 2 times a day and you have to squeeze your mouth twice a day, it is not going to make any difference. Once you give a goodie to them, I think that will make it more memorable. That's what I feel. Then adopt a village, I have already told you. One dental team should regularly visit and ensuring, the continuity of the care and as well as the follow-ups. Also, we have, like, I am in a government institute, so our director, sir, he also is very proactive. He is from community medicine. So he is also very proactive, and we identify small villages and regularly conduct these health care camps to improve the oral health status of them. So this was we had conducted in one of the villages. So there has to be door-to-door campaigns as well. So we go and visit those people like who are bedridden. We talk to them. We, share them how their oral hygiene is to be taken. This I learned the importance when I was given a task of, training those those brothers and sisters who are posted in emergency ICUs, how an oral health is to be taken care of if the child, if the person is conscious or unconscious. So I thought maybe why not go to the houses as well and find out oral elderly people, because they are so dependent, they are frail, they are not even able to speak. And what about their oral hygienes? Why would they get undetected? So we go and speak to them. So this is the house of a specially able Cheshire home where I have been a member. And then we go to those villages, and because we are now like a part of their family, they allow us in their houses, and we can see what kind of area they are in, whether it is smelling or whether it is kept cleanliness. And focus based schools hygiene camps should be there. The focus should be on maternal and child care health, what hygiene they are taking, what kind of nutrition they are taking, what is the importance of vitamins in their food, vitamin A, B, C, and they need not have to have fancy foods. They can have proper seasonal fruits. Your amla is there, where they can have mosambi is there, which is rich in vitamin C. They can have cheese as that can be procured. Curd is a good probiotic source. Your green leafy vegetables. So all these things can be inculcated in them. The now we are more into wheat, bajra, and all these things, and less refined food for that matter. Brushing and flossing and fluoride application and checkup wherever it is possible. We also go to those areas and check their water fluoridation part, how the waste, biomedical waste, how it is made. This is one of the plant where they have a compost being made. So they do it, and then how the water is, like what kind of TDS the water has, because fluoridation also plays a very important role. Go to their kitchens where they are there, so that to monitor and talk to the cooks about like what oral hygiene is and what kind of things they can have to inculcate good oral hygiene practices. Awareness walks are very important, 4th February, and there are many World AIDS Day. We always have that. So go to those incorporate all many social activists, school girls, and everyone. So this have these small awareness, self help groups. So awareness walks are very important. Speak as much as possible about oral health. Voice your opinion. Talk to them about any other fraternity, be it your oral hygiene, be it your tobacco cessation, or be it the health of children, or be it what kind of problems even a crowded tooth would have. So these are the some of the events what we had conducted. Community-based oral health talks, monthly dental health checkups, practical demonstrations. So these are all the repetition ones, including of your nutritional discussions. When we have kitty parties and all that, we discuss about other things. So they are not my cup of tea. So we have something like talk about women health. We have these small NGOs where they have like YouTubers or maybe real promoters. So we talk about women empowerment, women health, oral health. So what all it can have, because I feel if you teach one mother, she's not going to be illiterate. Her whole family is not going to be illiterate. So you are actually, teaching 2-3 generations of hers. So this is very important. Go to the social media and get yourself published, or maybe if you do good work, I think those people are only going to come over and they can talk about it. What kind of problems, if you have a good cardiogenic potential, one will have, if you do not brush your teeth properly. So all these things. So we do have eco health programs where we have collaborated with one of the government officials, where we can have WhatsApp and mobile learning. So now only the sky is the limit. You can talk to the ANMs, all these CHC, PHC center doctors, because lot many times these are not the dentists which are there. So they are the health professionals, sometimes even a pharmacist in the rural areas where their last mile, even your digital health, or maybe they would not reach. So we have a PHC center. And when we were working with E-Sanjeevani, we had this spoke and hub method. So we were hub and they were the spokes, So they would refer to any of the particulars. So because when we are working in a tertiary center, so lot many times the tertiary center gets overburdened. So when there are many small issues which can be handled it in their own, sections. So the attrition in those areas or the burden in the tertiary centers would be reduced if we can guide them or we can train them. get collaborated with the local government health officials and have certifications where the people who are posted in the rural health areas, they get, talk. And this was about the geriatric illness and its management. And we had presented one of the oral lectures, talk to the train the dental surgeons or maybe a doctors who are posted in them, talk to ASHA workers, ENM workers. So this was by Shifa, that is State Institute of Health and Family Welfare. We had conducted a program for 7 days and we had 5 batches of it, which I was one of the module designer and the main person concerned. Talk to them, take small workshops, and this is our PS sir, which is Principal Secretary sir, Dr. Parth sir. He is also one of them, Dr. R. Ganapati sir. So I have got help from many of them, whomsoever I have been able to be vocal about. Have interactive skills, street plays on oral health. Talk to them about malnutrition, what oral cancer can be. And, they always attract people rather than talking to them about one particular theme. There are many ways you can have it, in a way that they can understand. So I feel having Nukkad Natak and having these street plays a very important role. And also we talk about more of domestic violence, because lot many times the patient comes to us with a broken tooth or maybe with the other things where you can feel like, okay, domestic violence is there. So they are all done in very local dialects. Cultural references are always given to make it more engaging. And importance of oral health checkup, we have our director, sir. I always tell him, sir, these are the important days you have to come and see, and need not have to be anywhere out. You can do it in your OPDs as well. And when you are posted in your own clinics, you can go out and spread awareness in your markets. You would have, people in and around. You may have small shops, big shops. You can just go. Only effort is the one which is, to be taken. Organize health pledge programs. And this was the special group activity what I had done with the transgender people. And it gave me immense amount of, satisfaction with them, because and imagine the plight, we did not get a place in Lucknow where we could hold that. And this was held in a park. It was held in Lohia Park. And we danced with them. I spoke about it, and this was a CSR activity. We had done it with GSK. I took support of them, and I do not feel any hesitation in asking for the cause, and I do get help from everyone. So they were the ones, they came up with the social stigmas, what were assigned to them about their oral hygiene, because everyone talks about, disabled and specially abled and, weaker section of the society. But I felt like these community also have some respect, and they also are a part of us. So we had conducted with them. Then there are special drives. We take part in cleanliness drives, because if your area is clean, only then your health and other healths can be there. There are tree plantation drives. You should always come and, come forward for that. Mobile dental vans are there. So they are also very of the cost effective ones, and lot many school colleges and other people do have that. Then there are teledentistry programs which we had conducted. This was with ITU. Telemedicine was the first world conference what we had held in RML, and I was one of the organizing secretary in that. So this is also one of the helpful things. Have local workers, ASHA workers, which are appointed. You can give them the lead of conducting all these things. Establish rural help desk. So this is Dr. S.K. Mishra, sir. So he had the privilege and he had the capacity. So he had the kiosk which were incorporated or installed in along with IIT Kanpur to SGPGI Lucknow. And if you have the thing, please go and visit that. He is presently with us, and this is morning ka photograph what we had for oral Women's Day. So have these objectives, have that self-awareness groups where you can talk about, oral preventive careness, how your self-assessment also leads to. Now this is more vocal about how breast cancers are supposed to be, screened. Same way, oral cancers also have to be screened, and it will create awareness. There are various NGOs and other oral health programs by National Oral Health Program, Ayushman Bharat, and Prime Minister Jai Bharat. There are RSBK also and other national tobacco programs which are there. Community outreach programs, I would say, why did I take this topic is because it should not be like it incorporates a lot of things. It does not incorporate much of a cost. It is just 2-3 people which they have to go and they can exercise. Even one person is enough if you want to do it. And integrating oral health with general health programs. call to action, how dentist, NGO, and government can work in collaboration with each other. There are private party and government officials can just negotiate, and they can come up with MOUs where they can who have that oral health missions, expanding the mission beyond initial outreach program and encouraging policy level advocacy. I would have, if I have time, can I have the leeway of taking one of the pledge? We just took it yesterday to the school kids where we are telling them about, what is the importance of having this pledge as oral cancer awareness. It's a little long. I think I'm exceeding more time. But if you need this pledge, let me know. I'll post it in the group. So thank you so much. I think when you want to do something, it is always, this is my department. So this is just morning ka photograph, because we had one program as well where I was one of the organizing committee people for Women Day. So, and this is my son, like we were
Dr. Shelley? Dr. Shelley, your screen is frozen. Dr. Mahajan? Dr. Mahajan, we cannot hear you. Hello. Can anybody type?
any time of thing when I see,
Yeah, you. That's all right. Just make her the host again. Skill, make her the host again. Yeah, I think we lost connection with Dr. Shelley, and it was a very interesting and engaging lecture from her side. And there are so many of you who would want to connect with her also. I see some technical glitch on the.
I can hear you.
Yeah.
Dr.
Yes.
Sonal?
Yeah. Now you're visible. See what happened after the pledge? Maybe you were winding it up only, and the screen got frozen at that point. Anyway, just smile for the camera.
That was the last. And
Yeah.
anyway, I was just talking about it. And thank you so much.
Yeah, just smile
Again.
for the camera. Okay. So Dr. Shelley, it was a very different way of lifestyle, I would say. This cannot come in one day. You cannot say that you will help somebody for 1 hour, half an hour or 45 minutes, and then you're done with it. It has to be inculcated in your lifestyle. And I'm happy to know that you are passing the wagon to the next generation, and your kids are also involved in it. And that says a lot about you, madam. Hats off to you and your organization, because it's not everybody's cup of tea to contribute to the society wherein the only satisfaction they're going to get is their smiles. I doubt there is any monetary gain in this kind of an organization, but then things said apart, it's a big mission that you're carrying. And can you just enlighten who was the inspiration behind this? I know for your kids, you're the inspiration for sure, but who was the inspiration behind this? I think she's frozen again. Yeah.
I have lost.
Yeah.
I think
Who was
the voice is lost.
Yeah. Who was the inspiration behind this, ma'am, in a word?
My father.
Oh, yeah.
When I was a kid, I used to travel with him. He's into Lions Club and all that. So he's governor of there. So I used to go, we used to organize eye camps and all that. And we are two sisters. So I thought maybe, this is something which I would, and I feel connected whenever I do it. And this is not every day's work. This is not at all every day's work. This is just a small thing. And I have started, doing it even when I had passed out from the dentistry. So this is not one day's job, or maybe, the documentation has been done, but this I've been doing when I was in Saraswati and dental college. Like before joining RML, I was into different colleges as a PG teacher. So I have had like Saturday and Sunday, maybe Saturday half day and Sunday. So whenever everyone used to ask me about anything to conduct a camp, I would never be able to say no. I would definitely get time, and it would revive me, it would revive me to perform my next week as enlarge.
Yes,
So
ma'am. It was a pleasure knowing this side of you also. There are some questions in the chat box if you will be kind enough to address them. And with that, I would like to invite our next speaker, Mrs. Neeta Menzies. And she is not a dentist, but she is somebody we all dentists should ought to sort out to, because she is going to be talking about the money factor. Dr. Neeta, Miss Neeta, can you just switch on your camera as well as your mic?
Hello, can you hear me?
Yeah, we can hear you. Yes, you are there. Okay. So, Ms. Neeta is actually the founder and chief mentor at Financially Smart and Money Prashtha, author of, and she's author and she is certified financial planner, national president at WICCI, and on financial literacy and management council. Ma'am, for us, all these are layman word. When it comes to money, we just think about counting the money part, but when it comes to financial hygiene, we dentists may be lacking somewhere. And I'm sure you have many clients like us, or rather me, who are not very well versed with the financial aspect of it. So you are going to be giving us 9 financially smart moves empowering women dentists for a brighter future. So welcome to the team, ma'am, and the stage is all yours. Thank you.
Thank you so much. Thank you so much, and thanks for inviting me. In fact, I should tell you, I wanted to be a doctor, but the career trajectory of mine suddenly changed when I encountered money and had done a costly mistake some years back, and then I ended up being a financial doctor. So, in fact, some of my doctor clients had named me as a financial doctor. Right. So, can you hear me? Am I clear?
Yes, please continue. Please continue.
Okay. So wonderful. So, in fact, yeah. So, and today's session that we're talking about is going to be financially smart moves. So, I've listened to the last 2 presentations. One was phenomenal, where we're talking about dentistry as being as an entrepreneur. And the one which Mrs. Mahajan spoke right now was so amazing about giving back to society while you are actually doing such a fantabulous job. So in fact, when I've been meeting so many clients, so many doctors, I realized it's such an amazing work that you are doing for humanity, especially, it's throughout the years. And when it comes to dentists, there's so much work. I mean, so much that I learned today about oral health care, which is so important, which normally we take for granted. So with that, let me just, today we're going to talk about the very important thing, that is about money. So money is such an important tool, that's what I've seen. And I realized this early in my life. And so I decided to start a movement called as Financially Smart Movement. And today being Women's Day, first of all, happy Women's Day to all of you. I would like to share with you one minute. Yeah, I should see the screen. Yeah. So today, when I was looking at, the economic life cycle of dentists, when I've been looking at various doctors as well, we feel that there are, each one of you would be aware, it's about first the startup phase. When you start off, normally you are at the age group of around 26 after you finish your education. I feel normally it's 5 years of graduation, which is there, which is up to 21 or 22 years that you complete. Then you have an option whether to start your own practice or join somewhere as as an employee, where you're practicing with a hospital or with some other dentist. And at this time, or the third option is whether you go in for specialization, like each doctor goes in either maybe for a dentist, and in dentist there are various specializations. So the first 26 to 35 years is normally when you say the startup phase. Then comes the peak earning years, which is in the growth. I would say that would be around 36 to 55 years, which is around till the maturity phase. And finally comes the cooling off period, wherein it is your retirement, or normally I've seen my dentist clients between 56 to 65 or till health permits. That's how is the economic life cycle. And it is always said you need to make hay when the sun shines.
So you need to make your money work for you. And that is what we are going to talk to you about today, because money is such an important tool. We all need it. We all require it, but we do not know how to manage it. So when I talk about financial freedom or about money, one thing I've realized it is we need money, and we need money because we need to have the freedom to choose. Money gives us the power of choice. The choice how to use our money, the choice whether we want as a woman, now because it's Women Day and I'm talking to women dentists, the first thing that I look at is, whether if you have money, you are able to make various choices. You're able to build up your support system and get back to work. You're able to actually decide whether you want to get married, whether you want to travel, whether you want to start an entrepreneurship. Money is an important tool which will help you and will require in all these various things. And when it comes to doctors, as I said, other than, when I look at corporate executives or business owners or other people that I deal with, I realize when it comes to doctors, your economic life cycle, the money starts coming in maybe from your age, say 20, 30 or 35, actually, when it is someone who is, setting up a practice. And when you set up a practice, it also comes up with high costs. Even medical education today is expensive, right? So after all the education costs, there could be debt loan, that is educational loan, which is there that you're repaying. Plus, then if you're setting up a practice, you need to get equipment, because in dentistry, you need to also get a place where you can practice. So all these things are going to come side by side. And apart from that, as a woman dentist, we've seen that women require financial independence and autonomy, which is even more critical for them. Why? Because we women, when it comes to us, one thing is we may need to take career breaks. One would be, when you are carrying. The second thing would be when you are having a child and you have to support the child. Normally, it's a woman who takes a back seat and she tries to manage both work as well as the children. The third thing, even when it comes to elder caregiving, it's a woman who is there who normally again decides and says, okay, I will manage both the things together. Having said that, there is a gender pay gap parity which is there in India. When I say gender pay parity, there is the men normally are paid for the same job, for the same skills, they are paid higher than the women. And this in India is around 34% today. So we are paid lesser. Second, women, as per statistics, women tend to live much longer. If you see 87 and 83, that's what they have predicted when it comes to around 2035. In 2013, the age expectancy of a woman, her life expectancy was 82, whereas a man was 78. And now with medicine becoming much more advanced, by 2035, it has been said, women will live at least till around age 87, whereas men around 5 to 6 years, their life expectancy is lesser. And finally, one more thing, it also is costlier to be a woman. If you see the two razors out there, that's called the pink tax. The products that we women use, most of the time, are more expensive. There is a premium or a markup when there is a pink additional, sense done to it. Like even a simple razor that is marketed or that we consume, the things that we consume, even in the forms of, our shampoos, our conditioners, even a haircut. When a woman actually goes for a haircut, it is going to be much more costlier than a man. So this brings us to the point that it is actually costlier to live the life of a woman. We are paid lesser and we have a longer time to live. So it is so much more important that we women need to actually take charge of our financial lives and not just depend on our father, brother, husband, or someone or the male person in the family. As I always say, your financial plan is not someone else's plan. It is your plan. You need to take, and your man is not your financial plan. You need to take charge of your financial lives. So, as I said, not only we do need money to last us longer, it costs us more to be a woman, and we also have less coming in. So what do we do? So I would like to first give you a 3-point action plan. I've promised you 9 steps that I will help you with. But first, let's start with just 3. The first one is educate yourself, my dear dentists, my dear women dentists. My appeal is to you to educate yourself about money. Start reading about money. I would say go ahead and at least every month set aside minimum 30 minutes, half an hour for yourself to get familiar about money. Simple thing that what is my earning? What are my cash flows? How is it? What are the investments that are available? What are the investment options that are available? If I'm, investing, am I investing in the right kind of product based on my risk appetite? Start reading about money. Attend courses. Invest in books. I'm an author as well myself because I felt that women need to read something when it comes to financial planning. So I've written my book recently, which is Be Financially Smart, A Modern Woman's Guide to Money. So educate yourself, and unless it is not scheduled, you will not do it. So get into your calendar and, like any appointment, set an appointment of educating yourself about money, specifically about money, at least 30 minutes in a month. The second action plan that I want you to do is have money conversations. I've always seen when men talk about money, when men get together, they always talk about money, they talk about discounts, they talk about, even today, there are crypto bros who are around, they talk about the equity markets, they talk about real estate, they talk about so many things. But when women get together, what are the conversations? About children, about sales. Okay, this is being sold Netflix, about maybe some Netflix and movies like that. Or it will be sales like Nika. Okay, this sale has come out. Or it would be something, but nothing about money. So I want you to ensure that you start talking about money and make this conversation not something very taboo. Today in India and across, which I've seen, sex and the second thing is money, that is very taboo about talking. So we need to break that paradigm and say, no, we can talk about money. A simple conversation starter could be, okay, if I'm planning my vacation maybe 3 years down the line, or maybe after 6 months, how much do I need today? And how do I set aside money for that? Or how much would I require for my retirement? Or how much money do I require to set up my practice? That's the money conversations that you need to start talking about. And the third most important thing is start investing, however small. Start, because it is important to start. Like I always say, there is potential when you have knowledge. Once you educate yourself, knowledge will be there. Once you start talking about money, you will get the knowledge. But unless you put that knowledge into action by putting your hand on the start button, you will not be able to learn. Even swimming is learned by getting into the water and then swimming. Right? So similarly, when it comes to learning about financial planning and about your money, you need to start investing, however small it is. Even if you can start with 500 rupees today, you can start a kind of an SIP, which is a systematic investment plan through mutual funds, and you can start growing your money. Right? So 3-point action plan, which all of you need to do. And as a reason, because of that, I said, I want to give you a system. I designed a signature formula. Since my company's name was Financially Smart, when I decided to design my company, I said, what do I name it? I thought of many names: Financially Savvy, Financially Good. And I finally zeroed down on Financially Smart. And I said, I want to give a message even through the name, where each letter of the word smart stands for something. And I said, why just smart? Ye dil mange more. So I made it smarter. So to be a financially smarter woman, if you follow this formula, I'm sure you will be able to get a healthier, wealthier, and a stress-free lifestyle, which all of us need today. And women, we definitely need, because we just saw that our cost of living is costlier. We are going to live longer. We are paid lesser. And we need to make best of the time that we have in mind. So what is the financially smart formula? S stands for saving habits. You need to have money, so you need to earn. Once your money comes in, you need to save that money. Now, saving should be a habit. And for that, I say, when you save your money, you need to ensure that when you receive some money, when you say 1 lakh is your income, for example, normally what happens, people, the money comes into the account, then they start spending. And then by the time they decide they want to save and invest, there is no money left in the account. So the right way or the smart approach is about, if you're earning 1 lakh, first set aside, say minimum 20%. Normally, I would say someone who is as per the age, that's the minimum I'm talking about, 20%. But if you're 40 years of age, try and save minimum 40%. But start off with minimum 20%, the minimum threshold. Start saving that money, automate that investment, and then spend the remaining. Once you get into this saving habit, you will be able to actually develop much better way of investing. The second one of smarter is M, which is money management skill. Just like we need to have communication skills, you need to have various other skills. Money management skill is very, very important. And this was not being taught to us in schools, not taught to us in colleges. My doctors who are MDs and surgeons who are earning even 1 crore a month have told me, Neeta, why was this not taught to us in school? And hence I decided to create a system again for money management skill, which is in the form of 6 different envelopes. So once you save your money, the 20% or 30%, whatever you decide to save, how do you put it into 6 different envelopes? So once you decide that, once you develop money management skills, the third thing is attitude, your mindset. You need to know that your mind, your brain is the most important thing, and our brain is not trained to be disciplined unless we train it. And once we train it, it is like a muscle. It will do extremely well. So you need to give your brain the right kind of messages, the right kind of attitude, and have the right mindset. When I say mindset, it is about ensuring that you need to ask how much, if you say, okay, do I have enough money? Instead of asking that, you need to say, how much do I need to achieve this? Start asking your brain and you will start getting the solutions. What can I do to afford this? Suppose you want to set up your own practice. One way is saying, oh my God, setting up a practice is too expensive. I will need so many loans. I will need money coming in. But the other thing is, okay, how can I set this practice? For that, what do I need to do? What is the amount I require? And how do I start saving and investing? What are the loans that I will get? And you will start training your mind accordingly. So A, that is the attitude and mindset is most important. Then comes resourcefulness. We are all having a smartphone, but how smart are we? On the click of a button, we have so much information available. There are curated courses which are available. In fact, I do a lot of courses. I have my own website, www.financiallysmart.in, where I conduct various courses. I do workshops where I train people on each of these aspects, and each aspect of this is almost a 5 to 6 hour training. How to manage your money, how to invest your money, where to invest. All those things are various things. So you need to ensure that you use the resources that are available and start learning, educating, and then implementing. Then comes the T and the E. If you see, I've highlighted that in green because these are the 2 most important things that you need to remember. T is time. You need to give time for your money to grow. You can't just invest and say, I want my money to grow within 6 months. No, it is not possible. Even when you plant a seed, you need to nurture it. You need to water it. It will take time. And once the seed gets into a plant and then it gets into a tree, then it will give you a fruit. So when it comes to our money, also we need to think and plan it accordingly so that we know that what money is required for an emergency or short-term goals are there maybe in things where it is easily accessible. Money which is available for the long term should be given time to grow. And today when we talk about long term, we have to talk about at least a decade. Because There is a magical power, my dear friends, my dear women, which is called the magical power of compounding that starts working on your money. And that happens only when it is 6 years plus. So you need to give your money time to grow. And where do you create money? Where do you create wealth? That's the E. You can generate wealth if you put your money in equity. You can't keep your money at home. It will not grow. You can't put your money in the bank, in a savings or an FD account. It will not grow because there is a silent killer out there which will not allow your money to grow. And I will address that in the next slide. You need to invest in equity. You need to invest in other businesses. You need to invest in the equity market. And the safest way to do it is through mutual funds, where a fund manager is there who helps manage the entire businesses or the stocks that you are invested in. And it is diversified. So you can use equity. And once you build a desirable portfolio through your mutual funds, then you can move to the next higher level, which is stocks. And finally comes R, the review. So review is very, very important because it is about understanding how you decide what is happening in the entire process. You can review, it's like revision. So you cannot just fill it and leave it. You need to check on whether you are following the right saving habits, whether you're doing the right thing. These things are required. And that's the smarter way to wealth, which is almost the 7 points that I have given you. So now that we know what is the smarter way to wealth, the next important thing is to know how to achieve a goal, because the 3 key elements of achieving a goal, 99% of doctors that I have met do not have a written financial plan, my dear friends. And the reason being, they have said they do not have time to plan. But one thing is clear, if you do not know where you are going, any road will do. So you need to have a plan in place. And when you are setting a goal, the first thing that you need to do is understand, know the purpose and name the goal. Why do you need that money? Name it, because again, our brains are wired in such a way that we have emotions. So if I set a goal saying that I want it for my child's education 10 years down the line, then I know that fund is being created or that corpus is being created for my child's education. So I will not touch it if I want to go on a vacation. Right? So you associate it with the purpose and name it. The second point is, how much do it cost today? Now I'm deciding for my child's education 10 years down the line, for example. And I might think to myself, okay, as of today, maybe 5 lakhs or 10 lakhs is good enough. But as I said, there's a silent killer called inflation, which is the purchasing power of our money. And that silent killer actually eats into our money. So we need to ensure that whatever money is there, right, we need to ensure that it beats inflation. If our money is lying in an FD, and if an FD gives us, say, 7%, and if inflation is 7%, then we are actually not earning anything. We are not able to generate wealth. And there is education inflation, which is around 10% today. There is health inflation. Hospital bills, if you had seen during COVID and all, that's around 8 to 9% or more. There is food inflation. So when you want to generate wealth, you need to ensure that you invest at a rate which is above inflation. So you need to ensure that you increase your savings rate. When you're saving your money, when you're doing 20%, start from 20%, maybe go to 30% or 40%. And whatever money you save, put it into the money management skill, the 6 envelope method. You can check out that on YouTube because we do not have enough time today, but you can check out my courses or on my YouTube. And once you set up that, then when you invest your money, invest it at a rate higher than inflation. Right? So once you do that, the third thing about the goal is understanding, when do I want it? And once you do all these 3 factors, you will be able to achieve your goal. So when you plan as I said, you need to have 2-3 things. Even before investing, once you save, once you know your goals, and even before you start investing your money, you need to actually look at these 3 important things. Your risk management, which is first, which is set aside an emergency fund, which is for you doctors, if you're into practice, I would recommend 9 to 12 months of expenses should be kept aside so that in case of any emergency, like COVID, which had happened some years back, or in case of health issues where you're not able to go back to your, or attend patients, or if you want to travel for some time or for any reason, 9 to 12 months should be kept aside, maybe in an FD or a liquid fund. Then comes have a health insurance policy. Very, very important because we have a lot of lifestyle diseases up today. And hospital bills are just hitting the roof. And the third thing is buy a term life insurance plan. Most important. And ensure, since all of you are doctors, you are professionals, you are almost as good as entrepreneurs, ensure that your insurance policy of you and your husband is endorsed under the MWP Act 1874 so that no creditors can attach to your insurance policy. Because in case you're buying equipment, in case you're investing in a place, if you're taking loans, there will be liabilities. And God forbid, if anything happens to the person who owns the insurance policy, there should be no creditors who are attaching to that, and that should go to the rightful beneficiaries, which could be the wife or the children. Once that is done, the next part is about your goals. Plan for your long-term goals. Plan for your retirement. We do not have a social security scheme in India. I've seen a lot of clients planning for their children's education. But believe me, for education, they will get a loan. But for retirement, you will not get a loan. So you need to ensure that you plan your financial freedom. Plan your retirement from day one and start investing from now. Start investing. If you're 30 today, you may have around 20 to 25 years. Start putting aside that money in an equity mutual fund, which is long term, and fill it, shut it, forget it. Let it grow, let it compound. And then look at long-term and short-term goals as per the goals that I mentioned to you. And finally, also check your nominations, write your will, because the money and the various assets that you've created in so many years, you would like to pass it on seamlessly to the next generation. Also check out the nominations that are there in your existing insurance policies. Is it up to date? In your investments, which are current investments. So do a checkup of all those things. And so since I have limited time, I would suggest that to enhance your knowledge, as I said, the first thing is about educating yourself. You can pick up a copy of my book. This book, Be Financially Smart, The Modern Woman's Guide to Money, is available at all stores, online and offline. I've talked about a lot of things in this book. It's a 7-step action plan also given in this book. I've talked about the 6 envelope strategy that I've talked about. I've also spoken about how you need to build your support system. What are the various red flags that you need to see when you look at various investments? There is a lot of information. So if you want to educate yourself, one, you can visit www.financiallysmart.in, where I have a lot of courses where you can update yourself, learn about money, and you can start talking about money. And yes, if you want to invest, start off even with 500 rupees. Start. The most important step is to start off. You can visit my website again, www.moneyprastha.com, where Money Prastha means, Prastha is a Sanskrit word, which means your platform, which is your platform for your money, where you will have a coach who will guide you and you will be able to learn and also implement, because it's about doing, first learning, then doing, then teaching. And you also can give back to society by spreading the message that financial freedom is important, financial literacy is important for women, and it's time to get financially smart and be a part of this financially smart movement.
Very well put, ma'am. Very well put. Thank you so much for enlightening us on this very difficult topic when it comes to money management. We are working for money, but we need the money to be worked at, like let the money work for us now. So time has come for that. Ma'am, if you can just stop sharing the screen, we will like take a picture.
Sure, 1 minute.
Yeah, stop screen share. Yeah, just smile for the camera. Yeah, thank you so much, ma'am. And it was a pleasure having you on board. I've understood now, even if I ask you the question, you will be like, tell your younger self, older self, whoever it is, start whatever it is. But what is the inspiration behind your journey of success? Like, who has been the inspiration?
So for me, the inspiration was when actually, as I said, I wanted to be a doctor, just like any one of you. I was studying to be a doctor, but I realized it's not about being a science student or about a commerce student or anything. It's about when it comes to money, personal finance is more important, and personal finance is more personal than finance. And when the people around me were the inspiration, when I started seeing them, I said, okay, everyone needs to deal with money. And that's when I decided on my journey. So
Thank
from
you.
being a doctor, I decided to be a financial doctor.
Thank you so much for this guidance. And there are questions in the chat box if you can answer them, and drop in a link for your book also. On that note, I would like to call in our next speaker, Dr. Nupur Srirao.
Hello, am I audible?
Hi. Hello, Dr. Nupur. And Dr. Nupur is a known name when it comes to organizing conferences and being a part of the conference. And Dr. Nupur, welcome to International Pink Dental Congress Season 3, 2025. And she's a MDS prosthodontist, fellow in aesthetic dentistry, owner of Surjit Singh Eye and Dental Clinic, and founding dental consultant at Prabha Medical Center, yeah, Chandigarh, and editor of Dental Reach and Cactus Communication. Today, Dr. Nupur is going to be talking about treatment options in prosthodontics. Nupur, smile for the camera, please. I can fondly call her Nupur because she is my darling Nupur. Nupur, start sharing your screen, dear. Share screen, the green button down.
Wait, to check my settings.
Below, you'll see a bar where you will have a share screen option.
Need to. Okay, I will have to log this.
There's some network communication disturbance. What is that, Nupur?
I will probably have.
There's a network error, dear. Yeah, so that was Dr. Nupur. And after this, we actually this session for this timing was scheduled for Dr. Shivangi Jain Gajwani, but due to some medical emergency at her home, she has shared a video to us, and I'll be playing it at the end of Dr. Ruchika's lecture. We will be playing that video for you all, and she has been kind enough to uh, record the whole lecture, and she shared it with us. The only thing is that due to the technical glitch, we will not be able to share it right now. But at the end of Dr. Ruchika Sood's lecture, we will be able to share. And I think Nupur is back again. Yeah, Dr. Nupur, start.
Am I visible, audible? All right. Can you hear me?
Yeah, we can hear you. Just start sharing the screen. Yes, yes. Yeah. Press on the presentation.
Yeah. All right.
On
Can
the
you see
slide
my
share,
present?
please. Yes, play. Yes, go ahead, Nupur. Go ahead, Nupur.
All right. Okay. Okay, good afternoon, everyone. I am so sorry for that small technical glitch that happened. My apologies. And but wishing you all a very good afternoon and very happy Women's Day to all the female dentists who are watching this webinar. And a big thank you to all the male dentists who have registered for this conference and supported us in our feminist endeavor. I'm a prosthodontist, as very kindly introduced by Dr. Sonal, and I love my subject, but I am aware that a lot of you don't like prosthodontics. because there are so many options and sub options and so many things to be taken care of. And even though prosthodontics uh, is something that you cannot escape from, as some private practitioners here would be knowing who are running their own clinic, you have to offer some kind of a prosthetic option to most of your patients. I will not say all, but most of them, like if you're doing a root canal, you have to offer them a crown or an onlay post your RCT. Or if you are extracting the teeth, you have to offer them an implant or a bridge. So there is no escaping prostho, right? And also, it is well paying. Uh, one of my very favorite female professors of my alma mater, Vayanti Dental College, used to tell me this very often. Endodontics and oral surgery is the bread and butter of dentistry, but prosthodontics is the jam and honey. So it is a fact. You have to know RCTs, you have to know extractions. You can't do without them. But prostho is something that you will be doing at a basic level. You will be doing some advanced prosthetic treatments also, and it has the capacity to fill in your pocket. Okay, so even if you don't like this subject for whatever reason, um, it is very important for you to change your mindset because it can cause a big change in your economics. So, for whatever reason, for the patients or for the economics, please learn it well and understand it better so you can practice it better. Okay. So coming on to this case, say a patient walks into your clinic or your college and says that, doctor, I have a difficulty in chewing on the right side of my mouth. You ask him, do you have pain? He says, no, I don't have pain. I have difficulty in chewing. And you're very impressed by me, or you're very impressed by Chitnis ma'am, who said prosper is very important, and you say, okay, there's a missing six down there, and it's your molar tooth, it is your chabane wala daant hai aapka, so we must replace it, and you start giving him options for prosthetic treatment, and you tell him that that is the cause of your difficulty in chewing. But is that what you should do? Should you do your prosthetic treatment first? So I think before we dive into the different treatment options, we should first know when we should do prostho at all. Okay, so there's a sequence of treatment that you have to follow. There are 4 phases. The first phase is your phase one, that is acute treatment. You have to address the chief complaint of the patient. You have to elicit a proper history. You have to ask him, do you have any pain, pus, discharge, swelling, and do accordingly. Do the treatment accordingly. So this includes your extractions, your resto work, your endo work, right? Then phase two is your preventive treatment, where you are doing your basic perio work like your scaling. You're doing a little bit of community medicine, if you remember, Tobin Peter. You're doing your fluoride treatment, you're doing your seal-in treatments, right? Then phase three, stabilization, where you are preparing for the definitive processes so that your definitive processes is more long lasting and is more stable. So, say a basic perio treatment does not help, that is, your preventive phase has not helped, and the patient a more advanced kind of a perio surgery, like say your flap surgery, has a lot of granulation tissue which you must remove before you're planning a definitive treatment. Or does the patient require a crown lengthening procedure? Or does the patient not require prostho, and in fact requires ortho? And we will discuss in the later slides. There are a few cases where there is confusion between, when to do ortho and when to do prostho. So we will be discussing that. And at the end of it all, then comes your definitive treatment, that is your prosthetic treatment, where you will be restoring the function and aesthetics by offering your patients treatment options such as your implants, bridges, or veneers, right? Now, coming back to this case, you will not give him a bridge first. You will elicit a proper history, and you will ask him if it is not pain that is your chief complaint. Difficulty in chewing means what exactly? Maybe there is this food accumulation that is happening in the molar, or maybe it is a root teeth which is causing him some kind of irritation because of which he is not chewing on that side. And you will address these two things first in the upper arch. Next, you will do your basic scaling so that we are preventing any further uh, ill health to the patient. And thirdly, you will be checking your missing 6 site. And as you can see, the mesodystial diameter is very less. So even if you're planning a prosthesis, you need to do something to that 7. So do you need to do a prophylactic RCT, or should you upright it orthodontically? That is your phase 3. And your phase 4, your final phase, is then your prosthetic phase, that is your replacement of missing 6. Now, replacement of missing 6, what options can you offer to the patient? You can either offer an implant or you can offer a bridge. We'll be talking about implants first because I think there is more confusion regarding implants, because it's comparatively a newer branch, and everyone is interested in implants more. So I will be addressing the confusions regarding implants first in my presentation. So we know that implants are better than bridges because they conserve the tooth structure. There are more advanced kind of a treatment. It's good for the bone, and also a better result aesthetically. And there are some cases where you have to replace it by like it is best if you can replace it by an implant. For example, if the canine is missing. Canine is a very important tooth in our mouth. It is best if we can retain the tooth. For some reason, if it is lost, then it is better to replace the missing canine with an implant rather than a bridge, because your canine is responsible for taking up a lot of load and your occlusal harmony. And if you're planning a bridge there, your lateral incisor is not strong enough to take up those loads and be like a good abutment. So it is better to go for an implant. Distal extension cases. Distal extension means that there is no posterior abutment only. Say a missing 6 with a missing 7. So there is no posterior abutment. It is better to go for an implant because you must not give a cantilever posterior bridge. Okay. But some cases are better off with a bridge. For example, if your abutment teeth have been extensively damaged because of caries, and you have already done root canal on them, and you are going to crown them, then it's better you give a bridge. You have to give one more tooth, you have to give the pontic, and you give a bridge, and that's that. A lot of contrasting literature on this. Some literature says that implant, even in this situation, implant has its own advantages because you're saving that little bone there, you're stimulating that bone there. But my personal opinion, and according to the literature that I have mostly read, I feel it's just best to just replace it with a bridge. And of course, your osteoeconomics. So usually implant patients, either the ones who have bone don't have money, the ones who have money don't have bone. So in such cases, best is you go for a bridge. Say you have decided to go for an implant. Next question is, should we go for an immediate placement and should we go for an immediate loading? This is the most confusing thing for people. Okay. So if you have coming on to placement first, how do you decide if you want to place it immediately? Immediately means you want to extract the tooth and you want to place the implant, or you want to extract the tooth and you want to wait for some time and place it after 3 to 4 months. Okay. You can do an immediate placement if your patient is absolutely healthy, has no medical condition. You can do it if he has adequate soft tissue and good bone and a good gingival, thick gingival biotype. You can do bone sounding procedure to find this out. And especially for your smile window cases, for your aesthetic window cases, it's very important that you have an intact buccal cortical plate. Very important that the case has that. In such cases, you can do an immediate placement. It is better to do a delayed placement when your patient is heavily medically compromised, or his maxillary sinus is involved, or he is a case of chronic generalized periodontitis, or has been using bisphosphonates, or he does not have that buccal cortical plate, or has a very active periapical infection. There is no consensus on smoking and bruxism. It is a relative contraindication, they say, for immediate placement, but I think it totally depends on the other factors that I have mentioned here. And also one factor that I have not mentioned here is your skill. Okay, if you can do an atraumatic extraction, only then should you plan for an immediate placement of an implant. Next, when do you load? Do you load it immediately or do you wait and load? By immediate loading, I mean on the day of surgery or within a week of surgery. So you can send the patient back after surgery, if, because it's a tiring day for the patient, it's a tiring day for you, and you can call him back, but within a week. After a week, it is not considered immediate loading. Okay. So if your primary stability during implant placement in a normal site, which was healed, and you had opened it was a missing sixth day or missing whatever, and you have opened the site. If you have a primary stability of around 35 Newton centimeters, you can load it immediately. If it is a tooth where you have extracted atraumatically, and the primary stability you have achieved has to be minimum 45 Newton centimeters for you to load it immediately. If you have a good D1, D2 bone, you can load it immediately. If you have a D3, D4 bone, but you have used very sophisticated implant protocols, like you have done implants like under preparation, which means like stepped osteotomy, okay, or you have done a subcrestal placement, or you have used your densa burrs and you have done bone condensing, and or you have engaged both the cortices and done bicorticalization. Okay, both the cortices, I mean the upper cortical plate and the lower inferior border over here for the mandible, and for the upper is the nasal bone. If you have engaged them and you've got, and for the posterior is the maxillary sinus lining. If you have engaged these and you have achieved bicorticalization, then you can do an immediate loading. And of course, all the factors that we discussed for immediate placement, in those factors also you can do immediate loading. It is better to do a delayed loading when your primary stability is less, or if you have a D3, D4 bone, which you could not, use sophisticated protocols for whatever reason, where you have done a lot of bone grafting, where you have done sinus lifting, and most importantly, if the patient is uncooperative. Usually everything else is great in the patient, but if the patient is uncooperative and you have immediately loaded it, and some problem usually happens with those patients only. So as a risk of abundant caution, you must just wait and do a delayed loading. Okay, so we've finished with implants. Now, you are someone who believes in crown and bridge dentistry, or you want to refine your skills more in your crowns and bridges. Okay, so when do you offer treatment of when do you offer a PFM crown and when do you offer a ceramic crown? Here by ceramic crown, I don't mean a monolithic zirconia. I mean a layered zirconia. That is a zirconia coping and उसके ऊपर porcelain का layering किया हुआ है. That is what I mean by ceramic crown when I'm talking here. Okay. So of course, if the tooth is discolored, you can offer both options to them. In multi-unit bridges for your anterior zone, okay, with a low to moderate aesthetic demand, you can offer them a PFM bridge. Posteriorly, again, low to moderate aesthetic demand, you can offer a PFM bridge. If patient cannot afford a ceramic, you will offer a PFM bridge. If you're planning of processes which requires the use of attachment, precision attachment or semi-precision attachment, you will have to use a PFM bridge because the attachments are metallic. Okay. And in cases where retreatment is required, then it is easier. PFM is easier to retrieve because we cement PFM with a GIC and we cement ceramic crowns with the resin modified GIC, which is more difficult to retrieve. So if you are feeling that little dodgy RCT case hai, may not be, I may have to do a re-RC in this, it is better you give him a PFM crown. Okay. Better not give a crown at all, but if you are like 70-30% sure you can crown it, better to give a PFM crown. If it is a multi-unit bridges in the anterior zone with a moderate to high aesthetic demand, okay, you can give them a ceramic bridge. And for posterior, with a low to moderate functional demand, you can give a ceramic bridge. And of course, ceramic, we are propagating it as metal-free. So in cases where there is a base metal allergy, you can give a metal-free, that is a ceramic crown. Okay. Now, the patient wants to go for a metal-free only. Then, of course, you have two options. You have Emax or zirconia. Here, Emax is the lithium disilicate actually, which we popularly refer to as Emax. And by zirconia here, I mean monolithic zirconia. Okay. So, patient with a very high aesthetic demand, it is better to give an Emax crown. And the patient with a moderate aesthetic demand, because zirconia is opaque and you may not get that perfect shade match, you can go for a zirconia crown. Okay. Emax lithium disilicate is also of two types. It is a layered lithium disilicate or a monolithic. Okay. So there are layers in that also. Yes. Okay. So for posterior crowns also you can give an Emax, just that you have to give a monolithic Emax, and you have to ensure that there is an adequate bonding surface. Even in Bruxers you can give, but adequate bonding surface matlab adequate enamel hona chahiye. Only then you can give. Why? Because Emax is a bonded restoration. Its strength lies in your bonding protocol. Okay. In 3-unit anterior bridges, up to second premolar, you can give your Emax crown, but not more than one bonding. Okay. For your partial coverage restorations, which are rage currently, your on-lay, your tabletops, everyone wants to do it. Emax is usually what we use for these kind of restorations. And your veneers, your laminates are Emax lithium disilicate, always. Coming to zirconia, of course, like I explained, a little opaque, so you can use it when the anterior aesthetic demand is less. Posterior crowns with, compromised bonding surface, you can or you can also use it in Bruxers. You can use monolithic zirconia in Bruxers, and you can use it for your bridges also. But you have to take care. Zirconia is a very strong material, but it is very weak at its connector. Okay, so by connector, it means that the crown height post reduction has to be adequate. If the crown height post reduction is short, it's a small crown, then your zirconia bridges will not work. Okay, short clinical crowns may zirconia bridges will not work. All right. So coming on to this, metal free and zirconia, ceramic, itna advanced ho gaya hai, aesthetic. There's so much of uh, everyone's focusing on aesthetic. So that leaves us to question whether metal crowns are outdated now, because they're unaesthetic, and it is like how in endo we have amalgams, poor amalgam restorations. They have, withstood the test of time, and just because they're unaesthetic now, and of course due to amalgam concerns, due to mercury concerns, now they're getting a little outdated. But is it so also with metal? It is not so. You'll be surprised to know that yes, metal crowns still have a plethora of indications, like your posterior crowns and bridges with high functional demands. It is best to give a metal crown. Okay, in Bruxers, with short clinical crowns where you can't give a zirconia, it is best to give a metal crown if he does not mind the aesthetic value of his posteriors going down. If the crown height is going to be very short, if there's decreased interocclusal space, that means the crown height is short, and the lab guy is telling you clearance clearance come hai. Okay, how to give clearance? So there is no interocclusal space. So in such cases which have very minimal interocclusal space, you can give a metal crown because metal is very strong in thin sections. It does not require a lot of thickness to do its work. 0.2, 0.3 millimeters clearance अगर आपको मिल रहा है, you don't know what to give a metal. Okay, of course, economics, we are still developing, and as Dr. Sonal also mentioned, I'm working in a charitable hospital, and it breaks my heart to see a lot of people cannot afford ceramics, and we are regularly offering metal crowns to them, and they're very happy with it, right? Your inlays and onlays, your partial restorations can be done in metal also. And in cases where retreatment may be required, you want to go for an economical option, metal crowns are good. And in young patients also, as you know, we regularly give stainless steel crowns or metal crowns. Now, in young patients, of course, metal crowns are good, but they are anesthetic. And some patients may ask you, कि बच्चे को स्टील का crown देना पड़ेगा. अच्छा, okay. Not very happy with it. You can give a zirconia crown in such cases. Please don't give PFMs. PFMs require a lot of preparation, especially in vital teeth, in young permanent molars. For whatever reason you're capping them, it is not advisable at all. Better to give a zirconia or to give a metal. Okay, my choice is a long-term provisional. Long-term provisional means either an indirect composite crown. This crown is not what the composite is not what we use here in the clinic. It is you have to make an impression, send it to the lab. The composite crown is made in the lab. It is cured under special curing units where they're cured very properly. Polymerization shrinkage is taken care of. It's a high strength material. Okay, so you can either give that or you can give a heat cure acrylic crown. So heat cure acrylic is also not that cold cure acrylic that we mix and we make a temporary crown. Sometimes we tell the patient, "अरे ऐसे ही बना दो, आप temporary crown बना दो." He makes it in a cold cure acrylic crown. Just like, for example, like in dentures, we make record bases with a cold cure acrylic, pink acrylic, and the final denture is a heat cure pink acrylic. So this is the heat cure clear acrylic that I'm saying. You can use that. Use it. We use it regularly in FMR cases as long-term provisionals. They last for a long time, and these are good because these are slightly softer materials. If you give adequate thickness of these materials, firstly they don't fracture, and secondly, since they're softer, they allow very smooth eruption, and since they require very minimal preparation, you have a lot of scope later on to give whatever choice the patient wants later on for a definitive crown. Right? Now, next confusion: what should we offer the patient, full crown or partial bonded crown? These partial bonded crowns, of course, they're ultra conservative, and we have done so much of advancement in bonding techniques now that everybody is rushing towards minimally invasive dentistry. But for all its indications, there are certain cases where you have to give a full crown. For example, if adequate enamel is not there, because partial bonded crowns, they are relying heavily on bonding. In drugs, you cannot give them. If it's difficult for you to isolate that particular case for bonding, you cannot give. And of course, economics. Just because it is a partial crown does not mean it is less in cost than a full crown. A full PFM will be much, much lesser than a partial EMAX onlay. So that is also a cost also has to be taken into consideration. Okay. Then next doubt is, for in partial coverage, you have all these kinds of restorations like inlays and onlays. So when should you go for an inlay? When you should go for an onlay? Okay. Please, the picture that I have put up, I think is very descriptive and should remove your confusion for a long time. Inlay is basically an extended cavity. There are some patients who we tell them ki, your cavity is very large, your filling, itna bada filling hai, that is why it's getting dislodged. And if you want to contain this, you want the filling to last, you put a cap on these teeth. But the tooth is very good. All cuts are very nice, but just that the class 2 is very big and the filling is just dislodging all the time. So how many times have we told the patient to just give a crown and finish it off when you can give an inlay? Okay, inlay is basically it's meant for these large proximal boxes or class 2 caries with intact buccal and lingual walls, or when the width of your cavity preparation is larger than 1/3 the distance between the cut tips, if you divide that distance into one straight line. Onlay is nothing but an extended inlay where one or two cuts are weakened because of caries, a lot of undermining is there, and that cut has been weakened. Then you have to go for an onlay. Onlay means it is covering one or two cuts, but not all. If it is covering all cuts, it becomes a crown. Okay. And yes, in large press where if the cuspal inclines are contacting the opposing arch during lateral excursion, matlab, if that particular cusp is not exactly involved, but if it is coming, if it keeps on coming in contact with the lower jaw during, if it comes in contact during protrusion and during lateral excursion, if that particular cusp just keeps coming in contact all the time, your indirect restoration, your inlay also will not stay. So just involve that cut and make it an onlay. This is what that last point means. Okay, now when to give an RPD, when to give an FPD. I think, of course, everyone wants to fix processes, right? But there are certain indications where an RPD is better. Okay, for example, of course, cost factor. And for very long edentulous spaces, okay, like say second premolar to third molar or to second molar is lost. So please give a removable partial denture. Please don't do heroic dentistry and give a 8 unit, 10 unit FPD because they don't last. They will come back to you with mobile abutment. Okay. Either you can give them an RPD or you can extract, you can save the strategically important teeth and extract the other compromised teeth and give a tooth supported overdenture. That is a better option. Okay. For distal extension cases, that is no posterior abutment, it is better to give a implant. If implant is not possible, better to give an RP. Again, there is no point in treating your premolar as abutment and replacing a molar with the support of the premolar. That is also usually does not last. Now, there are many cases that we see in the clinic sometimes. Very long edentulous span on one side, short edentulous span on the other side. So you understood very long edentulous span, you have to give an RPD. Patient is also understands, okay, itna bada hai, is posterior abutment nahi hai, say, you have to give an RPD. But on the short span side, say one missing tooth, can you give a bridge on that side? Usually we have that confusion. I'll give a bridge, short, एक ही में दांत missing है, I'll give a bridge, and this side long span है, so I will give an RPD. But in such cases, it is better to give an RPD throughout because of a concept called as cross-arch stabilization. Whenever you're giving a prosthesis to the patient, like we had said, sequence of treatment, stabilization has to be there, phase 3 stabilization. If your prosthesis isn't stable, your patient is not going to use that. Okay. So when you ensure this, when there is cross-arch stabilization, the prosthesis is extending on both the sides of the arch and the prosthesis is very stable and comfortable to the patient. Now, when I'm saying RPD here, which RPD do I actually mean? Okay, we can see one RPD here, which is metallic, and one is acrylic. And I want you all to write down in the chat box which one do we actually mean when we say RPD. Please, can we have you rewriting the metal one? The acrylic.
Poll. Maybe you can connect later on. We don't have time for poll, so just continue with the lecture.
All right. So I'm sure a lot of you must be thinking that RPD, by RPD, I mean it is the acrylic RPD, but it is not so. It is the cast partial denture, that is the one that we see on the left side. Okay, I want you all to please open your mind to cast partials. It is not difficult. It has a learning curve, yes, but you only need to learn two things. One is the path of insertion and one is rest seat preparation. And first, if you are someone who does fillings regularly, you can very easily do a rest seat preparation. Okay, but having said this, there are cases where you have to offer the acrylic RPD option to the patient. Okay, when your teeth are heavily periodontally compromised, you know that with time, very soon these teeth are going to go off. You can give an acrylic RPD as a transitional denture. Or in a very young patient where you don't want to disturb your natural teeth, even for rest seat preparation, you can go for an acrylic denture. There are certain situations like fungal conditions of the mouth, like mucormycosis, where you can use these acrylic dentures as a drug delivery system. You can also use them as a novoli denture for increasing the vertical dimension. And say a patient is coming to you and he's a well-to-do patient, ready to do implants also, but has to go for a conference in 2 days. What can you give him? You can give him an acrylic RPD and ensure that he's comfortable. Okay. So I'm coming to the last part of my presentation, which is treatment options in prosto, the FAQs. Now, as Dr. Sonal said that we are short of time, so I'm sure we probably cannot indulge in a Q&A session. So there are some FAQs that a lot of my juniors and friends and colleagues have over time persistently asked me, and so I've included them in this presentation here, and I will be addressing them in the coming 5 slides. Okay. During smile designing, when should I choose laminates over composite restoration? Well, a lot of you are very skilled and you are doing beautiful composite fillings and spending so much time into it, and patients are also happy because filling se ho gaya, it is a little more economical also. Okay, but There are certain cases where you must offer laminate as the first option. Um, if the patient is coming to you with the previous repeated restoration failures of that particular tooth by a previous dentist, or the defect is very large, or you want a better aesthetic, better, so that the processor does not catch stains over time. It is best to give an indirect restoration in such cases, and better control over proximal contacts also. Of course, now we have a lot of good metrizing systems, and there's BioClear, and there is so much that has come up. But if you can remove that prosthesis and just polish it manually and see it and polish it, there's nothing. It cannot beat what you can do in intraorally for the proximal contact and finish at least. And of course, young patients, we prefer to do fillings for them. And once the patient is over 18, we decide to go for over 18, over 20, we decide to go for a more definitive prosthesis, laminates in their case. To close diastema or correct crowding, when can I offer prosthetic treatment instead of braces and aligners? Now, although I'm a prosthodontist, but I strongly recommend, and I also to my patients always offer them orthodontic treatment first, because stability over restaurability, guys. You have to ensure that your occlusion is stable for a long term good effect for the patient. A lot of studies have been done where they have compared these two treatment modalities and have found that orthodontics is more stable. It is more friendlier to the periodontium. So go for an orthodontic treatment first, always. But when to do prostho over ortho? Sometimes, even after orthodontic, there's a minor space discrepancy, or patient wants a size correction, wants a shape correction, then you can go for a laminate smile designing in such cases. For complicated molar space closures, you can do prostho treatment instead of an ortho, because um, molars are big teeth. It's very difficult to pull them upright. You have to apply a lot of forces, and even if you do, there is always a risk of devitalization of these teeth. Missing canine, as I told you, canine is a very important tooth. It is you cannot so in ortho they sometimes reshape other teeth as other teeth to give the illusion of a smile. But you cannot reshape a premolar into a canine and expect it to do canine's work. Best to do prostho in such cases. Class 1 molar occlusion, not requiring manual extraction, or class 3 malocclusion is upper anterior missing teeth, better to do a prostho treatment. And of course, occlusal equilibration for a more stable orthodontic bite. What are the prosthetic considerations of restorability? That is, to put it simply, this question is a little complicated. When to save and when to extract? Um, we understand tooth is mobile, we have to extract. We understand tooth is carious, very grossly destructive, that we have to extract. But like we can see in this chart, which is a very beautiful chart, so you can just screenshot this. When to decide and when to how to decide when to extract and when to save. There are certain factors that sometimes we kind of just ignore, or we kind of tend to not think about them. Is factors like faulty restoration. Small overhangs are fine, but if there is a lot of overhang, a lot of big overhanging restoration which has encroached upon the periodontium and caused attachment loss, then it is very difficult to restore these teeth. Secondly, fractures. If there are root level fractures, you cannot crown these teeth. They have to be extracted. Okay. Then extensive caries, of course, you cannot poorly restorable. Also, if the tooth is fine, the crown is fine, but root caries have a hot, then also you cannot prosthetically restore it. So please keep that in mind. Ratio, very difficult for a long-lasting prosthetic outcome. And post and core required. Post and core, just remember this one sentence: 2 millimeters sound circumferential dentine. If this is not there, you cannot, your post and core will not be successful. Okay. In addition to this, one tip that I would like to give, if the tooth is strategically important, like your canine, like I said, whatever we can do to save it, we should save it. Okay, do a post and pour, do whatever, try to save that natural tooth, because it has nice long roots and can help in maintaining occlusal harmony. And if you have a premolar on both the sides, Save it, and you can extract the rest of the teeth if they're compromised, and give a tooth-supported overdenture on it. How do I approach a full mouth rehabilitation case? Very commonly asked question, but it is not possible to discuss this given the time limitations that we have. Even if we have a half an hour, 1 hour lecture, actually it is not possible to discuss this. So I urge you to please read this article and that I have written, and not only read this article but a lot more other articles, and educate yourself before you enter into FMRs. One thing I can for sure tell you is that full mouth rehab does not mean full mouth RCT. Okay, so please remember this, and please read up before you touch an FMR case. Okay, this is the last question, Jugadu question. When is cantilevering in bridge allowed? Like I said, distal cantilevers are a big no-no. Okay, but in some cases you can do a mesial cantilever. For example, if you're replacing lateral incisor, you don't need to include the central incisor in this. You can just cantilever it to the canine. It will work very well because the forces are very less in the anterior region. Okay. And the bonus tip, of course, a lot of times we see distal extension cases missing 7 and no 8 present, or missing 6 and 7. But we cannot place implants in these cases for some reason. Maybe the patient is heavily compromised medically, or bone is not good, nerve is a little elevated. Okay, but so we tell him, okay, I'll give you an option for an RPD, but patient insists on a fixed process. Then there is one special situation where we can give semi-fixed processes with the use of precision attachments. A lot of good labs are doing it, and you can contact any of them and get this done. Right? I hope that I have been able to clear away some confusions regarding the different treatment options available in prosthodontics. I'm very open to sharing my knowledge and discussing cases. So if any of you would like to get in touch with me, please, you can contact me on this email ID. I would also love to hear your feedback about my lecture. And warm thank you to Dr. Sonal, who's a very good friend of mine over time. You know her since a very long time, as you yourself also mentioned. And Dr. Rashmini also, and ma'am, Jaggi ma'am, and the whole team of Ipdcon 2025, National Health Academy, and MedSkill. Thank you for having me.
Thank you, Dr. Nupur. It was really enlightening. I know the topic is so big. Can you stop screen sharing so that I can take a picture fast? Yeah, smile. Nupur, one word for your younger self. Only one word.
It's not one word, it's one sentence. It's going to be okay.
Oh, well, lovely. Wonderful. This is precise, actually. Thank you so much, Dr. Nupur. It was really enlightening, and you can type in the chat box and visit the chat box also. With that, we would like to call in our next speaker, Dr. Arjuman. She is, Dr. Arjuman, can you just start your camera and say hello to the audience here?
Hi, good evening, everybody. Happy Women's Day to all.
Same to you, Dr. Arjuman. And she's a private practitioner from Clover Medical Center, Dubai. And she's going to be talking about oral myofunctional therapy. Dr. Arjuman, just smile for the camera. Thank you so much, dear. And I would like you to start sharing your screen, dear.
PowerPoint, right?
Yes. First, start sharing the screen. Yeah. Yes. Go on the presenters mode or screen share mode, slide share mode.
I'm going to kick you now.
The below icon, you have it here.
Fine.
Yes.
So we start with Happy Women's Day for everybody.
Happy Women's Day. Go ahead, doctor.
Yeah. So I'm going to be speaking about myofunctional therapy. Okay, and I would like to elucidate why it is important for a dentist to know about this modality of treatment. So basically, myofunctional therapy trains the muscles of the stomatognathic system to function optimally. So like all these muscles. So as a dentist, we are not limited just to teeth and gums, but we are physicians of the stomatognathic system. So we got to deal with all these muscles. Basically, there are 4 goals of myofunctional therapy. proper lip seal, improve the tongue posture, correct the swallowing pattern, and to establish nasal breathing. So let us talk about why these goals are so important for us. Well, let us start with the tongue posture. So I would urge you all to just think where your tongue is right now. Is your tongue at the roof of the mouth or is it down near the floor? Well, the tip of the tongue has to be just at the incisive papilla. So if you tell your patient to just say N, the tongue will go to the incisive papilla. That's the correct position for the tip of the tongue. And the dorsum of the tongue should rest lightly against the palate. That is the correct position of the tongue. This position ensures that we breathe through the nose, because when our tongue is against the roof of the palate, we can't help but breathe through the nose. The mouth will be sealed. When we place the tongue in this position, we also swallow correctly. Every time we swallow, the tongue pushes the palate, and it helps us to shape and mold the palate in a way that it has a broad and flat shape. If we do not swallow correctly, that means if we have a tongue thrust swallow, then our palate will look like a Gothic arch, high and narrow. It will not have that flat, broad shape that we want. So like this, you can see the green line, that's the palate. And we have to remember that the palate is actually the floor of the nasal cavity. So if we don't have a broad, shallow palate, the nasal cavity floor will also not be similar. So here we show that with the pink line, if the palate is like a Gothic arch, high and narrow, then the nasal septum will also not have enough space, and we may end up having a deviated nasal septum. Also, then the oral cavity will encroach into the nasal cavity, and there will be less space for nasal breathing. And we don't want to mouth breathe. What we want is nasal breathing. When we breathe through the nose, the air that we take in first enters the sinuses and then it enters the lungs. And we know that the healthy sinus epithelium continuously generates large amount of nitric oxide, which is so important for vasodilation and antimicrobial activity. So when we breathe through the nose, the air will go through the sinuses, become moist, warm, pressurized, gather all the nitric oxide from the sinuses, and then enter the lungs. This air is a very healthy air, and the lungs can really remove a lot of oxygen from this air. So it's a more healthy way of breathing than breathing through your mouth. When you breathe through your mouth, you're still alive, but you're not getting the benefit of nasal breathing. You're not getting the benefit of the nitric oxide. So this slide shows the difference between a mouth breather and a nasal breather. A good tongue posture, like we're talking about the tongue posture. So the good tongue posture is also important for the proper development of our facial structure and airway. The tongue pressure against the palate signals the maxilla to grow forward and downward as it is meant to be. A mouth breather will have a low-lying mandible and tongue. So we'll tend to have a longer face, receding chin, tired eyes, forward head posture, poor cheekbones. Speaking about teeth, a low tongue posture or a tongue thrust swallow will cause the dentition to erupt in a way that we have various forms of malocclusions, such as deep bite, cross bite, open bite, dental crowding. When we examine a child for swallowing pattern, we ask the child to swallow with keeping the lips apart, and we see if the tongue is being pushed out against the teeth to decide whether the child has a tongue thrust swallow or a mature swallow. But in the case of adults, there's a simple hack we can follow to check whether the adult is swallowing properly or not. Just ask the adult to put out the tongue and check the dorsum of the tongue. Is the tongue coated or is it nice and pink? If it is nice and pink, it means that the patient is swallowing properly, pushing the tongue against the palate. But if the tongue is coated and white, it means the person is not swallowing properly. So to keep a clean tongue, we don't really need a tongue scraper. We never need to clean a tongue. All we need to do is swallow properly, because we are swallowing almost 1,000 times a day. And just imagine if 1,000 times the tongue is touching the palate and there is friction, how will there be any kind of collection on the tongue? The tongue will be nice and clean. And many a times when we ask the patient to stick the tongue out, we may find that the front half of the tongue is nice and pink, but the back half of the tongue is coated. That means the person is swallowing with the tongue against the palate, but not the entire dorsum, only the anterior part. And then we can use myofunctional exercises to train this person to swallow and breathe in the correct way. Okay, well, most of us, sorry. Okay. Most of us have heard about mewing. Mewing is a facial restructuring technique that involves keeping your tongue on the roof of your mouth to change your jawline's shape. It is named after Dr. Mike Mew, a British orthodontist. We find in your clinic, you must have come across many young girls and boys who know about mewing and are doing this technique because they want to look better. They want to have a good chiseled jawline. Well, mewing does help, but we have to remember that only mewing will not help because we have to also exercise the suprahyoid muscles, the tongue, the oropharynx. When all these are exercised, when they are functioning optimally, then only mewing will be effective. So if you want to go from having the flabby double chin to a well-chiseled jawline, myofunctional therapy can definitely help you achieve it. One simple hack to strengthen the oropharynx is the ballooning technique, where you take a balloon and you blow into the balloon, and then you hold the balloon in your mouth. You have to hold your tongue behind. Don't close the opening of the balloon. And what you need to do is just hold that in your mouth for some time. Just a moment. So you need to resist the pressure from the balloon so that it does not deflate. You just inflate the balloon. Don't pinch it. Keep it open and just hold it in your mouth. Initially, holding it even for a few seconds will be a little difficult, but gradually you will be able to hold it for 10, 15, 20 minutes. And this pressure, when this balloon tries to deflate and you prevent it from deflating, the pressure is felt in the back of your throat. And that helps to strengthen your oropharynx. So this is a simple hack. If you want to control your snoring, reduce your snoring, this is a very easy way to do it. Now, let us talk about some clinical examples of how myofunctional therapy can help us in our daily dental practice. Now, if you have a patient like this, a 23-year-old girl who comes to you with swollen, inflamed gums, well, only the anterior gums are inflamed, and she gives a history that she wakes up in the morning with a dry throat, feeling very thirsty. Well, you diagnose it accurately. You say, yes, this is a mouth breather. But then how do you treat her? This girl has been getting prophylaxis done regularly every 6 months. She's even got deep scaling done, but nothing helps control the swelling or the bleeding from the gums. Well, of course, you refer the patient to an ENT doctor who will look for any kind of nasal obstruction or allergies and then refer her back to you. But even then, she cannot stop mouth breathing because there is some neuromuscular pattern developed in her mind and she cannot sleep with the mouth lips closed. So here again, we can offer some myofunctional therapy exercises to train the lips to be sealed for the correct tongue posture and for the proper swallowing so that she can sleep with her mouth closed and breathe through her nose. Another example to prove the point is a snorer. If you have a patient who snores and he visits your clinic and tells you that, doctor, I'm snoring and can you help me? Of course, we can make them an anti-snoring appliance or the MAT. But how long will the patient wear this? Do you tell the patient like, okay, take this and wear it lifelong? Don't we have something else in our kitty? Isn't there any other way we can help the patient stop snoring or at least reduce the snoring? Here again, we can use myofunctional therapy exercises to help the patient strengthen the oropharynx, the tongue, the correct tongue posture, the lip seal, the nasal breathing, and help the patient get off any kind of dependency on any kind of machine or appliance to control the snoring. Another omnipresent dental issue is malocclusion. We have patients malocclusion, and the orthodontists do a very good job for aligning the teeth. But what about the root cause? The reason why the patient had this misalignment? Did the patient have some kind of a airway issue? Did the patient have some kind of a tongue issue or the swallowing issue that led to this malocclusion? So again, in that case, we need myofunctional therapy to correct it. Just by orthodontia, we cannot correct the underlying root cause. Another example to show the importance of myofunctional therapy is the case of a tongue tie. Whenever a doctor will release a tongue tie for an appropriate reason, this tongue tie, the wound will heal with a scar and the tongue tie effect will be lost unless and until we have made the patient go through myofunctional therapy before and after the release of the tongue tie. Then only the surgery will be successful. As dentists, embracing a comprehensive approach that includes assessing a patient's eating, breathing, and swallowing patterns can significantly impact the overall health and aesthetics. The dentist is the physician of the stomatognathing system and is hence uniquely positioned to screen for air issues and diagnose a wide range of health problems. By looking beyond just teeth and gums, dentists can play a vital role in promoting better health outcomes for their patients. This holistic perspective ensures that dental care contributes not only to oral health, but to overall well-being. With this, I end my presentation and thank you for your attention.
Thank you, Dr. Arjuman. It was very well thought of lecture, I would say, that you have covered up the topics in a way that you have developed the inquisitiveness in each and every one of us, that how are you treating these cases. So I am sure you'll be having many questions in the chat box. So thank you so much for this session. And can you just stop screen sharing so that I can take a picture and ask you a question also?
Yeah, sure.
Yeah, smile for the camera. Yeah, Dr. Arjuman, I would like to ask you one thing. I know you are already a mother-in-law, like, daughter is already big enough. But if there is a one thing that you would like to tell your younger self, what it would be?
I would just say that never take anything too seriously. Just live life one day at a time.
Perfect. Perfect.
And I would also say that choose your friends well.
Yes, actually, that meant a lot. That meant a lot because I know I also have a teenage daughter, and that makes a lot of sense.
You think of that only after your daughter. You have teenage daughter.
Thank you so much. Thank you so much for this enlightening lecture. And please visit the chat box if there are any questions, you can answer them.
Thank you. Thank you so much, Sonal.
Thanks for your time. So next we have Dr. Ruchika Sood. Dr. Ruchika, can you just switch on your camera and your mic?
Yes, Dr.
Yeah, just smile for the camera first. Yes, thank you. Dr. Ruchika Sood, she is being associated with all the Pink Dental Congresses, I guess, and all the Official Pink Congress sessions. And I think after my CV, I think her CV is something which I have learned by heart now because I've been narrating it so many times. So Dr. Ruchika Sood, she's a fellow in head, face and TMJ pain from Rutgers University, USA. She's a diplomat from American Board of Orofacial Pain and director at NeoCare Orofacial Pain Relief Center. And her topic today is dentistry beyond pink and white. So, Dr. Ruchika, your slides are visible and the stage is all yours. All go, set to go.
Thanks a lot, Dr. Sonal. And thank you for having me. It feels like being at home, where you are going to get the feel of the tasty tea. और कुछ हो नहीं हो इस कॉन्फ्रेंस में आके मुझे I remember the pretty flowers and the pretty balcony and smiling Dr. Sonu. So with those smiles, let's begin the topic for the day. What we meant to say was, as dentists, we kind of start identifying ourselves with procedures, with the teeth and the gum, if we want to go beyond that, like the soft tissue and the tooth. That's all I would hear commonly being discussed. And hence that what is it in dentistry that is beyond this? I happen to be one of the first orofacial pain practitioners in India. My office is probably the first office in India which is exclusively orofacial pain office. And every time somebody would hear that in those days, so dentistry karatas nahi, ajibat karat nahi. That means like you just don't practice dentistry. And I would say yes, I cannot do justice to my specialty if I still stay involved with dentistry. And I would always get a question mark or an exclamation. But I'm happy to share this on a platform that I have come to India with my daughter and 2 bags. And I've started my life at middle age from stage 0. And as a single woman, I've been able to raise my daughter well with dignity. And we survived in a city like Mumbai. And we bought our own office, lived well, her education, and all of this with orofacial pain. So I want to put the perspective right that this subject means a lot. It's not just, dentists are not meant to think only about teeth, okay? Yes, we focus on aesthetics. We want to get the things right, but function is what is ingrained in every dentist. But sometimes this function is also going haywire because of reasons which are beyond dental. Okay? So when we talk about women, there are a lot of things that happen with women, right? And majority of the pain patients are women. Now, why this gender disparity exists in pain is a separate topic of discussion. And there are a lot of research papers published on it. But there are few conditions which really pop out loud. And I think the biggest one of them is that Mother Nature has created women as nurturers. And because we are nurturers, we have a lot of elements to our being. And I am in love with Indian culture, with the roots of being an Indian, and the science which goes into the day-to-day life of an Indian lifestyle. A lot of people in my office are healing just by correcting and modifying their lifestyles. So what I meant to say here was that a lot of elements of being a nurturer are taken care of by living right and keeping the elements in balance, like waking up early, sleeping in time, honoring yourself for being a nurturer. Yes, women cook, but what happens when they cook? All the five senses, they get involved into cooking. So is there a bigger activity than that? Can there be a more fruitful, nurturing activity than that? There cannot be. And when a woman is feeding a child, we are talking about oxytocin, we are talking about dopamine, but in these day-to-day activities of being a nurturer, how the hormones are playing the role, if we understand that and optimize it, we can keep a lot of pain problems away. So as dentists, we are very much capable of understanding this. And I loved the language that the speaker before me said, like we are the physicians of the stomatognatic system. Nobody understands it better than us. And it's really high time that we own it. Because the number of people who are suffering with orofacial pain is very, very high. And dentists are most often the first point of contact. And most of the dentists refer the patients to neurologists, and neurologists refer it to me. So I see it very commonly, and I've been seeing it for 10 years plus now, more than 10 years, for 13 years, this is what I've been seeing now. That Dentist will refer to a neurologist, dentist will refer to an ENT, and then that patient, those specialists will, but dentists still have not been able to make up their mind, oh my God, there is an orofacial pain specialist, and this is the case of my specialty. And there is a lot that I can do as a practicing general dentist to do the differential diagnosis and maybe help the patient in need as a first point of contact. So where do these TMJ disorders and headaches and neuropathic pain fit in a dental office? They fit in because a lot of time myofascial pain presents as toothache. So when we take an X-ray and say this is not having a periapical lesion, but still I know so many dentists who are so honest with their patients who say there is no periapical lesion, पण आपण एक रूट कॅनल करून बघूया कसं वाटतं आपण बघूया. But you have informed the patient, you have done the right job, but let's put in the effort to train ourselves a little better here and put these patients for the management of myofascial pain before attempting that root canal treatment. Sometimes it is the posterior cervical muscles which are into spasm, and the patients will present as a problem that I'm not able to eat on one side. Because there is a spasm at the back muscles, what is happening with that? The spine has lost the equilibrium or the balance. The head, most of these muscles are what are trying to keep all of this part ahead of the vertebrae here. So once there is a spasm here, there is a disequilibrium, and this pull could take teeth out of occlusion. Before we pick up that burr and reduce the tooth and create something irreversible, let us think and train our eyes to see, is this neck looking good to me? Is there balance and harmony between both the sides of the neck? Then every pain which happens in this part, there are only two diagnoses which are done by the pain physicians most commonly. One is trigeminal neuralgia and another is atypical facial pain. Every pain conference, I have a discussion on atypical facial pain, and the incidence of atypical facial pain from 10 years ago publications is 0.01%. It was a diagnosis when the world of pain was not this evolved. But with a specialty like orofacial pain established, atypical facial pain, I think, is history. I have not seen even one patient of atypical facial pain in all these years of practicing exclusive orofacial pain. We have always been able to identify and diagnose something which was troublesome for the patients. So how do we train ourselves for those things? Is it possible that facial migraines are causing toothaches? These are all the possibilities, and if we educate ourselves, we can do very good job at differential diagnosis. And I'm very happy to share these studies from India. I remember this is many years back I started lecturing, and I would always use Brazilian data. I would always, because that was the developing country, and I chose to use that data in India, I was presenting in a developing country. Or we would have data from US and something from UK. But this is the first time I'm presenting data from India. And I think I really feel very happy doing this, which speaks a lot about the kind of awareness that has already got generated with the subject. So when the incidence is this high, how many dentists do we need to treat these patients? We need a lot of them. Okay, there is limited awareness amongst doctors. That is a concern. Patients are coming very well read today. They read a lot on Google. They read Australian resources. They read American resources. The Mayo Clinic is like everybody's Bible these days, but doctors themselves have not caught up with it. So we need a lot of specialized training, around chronic pain in our country to cope up with it. Orofacial pain has high prevalence but low priority and is often dismissed. Why is it dismissed this often is a food for thought for everyone today. I can share only my experiences. Like, it has not been an easy journey because I started practicing orofacial pain when nobody knew the subject, nobody knew the word. And first campaign that we ran was on headaches. And not many people showed up. Then we did a free campaign on headaches and few women showed up. And the next campaign was a larger scale one. This was the third one on headaches. So we did something close to 10 campaigns. On the third one, there were more men than women. And subsequently, like for the next 6 or 7 months, like we did 10 campaigns, it was a neighborhood campaign that we had done. And at the end of the day, there were more men than women which showed up for the camps. And that made me think, is headaches in India more a men problem? You know, there was no data, there was no statistics, and I was like, okay, maybe. But on deeper investigations, or you say, when we stayed longer on the subject, we figured out that women considered headaches to be normal. And then on Women's Day, we ran a campaign. And it was like all women who have headaches will find solutions. And women showed up. And some more than 200 women showed up that day at our hospital. And that day I asked every woman, why had they not sought treatment for this headache? And everybody's answer was same. They considered it normal. So can you imagine the kind of endurance and tolerance with which women live their life? So there is so much of underreporting of pain problems. So the problem is not lesser, but this acceptance that this is normal, headache to hota hi hai, was the problem. So then we ran a lot of campaigns and a lot of awareness drives where we were. And at some point I got tired of headaches and I said, okay, I'm not talking about headaches anymore. And then we shifted more to jaw pain and, the nerve pain, which was more serious problems for people and they related better. So what I wanted to share with this was there is high prevalence, but low priority. Women do not put themselves as a priority. So they suffer a lot in silence. There is always something more significant than their pain. So we must dig and help them understand and equip them with tools and knowledge to take care of their pain problems better. Okay. So complexity of these problems, yes, is higher. But you know what? I always say, if I could train, anybody can train. It's just training and then working on it. I am Dr. Gary Hare's student and I was blessed and I feel I'm really blessed. I feel if somebody is studying with Dr. Hare, he's capable of making a donkey also a good OFP doctor. So good training means a lot. Okay. The common symptoms of these problems are dizziness, popping sounds, pain, spasms. When you see all these kind of problems in your patients, please think TMJ problems. Please think OFP. And if patients say, I've been to an ENT, if I've been to a pulmonologist, I've been to a neurologist, but it didn't get resolved, you are sure this is an OFP problem. So there are a lot of comorbidities when we are talking about orofacial pain problems like TMDs, migraines, and still, in spite of knowing this or reading it online, people never evaluate, like, if I have a headache, I'm never evaluating for a TMJ issue. I'm never trying to evaluate this may be a TMJ headache. So, and this is very common in India, very, very common. Most of the TMJ headaches are self-diagnosed as migraines or diagnosed as migraines by other medical doctors who are also not trained on orofacial pain. And then people believe that they have migraines. So imagine how many patients can, as dentists, we can help. Okay. So another important factor is that occlusion and pain problems are not having any direct correlation. Okay. So please look up the guidelines. RTDC guidelines are published and they are free to read on internet, and that's a good starting point to educate ourselves on understanding more about TMD and OFP problems. Okay. So common aspects are dental pain, ear infections, migraines, sinus issues, and nerve pain. Chronic pain, you know, when we talk about pain, chronic pain, we say it's an emotional and sensory experience. We use the word emotional first, emotional and sensory experience. Even when we have cold, a common cold, I'm running cold right now, and I'm not feeling the same enthusiasm that I would feel all the time about presenting from inside of me, just because of a cold. So imagine somebody who has to live with pain and is suffering for months and years together. They are definitely going to have some emotional component to it. There are patients who get out of pain and that have after many years of suffering, and they're not able to leave us. Not because they really need us, because they need the coping mechanisms to believe, and they have to work with our psychologists to cope back to live a regular and normal life. You have to really encourage them and tell them that yes, you can do whatever you want to do with your life now. So that persistent pain sets them on a very different kind of a lifestyle, or frustration mode or isolation mode, and it takes effort and right hand holding to get them integrated back. As a dentist, can you do it? If you take training with psychology courses, yes, you can, but you can always team up with a good psychologist in your office and you can help patients through that. So most of the times, people are not able to help women integrate back also because they have been very dismissive. So many women are under psychiatric treatment for TMJ issues or facial pain issues because they were never diagnosed and dismissed as stress, as overthinking, as anxiety. इसका तो nature ही ऐसा है. She just makes up too much. There are a lot of things that go behind pain, but this dismissive outlook really makes women suffer a lot. So in our offices, we need to take the ownership and contribute our bit to bring this shift to help people get out of this suffering. Okay. And yes, women themselves need to acknowledge themselves. So much of talk about self-love, self-care, but I think we need to live that in our lives. Society conditions and preconditions women to suffer. We always say the men are brave, women are emotional, but you always see it other way also. I feel women are everything. Saraswati is also woman, Lakshmi is also woman, Annapurna is also woman. What aspect is not a woman? जहां शिव की शक्ति खत्म होती है वहां आदि शक्ति आती है. तो अगर जब संसार की जो सृजन है, जिसका ना आदि है ना अंत है, उसको भी शक्ति चाहिए अपनी शक्ति ऑपरेशनल होने के लिए. So imagine the kind of power a woman holds. And the woman who left a lasting impact on this aspect for me has been Sushmita Sen, because she lives it. She lives it, she just doesn't talk. Acknowledging your own Shakti, what power it gives you to live your day-to-day life. Yeah, it shows in the way you walk, in the way you talk, and the way you make your choices. And are you able to validate your own being? So women are not only emotional, women are everything. But this comprehensive thought process has to be integrated by and chosen by women themselves. Women's pain is more likely to be dismissed as stress or psychosomatic. So women should take the ownership and understand their own pain. Its hormonal fluctuations play havoc even around menopause. We're talking a lot around menopause, but how many times have you heard so many menopause coaches talk about TMJ disorders? How is the temporomandibular joint behaving at menopause? Or is there increased idiopathic condylar resorption around 52, 53 years of age? I really don't know the answer to this question, but this is a pattern that I have seen in my office, that a lot of women in their early 50s come with ICR. Why? So the sensitivity of this matter is fairly high, and women need to acknowledge it first and then seek help in the right direction. Okay? The hormones, which are our strength, they also contribute towards the suffering in some parts of our life. Like, estrogen influences pain perception. So it's a progenetic hormone. With fluctuation of its levels around menopause, in PCOS, in PCOD, women suffer a lot. We must rethink pain, diagnose it correctly, and provide the appropriate treatment. It is a very integrative field. We cannot work in isolation here because there are too many elements which are involved. We can train for a lot of things and understand them, but we need to develop a very good team of a right physiotherapist, a good psychologist, orofacial myologist, and then work together as one unit to help patients find solutions for their problems. Pain is a disease and a primary concern. It is not an afterthought, okay? And whatever it takes to understand these problems, we should be prepared and ready to train ourselves for it, and also adapt or adopt to it, because temporomandibular joint disorders or orofacial pain are whole body problems. A lot of times you will see a patient in pain and then they may be having autoimmune disorders, and that is why there is a problem. These days, a lot of times there are nutritional deficiencies, and nutritional deficiencies bring in pain here. And is it possible that because this is the part of the body which has higher autonomic nervous system supply, we get more pain here? So we need to think aloud. A pimple on face wreaks havoc for every teenager. So little pain on face, imagine how much of suffering it can bring. We need to make sure that nutrition is in place, the supplements are given appropriately, and not blindly give painkillers to the patients, and not jump into any invasive therapies. There are a lot of alternative pain management strategies that can be incorporated, and they give good results. We need to understand sleep medicine very well, and sleep is really integrated very deeply in the world of orofacial pain. And specialty like OFP can contribute and help many people. And it is strongly recommended that we propose and request for these trainings to be a part of our curriculum. At least an orientation be provided to every dentist so that there are more people who can take help on these kind of problems. We have reached in the developed part of the world where even virtual reality is being researched in behavioral therapy for chronic pain patients. And here we are struggling even for the basics. So the gap is too big. But if we all come together and put right proposals, I'm sure we can contribute and make a difference there. We should guide our patients to make right dietary choices. Pain is always about inflammation. When you are in pain, अगर मैदा खाएंगे, तो inflammation बढ़ेगा. Gut-brain axis is the first axis. See, our ancestors knew everything and they were the things which are part of our life. इसके लिए ना हमको इंडिया में ये बातें बहुत सिग्निफिकेंट नहीं लगती हैं, क्योंकि हल्दी दूध तो मम्मी वैसे ही देती है ना. अच्छा बेटे चोट लग गई, कोई बात नहीं, आज हल्दी दूध पी लो. हम ये नहीं सोच सकते कि टर्मरिक इज एंटी इन्फ्लेमेटरी, this should be the level of curcumin. This is, curcumin needs a lipid for its absorption, so it should be had only with milk. We just can't think. Our ancestors were perfect. अगर हम बिल्कुल दिमाग लगाए बिना सिर्फ अपनी दादी की बातें फॉलो कर ले तो भी बहुत हेल्थ आ जाएगी हमारे कंट्री में. लेकिन एटलीस्ट we have, let us understand them with this generation and try to preserve for the coming generations all the knowledge that's existing. It's हमारे यहाँ पे जो तिल खाते थे, जो जिस तरीके से गुड़ खाते थे, मखाना खाते थे, all those things are very very appropriate. या सोने से पहले जो हल्दी दूध की बात हो रही थी, वो अमाइनो एसिड्स जो रिलीज होते हैं, वो दे हेल्प अस विद स्लीप. So TMJ disorders are very, very highly related with apnea. 75% of patients with sleep apnea experience TMJ related pain. So 50% of patients of TMJ disorders have bruxism. And chronic sleep deprivation increases pain sensitivity by 30%. So all these teenagers, remember that study from Indore where we said 10 to 12% of adolescents are having pain. How many patients am I seeing right now before the board exams? Correctly, February ke mahine mein 10th graders or 12th graders will start coming with pain problems. Why doesn't it happen in September, October? Why does it happen only in January and February? So we have to understand all of these things and then provide appropriate care to our patients. And these are common things that we understand. Stress, depression, bruxism, all these things are interrelated with pain problems. Okay? Personalized treatment is precision medicine. Okay? Patients who have genetic predisposition may have higher pain sensitivity, because genetic factors do influence pain sensitivity and metabolism. But there are tests by which these can be identified and customized treatment plans can be worked out for the patients. And Ayurveda is definitely the most precise, individualized and patient-specific system to my understanding. But yeah, I feel I missed that boat, and now I'm too happy and too much in love with my own world, but of OFP. But that's food for thought. Like, we can definitely I have 3 Ayurvedic doctors working in my office, and we are able to provide a lot of relief to people by integrating therapies appropriately. Okay? Now, pain perception, like today morning's only first case, she's not reporting pain because she'll feel lesser in front of her mother-in-law. Husband had to drag her out and bring for pain report. ये किसकी problem है? सब कुछ अच्छा है, घर भी अच्छा है, husband is also caring, mother-in-law is also caring, but the daughter-in-law herself feels that I will be deficient or I'll become lesser. So she'll not report her pain. But lesser reporting will make others look her pain like, but the husband had the eye to see that she's gone totally into spasm. Let me just take her to the office. So ये चीजें women का thought process है which needs to be worked on at a level of the society. Okay. The cost of ignoring it is very, very high. शुरू में it is the same thing. When the tooth decay just begins, prevention में आप एक छोटा सा J-pit का filling करा लो, it's not expensive. Do oral prophylaxis regularly, it's not expensive. The more you delay the medical treatment, the more expensive it becomes. It's the same thing. Okay. Another very important fact is a lot of pain doctors came together, and I have witnessed and seen the shift in the pain care in my country. But orofacial pain still is not covered by insurance. In US, when the pain started getting covered, OFP also started getting covered. OFP was covered under medical insurance and people could take treatment appropriately. But in India, it's not the same. Why? Because I think we need those many orofacial pain doctors, we need consensus, and we need to show up as one body. And then maybe they will also think about it. But it affects the treatment outcome. Patient coming to our office today may not go for a non-interventional treatment, but go to a pain doctor and get an interventional procedure done because that is covered under insurance. So that is a fact that we need to acknowledge. So yeah, community outreach, integrative care, holistic approaches, having more mindset for research is also required because the phenotype that we have, we are different people. We are not having the white skin. The melanin is not going to work the same way on our skin. Similarly, our pain tolerance is different. Our pain ka perception is different. Our pain reporting is different. So the guidelines for care should be formulated by understanding our own population. I'm just going to run through a small case story of a 28-year-old woman, severe recurrent facial pain as electric shocks. I'm sure at the moment we use the word electric shocks, everybody wants to think trigeminal neuralgia. That's not true. If it is a TMJ disorder, it is very much possible that the mesenteric nerve gets involved, and in the same territory, we start feeling it as electric shocks. We can start looking at it as twitching. And these may be the problems which are very much in the dentist domain. Nobody understands trigeminal nerve better than dentists. So discomfort while eating, talking, this was her complaints. She underwent multiple surgeries, but pain persisted. And that's when she showed us, okay, we treated with physiotherapy, splints, and some Ayurvedic modalities. Within weeks,
was a very tough journey for me throughout. Like it was a 6 months journey, and I had a severe pain in right side of my face. Electric current was passing continuously in my face, and because of that, I was unable to eat, unable to drink, unable to have anything. So it was a very, very, very severe pain. I did radio surgery for
And
RF spacing.
that you did twice, right? RF ablation you did twice. And
Yes, mini surgery was also done, but there was no relief. And after that, I did a treatment from Dr. Ruchika. So,
what was your problem diagnosed by us?
it was a back problem,
And
it was connected here
with your joint.
with my joint. Yeah. So, a very planned treatment was processed by Dr. Ruchika. So then now I'm completely fine, no pain, no back pain. And thanks to Dr. Ruchika and solution. You see,
God of you.
and now
I just took this from my Insta reel because I didn't have time to edit it. But the point that we wanted to make by sharing this was that there is a lot of suffering. And women are at a receiving end with it. So I've taken this opportunity today, provided by the Congress, to say that orofacial pain is a real problem. It's often ignored, and it's time to ask for the change. Because if we want to be progressive and claim that we are advancing, then integrating the pain sciences, the science of pain, the cultural knowledge that we have, the spiritual base that we have to really, really integrate it. We are waiting for Italians or French or Americans to study Om and tell us that what frequency will bring what change to the nervous system. No, we don't need that. We have seen years and years and years of good life for our seniors. There were not so many degenerative changes because they ate ghee. Ghee is the best antioxidant known. Ghee is having the highest amount of regenerative capabilities. So if we come together and think about these things, I think we can make a lot of difference to the lives of many, many people. I really don't know how many of you have been to Mahakumbh, but one thing that I really learned from my visit to Prayag is that my country is amazing and why we are a resilient country. Because it is the texture of people and women in this country. Women were walking with such heavy stuff on their heads, leading the walks for kilometers and kilometers, and God knows from where so many people were coming and walking all the way. I saw people walking all night, people walking all day, but standing so grounded in their faith. If you will look at it, the maids who are working, the workers who are working, their prayer times are sacrosanct. So what are these prayer times doing to them? Are they giving them their resilience? So as educated or more apt individuals in this society, are we losing on some aspects of life by leaving behind the aspects that our ancestors had? Maybe those are the things which kept our country pain-free. The food was very good. The lifestyle choices were really bang on. The work culture was very precise. So maybe we already know the recipe for success. It's just time that we reclaim it and live it. With this, I will end my talk here, and thank you very much.
Thank you, Dr. Ruchika. And as always, you always inspire us a lot. And I can see the pink theme is being translated with you.
Yes, that's
with
love
your
for you, Sonal. That's simply love for you. You
Thank
gave
you
this
so much.
opportunity, right, to present and flow my heart out. I always know that this platform is where I can talk my heart.
As you said, it's your home, right?
Yeah.
Yeah. I'm just sit back. I'll take a quick picture again. Just sit back a little bit. Yeah. Okay. And the question I've been asking every speaker, what is it that you would like to tell your younger self? I think you've already spoken about your journey a lot, but one line if you want to tell your younger self, like.
Follow your heart, follow your instinct.
Yes, that makes a lot of sense.
Yeah.
Thank you so much, ma'am. And there are some comments for you in the chat section if you can have a look at them. I would like Miss Anushka to come ahead. She's a paper presentation participant. Anushka, can you unmute yourself?
Good evening, ma'am. Good evening, everyone.
Yeah. So start sharing your screen, dear. Audience, please excuse Anushka because yesterday she could not join us. Today she's presenting a paper. 5 minutes is your time limit, madam. So please start sharing your screen. Please
I
go
hope
on.
is it visible?
Yes, please go on the share screen mode or play mode. Yeah. Your time starts now, Anushka.
So greetings to all the members and organizing committee and respected judges of the International Pink Dental Congress 2025. Odontogenic cysts are common oral lesions which dentists come across, and they usually have classic clinical features. Most of the times they pose a diagnostic dilemma, and because of their unusual presentations. So today I, Anushka Singh, a second BA student, would like to present you a similar case with the title of Tale of Two Cysts, bilateral cysts involving sciences in a female patient. The patient is a young woman who came in complaining about pain in the upper left jaw since a month. And as you can see, there is no external manifestations like any swellings of the buccal or the palatal area. And everything looked completely fine. And this made the diagnosis a muddling puzzle. So, starting with the case presentation, our patient is a 28-year-old female who complained about pain and pus discharge from the upper jaw since about a month, and all the other systems appear to be normal at the time of the presentation. And with the existing complaint, personal and family history were not contributory. And these are the extraoral features from all the profiles. The patient did not possess any extraoral manifestations of any kind. At intraorally, as you can see, this is the right side and this is the left side. And the quadrants are completely normal, and we were clueless about what could be the reason because you see, even the teeth were healthy, there were no cavities. We took a radiograph and it gave us some hint that both the third maxillary molars were impacted, and we can see that there was some lesion around it, some expansive lesion around both the teeth, and sinus shadows were not seen, meaning the cyst was occupying both the sinuses. Now, this is the right third molar with its boundary, which is right inside the sinus. So, at this point, we diagnosed the patient with bilateral dentigerous cysts, but still biopsy confirmation was awaited. On the basis of radiological findings, the patient was operated in a single day operation. The surgeons had planned a procedure of enucleation with curettage under general anesthesia, and incision was made. The lesion, along with the third molars, were extracted. So during the procedure, BIP, that is bismuth iodoform paraffin paste, was placed to prevent further growth of the satellite cysts and to help in peripheral osteogenesis. And at the end, sutures were given. This is the post-op images, and the patient was called in after 4 days for a follow-up, and she showed good healing and recovery. So during the surgery, we were curious to know the content of the lesion, so we took FNAC and saw that the cysts were filled with cheesy inconsistency. So under the microscope, we could observe cholesterol crystals, which signified an infected and an inflammatory cyst. So meanwhile, the postoperative care was being taken. We received the excisional biopsy, which included the cystic lesions and the maxillary third molars. So we prepare the slides for histopathological examinations. We can make out that this is a lumen, and the epithelium lining is very thin and corrugated. And since the cyst was very large and infected, we can see the areas of inflammation where the epithelium was showing proliferation. The epithelium was very thin and only 6 to 8 layered cell. The characteristic tombstone appearance of the basal cell can also be appreciated here. And since the material was cheesy, histologically also it was showing keratin flakes accumulated within the lumen. Now the right side was showing parakeratin type of epithelial lining. And we were looking for daughter or satellite cysts, and we could spot some proliferating within the capsule. So this is a beautiful image where we can see the daughter cyst under higher magnification. And because the cyst was infiltrating the maxillary sinus, which is a part of the respiratory pathway, we can appreciate the pseudo-stratified columnar ciliated epithelium in the histological slide. Now, based on these findings, we gave the final diagnosis as bilateral odontogenic keratocyst, and it was non-syndromic because other parameters were not present. So OKC has been a topic of controversy because of its aggressive behavior. So many classifications have been given and revised, and earlier it was considered as a cyst, and then later on it was shifted to tumor classification because of its aggressive behavior. Now, again, in some recent classification by WHO in 2017, it has been brought back to the cyst category. Now, there are a few more published cases of bilateral OKCs, along with syndromes like the Golden-Gold syndrome. So we can see that the cutaneous manifestation radiographic features were present in this child patient associated with a canine. This is a case of female patient, little over in her 40s, and we can see that there's a bilateral mandibular case of OKC in association to nevoid basal cell syndrome, which is also known as Golden-Gold syndrome. So, what makes our case stand out from the regular cases of an OKC or a syndromic OKC? So, first of all, it did not it did not manifest any extraoral or intraoral features of any kind, and even gender-wise, they're most commonly seen in males, but our patient was a female. The most common site of an OKC is observed to be in the mandible, and our case involves not only the maxillary third molars, but also the maxillary sinuses. Now, speaking of which, bilateral OKCs are very rare, even so, when not associated to any syndrome. So, I hope our case would open a new window for everybody present here and help them diagnose and treat unpredictable cases like this one. And this case also emphasizes the value of multidisciplinary approach, where the collaboration between oral surgeons, radiologists, and pathologists ensured optimal treatment. Lastly, I would also like to thank the Ipdoc platform and Sonal ma'am for giving, and my mentor for giving me this opportunity to share our journey through this presentation and for guiding me along the way. Thanks to the Department of Oral Pathology for continuously preserving. Thank you.
Thank you, Anushka. I will consider your case presentation in the for the jury award also. So nice presentation, and keep up the good work. Next time, please be vigilant about your timelines. Okay. Next up, we have Dr. Shrishti
Thank you,
Kharat.
ma'am.
Are you there, Dr. Shrishti?
Yes, ma'am.
Switch on your camera, dear.
Yeah.
Dr. Shrishti, you have max 8 minutes, okay?
Right. I need to share my screen, right?
Yeah, please share the screen, dear. Dr. Shrishti, your
Yes.
screen is frozen. Just start sharing your screen, dear. Yes.
Yes. Can you see it?
Just a minute. I think it is loading. Yeah. Now go on the presenters mode. Not the new slide. Go on the slideshow mode, madam.
Yeah, I'm on the slideshow.
Okay. All the best. Your time starts now.
Okay, thank you. Greetings. I am Shrishti Karat. I'm an intern at Dr. D.Y. Patil Dental College. I'm here to talk about Densin Care, a revolution in dentistry. Densin Care is a dream I saw when I was 17, and now it is finally turning to be a reality. Densin Care is a pioneering company, and we aim at creating revolutionary products that change the way people see their oral hygiene. Let's talk about the missions we have at Densin Care. We have 4 main missions. The first one being keeping dentists as our first point of contact for all oral health purposes and innovations. Number 2 is to bridge the gap between patients and effective oral health solutions through innovative products. In the following slides, I'll also be talking about one of our innovative products. Moving on, we want to make sure that each of our innovation is backed by research and scientific evidence. Densin Care firmly believes in fostering a culture of prevention, education, and collaboration, and not just making innovation in dentistry. Now that we know about our mission and the company, let's talk about the story of Densin Care. As a student in dentistry, I always thought that the textbook language is much different than happens in the world. With this idea, I went and spoke with my staff member in the Department of Public Health Dentistry. I asked her how can we make our oral health better and bring our textbook language to real life. To which she recommended that at first 40, Denson Care started a team of 5 females, and now we're a team of 7 members working on innovation and putting dentistry to life. Let's talk about our flagship product, Brush Talk. Brush Talk is an innovative design that will help revolutionize the electric toothbrush market. According to the textbook of periodontology, we are supposed to use electric toothbrushes as they have better plaque control. But that wasn't the case. And then we realized that if we make a product that can help people to stick to their toothbrushes, it could be better. Let's try to understand what was the need for a product like Brush Talk. We did a survey, and the results of our survey were as follows. People were not able to charge their toothbrushes inside the bathroom, and hence the hassle of taking it outside was always a trouble. We asked them if the use of manual handheld, what is the main barrier to transition from manual to electric toothbrushes, and most of them said the inconvenience of charging it over and over again. You too can be a part of the survey by scanning our QR code. The main need for Brush Talk is to bring about a transition from manual to electric toothbrushes. This will help to reduce the plaque, which in turn will help reduce calculus and periodontal diseases. It will protect the toothbrush from growth of microorganisms. There is no need for changing as it is compatible with the pre-existing electric toothbrushes. It is cost efficient and does not require to be charged multiple times. Let's have a look at few of the unique features of Brush Talk. Brush Talk has a metallic back and it can be stuck to any magnetic surfaces, wall mounts, and thus it is hassle-free in storage. It has a built-in UV lights cleanser which helps to disinfect the toothbrush and prevent the growth of microorganisms. The design is compatible with the already existing electric toothbrushes in the Indian market, hence you do not need to change your electric toothbrushes. The product has a magnetic back with which connects to metallic surfaces, tapes, or wall mount, thus providing hassle-free storage, and it can be used in travel as well. It prevents cross-contamination and helps eliminate communicable diseases due to its ability of UV light sterilization. It does not require the use of electric charging, and it can be operated on batteries. Moreover, the battery that Brush Talk has a life of 6 months, so you do not need to charge your brushes for 6 months. Through Denson Care, we are not only introducing groundbreaking products, but also advocating for a shift in how oral healthcare is perceived and approached. By positioning dentists as the primary resource for oral health, Denson Care aims to empower dental professionals to take a more active role in the prevention and management of oral health issues. Our products are more than just tools. They represent a paradigm shift in how dental care is delivered, focusing on prevention, education, and collaboration between dental professionals and patients. Thank you. And Denson Care wishes you a very happy Women's Day.
Lovely presentation, Dr. Shrishti. Thanks. And next time we will have you on the scheduled timing and slot.
Thank you.
Yeah. So just visit the website and have a look at it around February.
Right, ma'am.
Okay. Thanks a lot, dear. And you are well within your time. Thank you. Yeah, with that, we will go back to our present. Just log out of share screen mode, madam.
Yes, just a minute.
Yes. Thank you, Dr. Shrishti. Okay, and with that, I would like to present Dr. Shivangi's lecture, who could not attend the conference due to her personal reason. So this is Dr. Shivangi. She is a prosthodontist, and she would be talking about the dentures and the applications of it. So just have a look at the lecture, what she'll be presenting. This is a recorded version.
Good evening, everyone. I'm Dr. Shivangi Gajwani Jain, and welcome to Ipdcon. Before I start with the topic, I would like to tell something a little bit about myself. So I've been awarded ICD Merit Award by the International College of Dentists and for prosthodontics. And I currently have a clinical practice by the name iDent in Mumbai. I'm also a part of Academy of Dental Expertise, where I actively conduct lectures, demonstration, and hands-on workshops with special attention to removable prosthodontics. I am a core member with Tomorrow Tooth International, which is an international body and has some of the most amazing clinicians I have ever met. And the most important thing is that I'm part of a charitable trust since last 15 years, wherein we try our level best to provide treatment to the elderly and underprivileged patients, and not just any treatment, but quality treatment. Having said that, I have a special, love for writing, and that is why I have published like 2 books. One book I have published is on complete.
Yeah, I believe there was some technical error. Can anybody hear me?
Yes, ma'am, you're audible.
Was the video live?
No, video not live.
Okay, Dr. Nooral, we will present it tomorrow. Maybe we will find a way of doing it. So with that note, I would like to.
Dr. Sonal, just share the video. We can email to everybody.
Yeah, we will mail it across also, but tomorrow also we can make it live if it is possible, because I think there is some setting error and the screen got froze on that part itself. So I'll share with you, Dr. Nooral, the lecture, and then we can just share. We will just see what we can do the best. Okay. Yeah.
Okay.
Am I visible now, or is still the screen
Yes,
is
visible.
You are visible.
Okay. So with that note, I would like to say my vote of thanks for the day, because many speakers, I don't know if they will be logging in tomorrow or no. Thank you so much, all the dear speakers who were part of International Pink Dental Congress 2025 today. And thank you for all the cooperation and all the waiting period. I know everybody had a tight schedule. Everybody wanted to talk a lot and share a lot. But this being an online forum, we have technical glitches and we have some delays always. So thank you for accommodating us and being a part of this Congress. Thank you, dear speakers. The lectures were so enlightening, and you will be surprised by the way I'm getting comments commenting that it is a very well organized theme for the lecture. So it is not possible without you all. And you all have been the backbone of all this forum. So thank you so much, and thank you, Dr. Nooral, for this undivided attention and undivided support. And without you, I always say you are the one-man army behind this whole theme. Tomorrow, we are going to have another set of 18 speakers, and it's going to be a marathon day. We will be starting by 9:15 tomorrow, and I hope to see you all tomorrow again with the same enthusiasm and same zeal. This is Dr. Sonal Yerpure signing off, and with the team of National Health Academy and MedSkills for the day. But tomorrow, we will be back again. Thank you so much.
Thanks, Dr. Sonal. I just,
Yeah. Yeah, 1 minute.
I think we should have say 15-20 minutes of your presentation where you tell everybody that how you remain so fresh. You are sitting from 8:30 in the morning, and now it is 7 o'clock, and as if you looks as if you are sitting just 5 minutes back. So fresh, so energetic, smiley face, everything. It's a great, amazing.
No, I'll tell you what the theme I always have at my heart is that I want to learn. So the best way for learning something is organizing a conference like this or attending the conference. So for me, I'm learning at every phase, even if they are the students. I'm awed by the way they are presenting at this early age, or the private seasoned clinicians. I am surprised as to what I don't know. So that is the enthusiasm that maybe that is taking care of me and making me go ahead with this journey. And yes, I always say I have a very, very, very strong support system at home also, who see to it that I am having water, food,
Yes,
coffee, and everything is set for me.
Keeping
So
yourself cool always, actually means people get irritated. No, so many speakers coordinating them, and sometimes the technical glitches
just
are there.
just take care of a teenager. You will understand that managing students or managing speakers is nothing. Just take care of a teenager for once. You will realize this life is much better.
Yes,
So no worries. And I take it humbly. I will take all the criticism and the comments and the wishes and all the accolades, because for me this is all a learning curve. For a person who was to retire at the age of 40, at 45, I'm doing all this. So for me, this is a learning curve. Life never ends, and it will always show you a different side of yourself. It will surprise you at the best. So thank you so much. And I would urge all the speakers who want to do a trial run to wait back, and we will have a trial run also for them. So I think there are 2 or 3 of them who want to check their slides. So
And
Dr.
Dr.
Nuka,
Sonal,
thank you so much.
will sign off and we'll
Yes,
join
yes, yes,
again, so
yes,
that
we'll do
because
that.
the program
We'll
is
do
the
that.
unofficial, no? So we'll just
Yes, we'll
signing
do
off
that.
and we'll join again. Thank
Okay.
you.
Thank
Thanks.
you so much. Thank you